Morning, Dan.
Good morning. How are you?
Good. Today, no problem, no password.
More straightforward to join.
We're good.
Thank
So
you, Ray,
I'll
for sorting that out.
introduce you. Then you introduce Deborah Christie. Good. Today, no problem. Perfect. I'm having staff meeting, so I'll turn off my camera, but I'll be back in 15 minutes.
Okay.
Okay, perfect.
Good morning, Dr. Wood. No problem getting in?
Not at all. Thank you, Ray. I don't know what magic you worked, but it worked.
Found a way to let everybody in now, so.
Well done. Yesterday morning was a little traumatic.
Yeah, just for a few minutes.
Yeah, we got there.
It gets the blood going, though, you know? I mean,
It certainly does. That's true enough. So where
I
are you?
contacted everyone presenting today and asked them to come in a little early. I gave them their links again. I promised them their links would not have any problem getting them into this room, so we should be good to go on that end. So we had a really good session yesterday, I think.
I think so. I was very pleased with it.
Very well attended, so I'm happy about that.
So did you say we had 832 or something like that? Was that the number?
832, yes, yep.
That's
That's according to Zoom's statistics. So
okay. Because I was watching at the bottom of the screen the number of participants, and it was sort of flicking in the high 180s, 190s towards the end of the day.
Yeah, we got over 200 a couple of times.
Yeah,
that just, you know, people all there at the same time, but that number changes as people come and go. So people are coming and going all day long. So
okay. Let's put this up so I can see it. Okay, let's put my talk up.
did you bicycle in again today?
I did. It's a beautiful morning.
You find it safe? Around where I live, you take your life in your hands anymore on the roads.
Where do you live?
Just outside Washington, a little town outside, about maybe 30 minutes.
Yeah, I mean, Denver is kind of awash with bike trails and whatever, but you know, I can come up the back roads really safely, so it works well.
That's good. We don't have that here, so we're just open targets if you
Yeah, okay. Yeah, as I remember, the roads around Washington when I've been there are pretty hectic.
Yeah. In fact, we just lost Doug Canning. You know Doug Canning?
I know Doug very well. Yeah,
he was in a bicycle accident over the end of May.
Yeah, I know. That was dreadful news.
Very shocking news. Yep.
Yeah. Such a good guy.
Good guy, and helped us in the very early days of the Hendon Project, and has been a good contributor ever since for the urology sessions that we run. We're 12 minutes out now, so what I'm going to do is get out of the practice session that we're in now and open up the webinar to people waiting to come in.
Okay, great. Thank you.
Here they come.
Okay, great.
my video. Start video.
Morning, DC. How are you?
Hello, darling. How are you?
I'm very well, thank you. Great to see you.
You too. I've been yelling at the screen, but I wasn't a panelist, so nobody could hear me. I think that's called screaming into the void.
It's something like that.
Oh, so you're enjoying Denver?
Yeah, very much so. Thank you.
Oh, good. It's a lovely place, isn't it?
Amazing. Yeah,
Really
good.
amazing. I went skiing there. I had a conference there, and we went out early and went skiing, and then came back and it was a great conference. But it's a really nice city.
Yeah, there are lovely places to ski. It's great.
Absolutely. Just checking I've got all my audio right. Can you hear me okay?
Yeah, we can hear you very well.
Now what I've just swapped to my Prof Debs. Is that better or worse?
Much the same, I think.
About the same.
Okay.
Did you want to
Is that the same?
Did you want to test your screen sharing?
Oh, I could do. Is that Ray? Hello, Ray.
Hello, how are you doing?
I'm very well, thank you. The ever patient Ray. 5,000 emails. What the fuck am I doing? Okay, here we go. Right. Hey, I'm officially retired from the NHS, but then I unretired myself.
It's like status quo.
Well, no, basically what happened was I had a slush fund. I had a academic slush fund. And there was enough money in there to pay me for 1 day a week. So I said, I'd like to come back as a research consultant 1 day a week and pay myself out my slush fund. And they bit my hand off. Said, yeah. Right, now, hang on a minute, Ray. I am paying attention. Honest. Wait a minute. Here we are. Oh, okay, so what do you want me to do? Do you want me to do share screen?
Yeah, try that and see how it works.
Okay. Yeah, I can do that. There we go. How's that?
And then
That looks great.
You want to do the display version of the presentation?
Yeah. Like that?
Here we go.
Yeah,
perfect.
That's perfect.
Yeah. Perfect.
How's that?
Great.
So let me just, yeah.
Great.
Okay, so everything's working.
Looks fantastic.
Yep. Very good.
Oh, I've given away the.
Uh-oh.
Yeah, punchline.
Now, what shall I do? Shall I stop sharing? Shall I? Because I'm giving away all my secrets. There we are.
Yeah.
What's going to happen, Deborah, is that I'm first up, if that's okay with you. But if you want to change the order and you want to go first, so you can get on and do other things, I'm very happy to do that.
Ooh, that would be good. What about all the people? What about all the people though that weren't going to come to your talk because they only wanted to hear me, and then they'd be really disappointed when they turned up and they got you instead of me? I mean, how would we manage that?
Well, we'll support them and nurture them through it.
Right, are you going to record the talk?
Yeah, these are all recorded, and each presentation
they're recorded.
Posted individually. Yep.
Okay, all right. Well, that's fine. Hi, Andrea.
Andrea, we were just talking.
Hi, nice to meet you, Deborah.
Nice to meet you too. I hope you're looking after Dan.
I am. We're enjoying him very much. We don't plan to send him back.
No, UCLH don't deserve him.
Yes.
Well, that's another discussion. That's a glass of wine discussion.
Definitely.
Andrea, we're just going to so that Prof. Christie can get
presentations.
Okay. So I'll introduce you.
You introduce Deborah, and then I'll introduce you afterwards. Then.
That's fine for me.
Welcome for today's meeting.
Is that okay?
Perfect. So I'm going to turn off my camera, and I come back once Deborah is done.
Okay.
What time are we starting?
In about 2 minutes.
2 minutes.
Oh, blimey. I better get myself set up then. Hang on. Right, okay, we'll play from start. I hate the way when it goes play from start, it goes to the full screen. Okay, I'm all ready to do that, and I will, but I need to share my screen. Do you want me to share my screen? No, I won't. Will I share my screen now or wait?
I would just hold on a second until we're sort of ready to go, if that's okay.
I will do that.
So what are you doing with all your extra time?
Oh my God, I'm so busy. I'm working as a clinical director for a online therapies platform. I am working as a consultant to another NHS trust, developing a new pediatric psychology service for them. I'm also working for Abbott Pharmaceuticals as a wellness ambassador and writing blogs and doing stuff about stigma, a project on stigma with them. And I'm qualified as a transformational lifestyle coach as well. So I'm doing coaching, yes. And then I'm doing 1 day a week research in the NHS as well. So yeah, it's great. And then I kind of like work it out so that I have Friday, Saturday, Sunday, Monday is for traveling and fun and doing stuff. And then works kind of like Tuesday, Wednesday, Thursday. So it's great. I'm really enjoying it.
Yeah.
And lots of traveling again. Woo woo.
Yeah. Isn't that great?
Oh my God. Yeah. I have to tell you, I've been saying to people, I'm flying to Colorado this afternoon and flying back straight away. And in the old days, we actually would have flown to Colorado.
Yeah, it's true.
This sucks. This is no way as much fun as flying to Colorado, having dinner with you, which we would have done, drunk far too much wine. I know, I'm just going to make myself smart and professional. Excuse me.
All right.
There we are. Do I look lovely?
You do.
Perfect.
Very glamorous. So we'll, for those of you just logging onto Zoom to join us for today, thank you very much. I'm just going to give everyone a couple more minutes just to get everyone settled and in, so that they can make their coffee and settle in and enjoy what looks to be a fantastic day ahead. So we'll give you a minute or so more.
Is everybody putting in where they come from? I'm going to put from this.
Yeah, we had some really nice chat messages yesterday from all over the world. It's fantastic. I see we've got Dr. Ghanem on from Yemen, and we've got a Dr. Mistry from Italy, and then we've got yourself from the UK. Fantastic.
Yeah, well, that's 3 of us anyway.
Argentina, we've got Venezuela, Germany, Algeria. How exciting. Great to see everybody.
And Colombia and Australia.
Yeah. Australia.
Woo.
Now, Australia is a very noble effort because I think it's about, well, I'm not sure what time of day it is there, but it's
about 11 o'clock in the evening.
Yes. Oh, there you are, 11:01 p.m. Thank you, thank you.
Wine time. I hope Emma hasn't started drinking yet then. Oh, the Philippines.
There we are. Amazing. Oh, Finland we've got. Chile. Yeah.
This is like the Eurovision Song Contest.
Only more international.
And without the singing.
Well,
but more professional.
Absolutely, of course.
Okay. Right. Welcome, everybody. I'm delighted for those of you that were here yesterday and have chosen to join us again. Welcome back. We had, I thought, a really excellent day yesterday. I certainly learned a lot and really enjoyed the conversations we had. To those of you that are joining for the first time today, thank you very much for joining us. We're very, very pleased to see you and hope we'll have just as exciting a day today. Yesterday, we had over 800 participants throughout the day from all across the world. And you can see on the chat now that we have a truly international audience. So we're going to, without further ado, get the day underway. We've actually chosen to swap the first 2 talks. If you are hoping to log on and see me talk first, Dr. Christie is going to precede me, or Professor Christie, sorry, is going to precede me. But if anybody feels that they're worried somebody's going to miss something, the whole thing is recorded so you can watch it back should you wish to. It's my honor and privilege to welcome Deborah Christie to our meeting today. Prof. Christie and I did a lot of work when I first started at UCH looking after some of these patients. And I can honestly tell you that some of my most fascinating consultations were working jointly with Deborah and the team to understand the psychology behind some of what was going on. Deborah's going to talk to us about the adolescent brain and the importance of understanding that in their development, and that plays into how we manage our patients. Deborah, thank you so much for giving up your time and joining us today. I'm really looking forward to hearing your talk. Thank you.
Thank you, Dan, and hello to everybody. Oh, Thailand, this is very exciting. India, Uganda, fantastic audience. Really, really great. It's lovely to be here. It's lovely to be here, which is in the UK, sitting in my loft with a beautiful sunny day. And I'm really looking forward to presenting. So I need to click that, and then I click that. Okay, so I was asked to talk about state-of-the-art, the adolescent brain and transition. And transition's an interesting thing when you're working with young people. There's this sort of movement from one small fishbowl into another small fishbowl, and then kids end up in the adult fishbowl where they're small fishes in a big bowl. And it can be really confusing and challenging, not just for the young people, but for their parents and families. So I wanted to start off just by talking a little bit about, in the 1950s, there were only kind of like three main transitions. There was puberty, there was marriage, and there was childbirth. And you can see roughly marriage was around about 18 and childbirth was around 22. And now, today, everything's shifted. But not only has everything shifted with puberty occurring earlier, childbirth a lot later, and marriage even later, there are other important transitions, things like school and university, child and adolescent mental health services to adult mental health services, which range from 16 to 18. And then the movement from pediatric care into adult care, which used to be a lot later and has moved around as well. So these arrows move around. Now, I know that some of you may be pediatricians and some of you may not be pediatricians. So just in case there are any adult physicians just out there, this was just to help you understand what happens at puberty. So there we are. And of course, I can't hear you all laughing, but I know you all are. Let's think a little bit about what the job description of an adolescent is. So the first bit of the job description is biological changes. The important biological changes include changes in body shape, in appearance, and in function, what the young people are doing with their life, how they look. And those changes are dramatic, really, really dramatic. There are psychological changes as well. And the psychological changes are around personal identity, sexual and gender identity, and thinking patterns. And socially, there are changes in how young people relate to their families, how they relate to their peers, and how they relate to the outside world. And all of these changes fit into what we expect or what we assume an adolescent is going to be like and how we're going to have to interact with them. One of the most important things to be aware of is that post-puberty, there's quite a significant impact on behavior, which is probably driven by biology. So all of these things here significantly increase post-puberty. So significant increases in self-harm, young people presenting to accident emergency or emergency departments, much more likely to be teenagers. There's a significant increase in aggression, particularly in boys. There are significant increases in the rates of depression, particularly in girls. Substance use becomes a problem post-puberty. Pain perception changes. So that really unusual group of young people who present in adolescence and young adulthood with significant chronic pain conditions, again, that doesn't happen. You don't see that level, that amount in younger children. We also see the onset of autoimmune conditions in adolescents and things like obesity and metabolic syndrome. And so I thought this was quite a nice quote, really explaining how there's this conflict between physical maturity, but psychological irresponsibility. Now, how does that play into transition? So I wanted to take a little bit of an online quiz here. And I can't see the chat, so you'll just have to be honest as to how many you get right or wrong. But as we're going through, see how well you can do. So here's the very first question. Transition should start at around 15 to 16 years of age. Is that true or false? Well, in the words of the great 45th President of the United States, it's false news. Because actually young people want transition to start around 11 to 13 years of age. And one of the problems with transition is that we keep asking young people what they want. They keep telling us and we keep ignoring them. But they say repeatedly and consistently that what they want is they want to transition, the idea of transition to be introduced early. They don't want it suddenly landed on them when they get to 15 and told, oh, next year you're off to the adult clinic. Okay. How about evidence? What evidence is there that there are a benefit to having young adult clinics? So rather than putting kids straight from pediatrics into adults, having this sort of adolescent clinic. And here we suggested 16 to 25, but actually some adolescent clinics could start even earlier. Well, actually, that one is true. And there's good evidence for physical outcomes if you compare things like renal allograft survivals with young people that were in a young adult clinic and young people who just went into a standard adult clinic, that the probability of transplant survival is significantly better. Now, this is true when you look at things like attendance at appointment for diabetes clinics. It's true when you look at survival rates for other kinds of transplants that happen in adolescents. But basically, if you have an adolescent clinic or an adolescent young adult clinic, you will improve your physical outcomes. Okay. So, opportunities for young people to see healthcare professionals independently of parents positively influences transition, improves outcomes. Also true. And the data shows that if you do that, you get an improvement in health-related quality of life. You get an improvement in transition readiness. Young people are much better at attending their hospital visits independently. And a very simple outcome measure, attendance at the very first adult clinic appointment is significantly increased if you have a independent training. You train your adolescents to be good adults. And that's really what transition should be about, training adolescents to be good adults. Now, in the UK, is current training fit for purpose? Well, this one is an actually it's false. It only happens in a few hospitals. There's very little training. It's getting better, but there's still very little. And it's one of the main barriers to the delivery of transitional or adolescent healthcare. I mean, and one study that asked adult gastroenterologists found that they said they didn't feel competent addressing the developmental aspects of adolescence. So we're not training our physicians well enough to understand what it's like to work with adolescents, even though all of these adolescent physicians were an adolescent. But it's a bit like childbirth. You kind of like forget all of the pain of adolescence once you become a grown-up. Okay, next question. Adult physicians should be involved in transition before transfer of the young person. Again, true. Young people like to meet their adult doctors. And in diabetes, for example, it's true. You get better adherence to appointments with arthritis, with cystic fibrosis, with heart transplant, and with congenital heart disease. What about psychosocial transition programs? Do they improve health outcomes? Well, this is an interesting one here because there's an enormous discrepancy. So half of the people who argue that it does are on one side, and half of the people who argue that it doesn't. And at the moment, actually, poor old Dr. Jenkins is a bit on his own, because most of the argument comes from anecdote and speculation. Transition coordinators, are they worth their money? Well, actually they are. It's worth having a transition coordinator because you get a much better survival rate and you might get much better adherence to medication. Health passports. I wonder how many of you out there use health passports. Do they help? Well, the evidence is really, really mixed with health passports. They work when they're used. The problem is that they tend not to be used as much as people think they're being used. So, for example, we were working with a young person a while back and has spent hours and hours producing this wonderful health passport. And just before he was going off to his first adult appointment, he'd been emailed it and everything was great. And we thought, this is wonderful. And then we spoke to him and we said, so what did you think of the health passport when you went for your adult appointment? He said, oh, I have no idea. He said, I never look at my emails, so I didn't pick it up. So health passports do work, but they only work if the kids are trained to use them in the adult appointments. So do the adult physicians actually ask for them? And is there any evidence on transition being fit for purpose? Well, actually, the evidence is pretty poor. It just focuses on a 2 to 3 year window around transfer. And there is continuing challenge that we don't really know what it is that is a long-term successful outcome for young people in the context of their daily life. So a lot of the studies are descriptive, they're not evaluative, and the research designs are pretty poor. Right, so we wanted to talk about the brain. So let's think about the brain. Do we understand the implications of the recent neurobiological evidence? So here's a brain scan. Actually, we really don't understand. We can surmise. The average teenage brain is a bit of an enigma. It's not like a baby's brain, but it's not yet an adult brain. Now, this slide, which is slightly more scientific than the previous one, shows how the grey matter volume changes over time with age. And you can see that it's got a sort of front to back, just like this. There's an extensive remodeling, and that remodeling is a sort of a wave from the back of the brain all the way to the front of the brain. So you can see in the 5-year-old brain, the dorsolateral prefrontal cortex, which is where the executive functions, and those are the grown-up bits. The executive functions are the bits that most grown-ups have. And I use the word most because I've met a few adults that don't have any. But when the brain is immature at 5 and preteen, there's very little executive function. And it's not really until well past the age of 20, and some would argue up until the age of 29, that the grey matter is fully developed. And you need the grey matter for your memory. You need it for making decisions. You need it for the frontal cortex, which is responsible for abstract thinking and identity formation. And as these changes occur, you get changes in sensitivity to reward circuits, to learning and social feedback. And when I show you the next slides, if you remember this, it will all start to make sense. So, 1,914-year-olds given functional MRI imaging, Whelan et al. Found that there are 7 networks that are linked with impulsivity in the adolescent brain. And I remember reading that and going, oh yeah, well, suddenly that makes complete sense. Because What do we think about adolescents? What are they? They are impulsive. They impulsively try things out. And there are associations of network activation with substance abuse. And we know that there's an increased risk of substance abuse with low orbitofrontal network activity. There's also much higher sensation seeking. So suddenly we have a substrate, an understanding of why teenagers are doing the things that they're doing. This is a quote and a portrait made by a teenager. And it's about exploratory behavior. And as a psychologist, I always used to like to talk about exploratory behavior rather than risk-taking, because adolescents aren't taking risks as far as they can see it. What they're doing is they're trying out the things that they see adults doing. We don't, you know, if we were all in Denver rather than our respective homes, and we were all going to dinner this evening, and we were all going to sit and have a few glasses of wine, we wouldn't describe that as having dinner and taking risks. But for teenagers, when they have something to drink, we say, oh, they're risk-taking. But actually, if we think about it as exploratory behavior, it fits with how the brain is working, and it helps us take a much more compassionate attitude and compassionate view towards what their behaviors are. So they're exploring things. What we know is that the gray pathways, the white pathways, the dopaminergic pathways, they change over time, and they increase vulnerability to risk-taking. So if you look here, this is the gray matter. As the gray matter increases from the age of 10 to 22, what you do is you get an increase in regulatory control, cognitive control, and the ability to integrate affect. Now, if you look at the dopaminergic pathway and the amount of dopaminergic activity happening in this time frame, you can see that there's this massive increase in dopamine, and then there's a reduction which goes down. And so what you have is you have this window, and that's your risk window. And look at where the risk window is. It's right over and at its greatest at here at the age of 15, 16. And that's when young people are exploring sex, when delinquency is at its worst, when violence and aggression is at its worst, when self-harm is at its worst, and when disease control is at its poorest. And not just disease control, but medical management. So when you tell a young person to take a medication, their brain says, I don't really think we need to, do we? No, you don't need to pay any attention to them. You can ignore them. They're just a doctor. What do they know? And so we get this attitude of, I can get away with it. I can totally get away with things when you're a teenager, because there's no inhibitory control, and there's no impulse, and there's high levels of impulsivity. So there's this inability to wait, this insensitivity to negative consequences. In fact, a bulletproof is a phrase I used to like to describe teenagers. You know, they're bulletproof. It won't happen to me, or there's nothing you can do to me that can make this worse. Incredibly distractible. And so if we look at the teenage brain, what we see, because this part of the brain, which is responsible for abstract thinking, hasn't fully developed, high levels of impulsivity. But this part of the brain here, which is our social brain, is really active in teenagers, which is why they're all wanting to go out there with their friends. And the idea of having a family day is complete anathema. Sensation seeking is at its greatest, and threat perception, again, is at its greatest. And all of these things influence the young person's identity. It influences their behaviors, and it influences their social relationships. And it's all about having that plasticity, the ability to change. And it is changing. It's changing over time. So it's not about giving this as an excuse. I had to apologize to somebody the other day for something that I'd done. I had completely mucked things up, and I had to send an apology. And I apologized, but what I said to them was, the reason I did this was because of X, Y, and Z. And I said, and that's, it's not a justification, it's an explanation. And so this, I'm not suggesting for a minute that we justify poor medical management, we justify the behaviors that young people do, but it helps us understand and explain and think about how can we mitigate risk. How can we, as physicians and psychologists and healthcare professionals, work with young people in order to mitigate the risks that are going to occur because of the way their brain is developing. I have to confess, I have 2 boys, and when I started working with adolescents, I found this and I stuck it on the wall as a reminder not to kill my children until they actually grew up. So just to kind of like talk you through the 3 sort of main stages in terms of thinking, the move from concrete thinking to established abstract thinking occurs from 11 to 13. And if you think about how do I deliver medical information, you have to be very concrete in the early stages. It can become more abstract as you get into that middle. And by the ages of 17 plus, you can be having conversations which are thinking about the abstract impact of poor medical care. And then there's this move from big picture thinking about things in the moment, to future oriented, to understanding if I do this, then this will happen. When you're little, and I'm talking about that very early cognitive level, you don't really understand the implications. You don't see the point. It doesn't matter. A young person with asthma, for example, they don't understand why they need to take their inhaler, because sometimes they don't take it, everything's fine. It's not until they get older that they can to understand that taking an inhaler is a prevention, it's a prophylactic rather than necessarily a treatment. And the preoccupation with our rapid physical growth at early adolescence then goes into establishing body image, being clear about what their body image is like. And the sexual thoughts that are connected with physical change move into fantasy and idealism, which fits with why TikTok and other platforms and programs like Love Island, I know a lot of places got Love Island, it's absolutely horrible because you watch these perfect, beautiful bodies walking around, and that's the image of perfection. And they're in the minority. We don't look like that. None of us look like that. Well, except we're in our fantasy stage. But that's when we're idealizing. Well, I want to look like that. And there's, a lot of suggestion, and I think good evidence emerging that this process of idealizing images and using filters on your Instagram and filters on your TikTok to make you look more beautiful and look better are things that really drive poor mental health. And it's not until late adolescence that cognitively young people have their intellectual identity established and they're functional. Who do they want to be? There's a very nice example here about the influence of peers, which I just wanted to put in. So this was a study where they got young people into a video game, and they played on their own, and they counted how many crashes they had, and then they played with some friends sitting with them, and then they compared that to adults. So who do you think had the fewest crashes? And of course, you would be shouting out to me, oh, the adults. Actually, adolescents, young adults, and adults on their own have about the same. In fact, young adults probably have a few, tiny bit more, but hardly any. So there's no difference. Isn't that surprising? But look what happens when you put them in with friends. If you put adolescents into a dangerous situation with friends, the influence of peers results in significantly more risk-taking. And yet we allow kids to drive in some places at the age of 15 or 16. And I think some countries have introduced the no passenger rule to try and reduce this effect. This was the wonderful Larry Steinberg, sadly no longer with us, who did this study. And I think for me, it's been the most helpful study when I'm thinking about the influence of adolescents and their peers. So of course we have to live with technology as well. And that means we have to be a bit more up to date with it, but we have to be able to think with young people and their parents about digital hygiene, about digital etiquette and digital safety. And it's no longer good enough just to say, don't go on it. It's important to talk with young people about how do they go on it. And remember the impact that being on a screen has on your brain. So things like the blue light, being on it too late at night, and stimulation impacting on sleep as well. And also watching, and it can have a very positive, powerful good. So one of the things that I've been doing is podcasts, but I haven't been doing the podcasts as myself. Well, I haven't been doing them as myself, but with a young person who's interviewed me, and then he's put that interview on his TikTok so that young people will listen to it because it's him. And we've talked about how to keep yourself safe with diabetes. So it's accessing it. And as I said earlier, young people don't use their emails. They hardly ever open their emails. They use WhatsApp, they use Snapchat, they use TikTok. If we want to get messages across, we have to be down with the kids, to use a really non-down with the kids expression, but we have to be able to communicate with them at their level. And hospitals saying, oh, we don't like the governance idea of WhatsApp, is not good enough, because your NHS, your .net or your hospital email may be encrypted, but what's the point of sending an encrypted email with advice or support to somebody who's never going to look at it? So I guess I wanted to remind you all that we're always in two minds, us and them. On the one hand, we're polite, listen to the rules, listen to orders. Teenagers can be an absolute joy. But on the other side, that poor old brain is driving them to change. And successful transition is possible. We need to plan for it. We need to make sure people have the knowledge and skills they need. We need to make sure that people have an understanding and meaning and the expectations, and we need to look at the environment we deliver our information in. And on that, I would just like to say, thank you very much for listening. I'm on Twitter on Dr. Debs 2110. Please feel free to follow me. And I'm very happy, if there's time, to take some questions.
That was an incredible talk. Thank you so much. And just like it illustrates so beautifully some of the patients that we quite readily come across in a clinic, and we think we're giving them a very rational explanation for why they should do something, and you're greeted with a brick wall or a shrug of the shoulders and just an apparent lack of engagement or comprehension, but it's all sort of going on inside and developing. So there are a couple of, there's one question here that I'm just going to read out. An excellent, very thought-provoking talk. With the data on brain maturity in recent court cases about early treatment of gender dysphoria, is it more appropriate that we have a transition program till 21 and more rigorous verification about abstract thinking, I guess, in terms of decision-making around interventions for patients looking at transgender treatment?
Yeah, I mean, that's a very topical question, isn't it, at the moment, with some of the political decisions that are being made with no thought to the clinical data. And in some states, there are political decisions being made where data is being misquoted to support a political agenda. I think you've got to take the politics out of this. You have to look at the science. The data and brain maturity. I have a memory that the data and brain maturity actually chased my teenagers' brains Every time I went to a talk on brain maturity, I would come away thinking, oh, phew, it stops at 16 because my kids were 16. And then I would go to a talk at 20 when they were both 20, and somebody would say, no, it's not, they're not mature until they're 20. And I would say, oh, okay, well, that explains the last 4 years then. And I've heard, some papers say, 29 actually is when the frontal cortex fully develops. I think with gender, you need good gender. What I would say is you need good gender affirming care. You need clinicians, multidisciplinary clinicians that can affirm people's beliefs at the time, that can take time to talk with young people and help them understand what it is that they're going through. It is the most difficult choice for a clinician when you've got a young person in front of you who is seriously distressed and suicidal, and the suicide rate in young people with gender dysphoria is horribly high. To then be told, no, you can't have puberty suppressants, or you can't have this and you can't have that. I don't think there's any right answers, but I do think extending it and expanding it and ensuring that we don't take a position where we act as if we know what's right, but we present things in a way that says to young people, do you know what, right now, this might be the right decision for you. There are quite a lot of people who change their minds. You might not be one of them, but what we'll do is we'll support you until you're really old enough to make a life-changing decision. And that might mean, I think, providing puberty blockers to people who have been properly assessed by a good, well-trained, gender-affirming care team. And I just think it's a shame that this argument is being politically polarized.
I couldn't agree more, and I think that that there's a lot of areas that, some of which we touched upon yesterday, that illustrate exactly that. It's an extremely fragile environment for our patients and indeed to work in. Thank you so much for your wonderful presentation and your time. So good.
Oh, that's an absolute pleasure. Nice to see you, and thank you everybody for listening. And I hope you're all laughing in the right places and enjoyed it. That's why I hate Zoom, because you can't hear people laughing. Anyway, have a lovely day. Enjoy the rest of your day, and I will go off and do something.
Thank you. Bye.
Thank you very much. Well, it's my pleasure now to introduce Dr. Dan Wood. He doesn't need much introduction. It has been a pleasure to organize this meeting with him, and we have been very lucky to have recruited him and now having him lead the transition of care program here from Children's to the university. So welcome, Dr. Wood. I think we're seeing the presentation mode, so you probably want to switch to perfect. Now it's great. Thank you.
Okay, thank you very much. So this is really almost a technical overview around urinary diversion. There'll be a number of other talks that delve into particular aspects of this over the course of today, but this is really an overview. So when we think about reconstructive urology, our perspective is that what we're trying to do is to help a patient have a functional urinary tract. And there are various reasons why they may not have a functional urinary tract, but in essence, we're trying to create a vessel for storage, allow them to be able to empty that vessel. For many patients, it's important to be continent or dry, but also in the background, we're thinking about making sure the kidneys are safe. And for many of our patients, there's this conflict between what they might need and how that might impact on their normality. And obviously cosmesis plays into that as well. So it's a big decision to divert someone's urinary stream. There are all sorts of reasons why we do it, but you do have to think very carefully about what you're doing, what you can preserve, and what your alternatives might be. So the reasons why we do it will be if there's an absent bladder or a bladder has had to be removed, if the bladder isn't big enough to do what we need it, if the wiring, the nerve supply to the bladder isn't working effectively and that's affecting function. There are other things that occur spontaneously through life, things like detrusor overactivity that can cause incontinence, significant congenital anomalies. And also, if you can't empty your bladder through a urethra that's been damaged by any means, then thinking about how we manage the bladder and occasionally urine diversion becomes important. It's big for a patient to think about this, and we need to think about and ask about what a patient is hoping for. We need to think about what they're able to do. So are they able to hold a catheter sufficiently to be able to catheterize themselves? In some situations, it's really important to take a careful look at a patient's comprehension of what they may be letting themselves in for. That's not true for many, but it is true for some, and being aware of that is really important. Surgically, we're thinking about what substrates we have to be able to use, what bowel segments are available, and we're wary about reasons why we might not be able to go ahead. So some of those reasons might be that there's inflammatory bowel disease, such as Crohn's disease. If the bowel is very short, and we're likely to affect somebody's nutritional status. If the bowel's been damaged by something like radiotherapy, that becomes important in terms of what segment we may be able to use and the safety of a reconstruction overall. And if a patient doesn't seem to be somebody who's going to engage in the ongoing management of that reservoir, then that's an important consideration. So will they catheterize or not? Really important discussions to have. When we come to take these cases on surgically, we always have a plan A, something that we want to achieve. But usually I will talk to patients about that we hope to do this, but we may have to do that instead. Because once you get inside an abdomen, you're trying to perform these reconstructions, there are often things that will limit us or lead to the need to change our plan slightly. We mentioned yesterday tissue engineering, I think that we may see an age where tissue engineering becomes something more prevalent. There's a lot of work going on, but we're not there yet, and we haven't reached a stage where it's viable or useful to us in the clinical sphere as yet. You have to have a team around you. You can't do this work alone. So I work with incredibly talented specialist nurses, both here and in the UK. I've worked alongside wonderful nephrology colleagues and radiology colleagues who've helped us with these very complex cases. And there are clearly other members of the team that we work alongside with, our colorectal surgeons, when the bowel is going to be an issue and so on. But it's really important to share that work amongst your team. So what are we trying to achieve? This kind of goes back to those first principles. We talked about having a reservoir that's low pressure. We talked about having a means of being able to empty that reservoir, and that can either be down through the urethra with natural or spontaneous voiding, sometimes strain voiding or catheterization, and then a means of keeping us dry. So the natural sphincters that are there. Sometimes we can create valves, and sometimes we use artificial sphincters to help us create that. And these are some of the options, some of the things that we can use in our reconstructions or our diversions. So we can use almost any segment of the bowel, apart from there are some limitations to that. We don't use stomach really very much, but there are lots of other substrates that we can use. Small bowel is most commonly used. We use colon, and rectum can be used as well. These are some ideas as to how we can empty our urine into the outside world. And then these are some of the principles, surgical principles that we use in terms of creating continence. So the types of options that we have in diversion are an ileal conduit, and you'll see that that's still the most popular and prevalent in a number of settings. We can make a totally new bladder. We can replace the bladder with bowel and create a continent channel. We can use the native bladder and create a means of draining that just using a metrophenol. And occasionally we divert the urine through an anal diversion, a so-called ureterosigmoidostomy. This is just a picture of an ileal conduit. You can see a segment of small bowel has been taken on its mesentery. The ureters are brought together and they're joined to the base of that conduit, which is then brought out as a spout on the skin. How you anastomose the ureters? Well, the previous slide shows the two ureters coming together in what's called a Wallace technique, or you can attach them independently, so a so-called Bricker technique. Either is okay. There is some discussion about certain circumstances where one may be more applicable than another, but that's sort of a further conversation beyond this talk today. The stoma, we invert the mucosa of the ileum to bring that out above the skin so that the urine is really kept away from the skin and drains directly into a bag. Otherwise, that can cause quite marked excoriation. I'm sorry, some of the formatting on this slide has slipped. So the kind of long-term complications are any bits of bowel that we use in the urinary tract inherently become longer and more circuitous with time. And so you can end up with redundant loops which hold urine and therefore predispose to urinary tract infections. Incisional hernia are a big problem in this type of surgery, particularly when patients have them for the long term. We heard yesterday about the importance of keeping an eye for stones, obstruction of the joint between the ureter and the bowel. Metabolic consequences are less prevalent in an ileal conduit because there's less dwell time, but UTIs or urine infections are a really important consequence. These are some of the things that we can see. The stoma basically having disappeared at skin level, a fistula with the spout, excoriation around the stoma, and then a stoma that's become ischemic and necrotic. So if we move on from an ileal conduit and we think about how we might want to reconstruct or build a whole new bladder, then one of the big proponents of that was Urs Studer, or is Urs Studer, and he created a neobladder in his own name, taking about 60 centimeters of small bowel, again making the anastomosis behind that, reconfiguring that so that you create this pouch, and the chimney is an anti-reflux mechanism, if you like, to stop urine being forced back up the ureters, and the ureters are then attached. And again, you can attach them independently, or you can join them as I showed you earlier. This can be a neobladder that is drained through a Mitrofanov, or in this situation, it's joined to the urethra and drains dependently through that, usually by catheterization. There are all sorts of different examples of neobladders, and this is just a diagram to illustrate that. Why do we bother to detubularize and fold it over? Well, the main reason is so that we get greater volume. That allows us to store more urine for using less bowel, and obviously that becomes then a more efficient system in terms of the way that we want it to work. We can expand a bladder and use the native bladder with a segment of bowel that's sewn into it, a so-called ileocystoplasty or augmentation of the bladder. And again, this is just a photograph showing the urethra and the stay sutures that we're going to funnel the bladder down into the pelvis. There's lots of discussion, or there have been lots of discussions about how you should implant ureters into a urinary diversion or into a conduit or a neobladder. Some argue that you have to tunnel the ureter to try and stop the reflux. Others will just drop on a ureter. And it depends a little bit about whether that's an open system, i.e. with a urethra that's going to drain, or whether it's a closed system without a urethra and therefore reliant on catheterization. So there are lots of subtleties to that debate, but it's an important consideration when you come to plan your surgery. We need to educate our patients. So once you have bowel in your urinary tract, there's a 70 to 80% chance that you will have bacteria in your urine all of the time, whether you're well or not. And so if you're well and you don't have symptoms, then that bacteria is insignificant. It's not clinically significant. So teaching patients about that so that they can educate other providers and they're not being treated for urinary tract infections when in fact it's just asymptomatic bacteria. Septic episodes are important, so teaching them to be mindful of symptoms, what they notice when they have a urine infection is really important. And managing them well in terms of making sure they keep their bladder empty regularly is really important, because the bacteria can translocate and that can cause other problems with sepsis. And we talked yesterday about the importance of understanding that bowel in the urinary tract gives you a significant risk of having a false pregnancy test or a false urine pregnancy test. So you need a serum assay. Stones are important in patients who've had bowel in their urinary tract, so they need monitoring for, so an ultrasound once a year is good. In terms of how they can prevent stones, the most significant risk factor seems to be have a balanced diet with lots of fruit and vegetables in it, but also making sure they drink plenty. This study showed us that those patients that developed stones tended to have a poor fluid intake and less urinary citrate. We know that this comes with metabolic consequences, so measuring that and monitoring that throughout a patient's life is really important. And we know that there have been some fantastic innovations. Paul Mitrofanoff, again, was mentioned briefly yesterday, but in 1980, he first described the use of an appendix into the bladder to create a catheterizable channel that comes up to the anterior abdominal wall, allowing a patient continence, but a means by which they can drain their bladder. It was a very clever concept that's used widely. This is one of my patients from London, in fact. This gentleman was in his early 20s and had used a significant amount of ketamine in his life, which destroyed his bladder. And so we ended up removing his bladder, which is the option of last resort, but he chose to have a Mitrofanoff that came up to his umbilicus so that he could drain his bladder. So we use, if it's available, we use the appendix, we take that on its mesentery, and we can plumb that into either our neobladder or a native bladder with a tunnel that creates a flap valve and keeps that continent. We can reconstruct or make a neo-appendix using pieces of small bowel, a so-called Monty-type Mitrofanoff, and there are various iterations of that. This is obviously a surgical picture of that, and you can see two short segments of small bowel that have been detubed, that have been opened out and then reconfigured to create a long, thin tube. Mostly we use the appendix, but you can use small bowel to reconfigure it. It's certainly described in the ureter. Other things have been used or described in the literature. In our experience, I haven't seen any of those that have worked successfully. It's really the top two that we're confined to. We tunnel it into the bladder. So this is an open bladder with a tunnel going under the mucosa that we can then pass the Mitrofanoff through and down to create that continence mechanism. We bring it out to the skin, and there are various ways of configuring the skin and bringing the tube up to the skin. There's not a huge amount of evidence to show us that one way is more right than another, but there are good examples of how we can do that. Bladder neck closure is something that urologists don't like doing, but it is an option of last resort if there is complete failed continence. And so transecting the bladder neck and closing it has about a 10% failure rate. There was a question on the chat yesterday about it, and I think that making sure you have careful dissection, good separation, and putting healthy tissue in between increases your success rate to the maximum you can achieve. This is my prettiest Mitrofanoff on a young lady who adorned it with umbilical jewelry and had various tattoos around it. So thinking about gut segments is really important in terms of how we manage the choices and the decisions we make in these types of surgery. In terms of long-term consequences, explaining to patients that they're going to need to remain engaged in long-term follow-up. And I think that it's important just to pause for a second. There is some enthusiasm from surgeons for just being able to perform a reconstructive urological procedure. And I'm talking, I suppose, largely about robotic surgeons who want to take this work and do it all robotically. And I don't have a problem with using that technology to reconstruct a urinary tract, but this isn't simply a technical exercise. These are patients with whom you create a contract. You offer them a big operation. They need long-term follow-up to monitor for these consequences. I mentioned earlier ureterosigmoidostomy, which is the pouch that is created between the sigma rectum. You can see folded over on itself with the ureters tunneled in. The front of that pouch is then closed. So this then acts as a reservoir that stores urine, and then you get dual effluent of urine and feces coming out together. And this is, it's not used so widely as it has been in the past, but it is a useful technique to have in your armamentarium when occasionally it's needed. You can't do it if the ureters are dilated or if there's been pelvic irradiation, and it's not good to do if patients are suffering with a degree of renal failure and obviously colorectal disease. The reason for not doing it if there's hepatic dysfunction is there's often a high ammonia load because of the dual stream and the urease splitting urease containing bacteria that create ammonium. So it's important to understand the physiology of what you're doing too. In terms of how you assess them, they're carefully assessed for continence. So a slurry mix is inserted anally, and if they can hold on to that for between 30 minutes and an hour, then they're probably going to be continent. There are other exercises such as manometry or electromyography. I don't have experience of those, but they're quoted in the literature. And it's probably wise, certainly in older patients, to have a colonoscopy beforehand. It's good because it's spontaneous. They don't need catheters or bags. The continence is high, but don't forget they are carefully pre-assessed to ensure that that's going to be the case. So there is a selection in there. One of the concerns around it is that they tend to get, or there is a risk of about 20% or so of getting cancers at the ureteric junction with the bowel. It's always at that junction. And so they do need, after 10 years, careful surveillance with an annual flexible sigmoidoscopy. Malignant risk in bladders overall is an important thing for us to understand and be aware of. We know that certain groups are at more risk. So if you're immunosuppressed, if you've had a diagnosis of extrophy in the past, and if you're a smoker, the risk is slightly increased, probably in all forms of urinary reconstruction, but it's not something that's worthy of screening. We found that screening programs didn't work, that patients who developed symptoms, they developed them during screening intervals. So it's important to teach your patients that if they get new symptoms like hematuria, urinary tract infections, or strange pain, that they contact their team and that's investigated on that basis. It's still true that ileal conduits are probably the most prevalent form of urinary diversion across all urological practice, and by that I include oncological practice. But I think there's much more of a move to other forms of reconstruction as time goes on. So I think being mindful of that and developing that as part of your practice is really important. So when you come to thinking about urinary diversion, certainly think about your options and what's available, both in terms of what a patient would like, what options are likely to be surgically possible, and how that long-term is going to look for that patient. Make sure that you have a service that's offering good preoperative workup and discussion with patients, but also long-term follow-up for them, so that we can look out for those things that I've mentioned as complications. This is not just a technical or surgical exercise. There's much more to this kind of work. Thank you very much for listening. I haven't been monitoring the chat while I've been talking. I don't know if there are any questions there.
I don't see any questions now. So if anybody has questions, please type in the chat.
So there is a question in there.
One question.
Yeah.
How do you prevent and manage giant lithiasis after vascoextrophy closure without enlargement of the bladder?
So I think that's a really interesting question. I think that it's quite possible that some of the newer techniques, so the Kelly, for instance, procedure, and a tendency to reconstruct extrophy earlier probably allows better cycling of the bladder, which creates a bigger volume and therefore perhaps less need for augmentation of the bladder. But there will still be a subset of extrophy patients who have a naturally very small bladder and who need augmentation. But the principles are the same for everybody. It's about making sure that there's a good amount of fluid going through the bladder so that they drink plenty, they have a healthy diet. If they have augmentation, Doug Hussman has shown us that it's important to irrigate that bladder every day with about 250 mils of water or saline to keep that risk low. So I don't think there's a 100% way of trying to prevent stones in those patients, but making sure that they have good general advice and knowing that those principles are important are certainly how we've looked after our patients till now.
And I just want to comment that I like your statement that when we embark in a big operation with those patients, we have a contract with them. I think we all always speak about the moral obligation that we have to follow those patients. the operation ends up being the small portion and the long-term follow-up is the most important one. So thank you very much, Dr. Wood. There is one more. If the child is peripubertal, as body changes rapidly, should one wait for puberty spurt?
So yeah, there's another question on the Q&A about bladder capacity. So which sort of ties into that. I think that, as Dr. Rink was saying yesterday, that I think that these decisions are about individualizing care and making sure that a patient and their family are ready to embark upon that surgical journey. So there isn't an age, and I wouldn't necessarily not do something before puberty if there was a clear indication for doing it. But if a child and their family didn't seem ready for that type of intervention, then as long as they're safe, their bladder is safe, then there's no particular reason for pushing ahead. In terms of bladder capacity, you can either do that cystoscopically if that's difficult, or if it's difficult, or you can do urodynamics in order to measure bladder capacity.
Wonderful. So I think we're gonna move on to stay on time, but Dr. Wood can certainly continue to answer questions in the chat. And now we have the presentation from Dr. Duncan Wilcox.
Thank you all very much. And thank you, Dr. Wood and Dr. Bischoff, for inviting me to give this talk. I'm very sorry that I'm having to give it as a recorded talk. But as you'll see later, if there are questions that I can answer, I'm very happy to answer them via my email address, which I've given. I have no relevant financial disclosures relevant to this topic. So today what I'd like to do is to outline the goals of transition. To me, that is relatively simple, which is to transfer patients when it's appropriate for them to a qualified, enthusiastic adult provider who understands the unique problems that these patients suffer. I'd also want to talk about the patient's expectations, the expectations that they will be transferred to people with skill who will treat them as individuals, not as children. I'm going to talk a little bit about my skill set and why, as a pediatric trained and pediatric practicing provider, it is difficult for me to fully understand and deliver the care I'd like for these complex patients. I want to stress that it's not just the surgical provider which is important, but the needs and education and experience of all the other providers which are critical to a success. And then finally, talk a little bit about managing clinic volumes, because if you don't transition patients forward and you keep accepting new patients, eventually you're going to have no room in your clinic for the complex pediatric patients that you are uniquely trained to treat. So why is this a problem now? Well, I think it's a problem now because a lot of the patients that are now needing transition didn't survive 30, 40, 50 years ago. So patients like cloacal extrophy, a lot of our patients with spina bifida, patients with posterior urethral valves, these patients are now surviving into adulthood due to improved neonatal, fetal, and childhood care that understands their unique problems and needs. And so consequently, we have this large cohort of patients who are now transferring out of the pediatric age room into the adult age group. And consequently, we need providers to look after them. I also think we understand that there are some late problems that these patients get. It's not just a continuation of the problems we see in pediatrics, but there are unique problems to growing up and into adulthood. And finally, because this is a relatively new cohort of patients, there is a lack of expertise amongst some of our adult providers, which is something we really need to advocate for and help train. So what are the goals of transition? To me, the goals are to ensure that patients get transferred to an individual who is well trained, understands both the congenital anomalies that these patients were born with, but also has a knowledge of the adult problems that they are likely to encounter. There needs to be a consistency of care. To me, this needs to be a warm handoff. That is, patients are seen in a pediatric clinic and transferred within that clinic to an adult provider who will then see them there, develop a relationship, and when appropriate, transfer them on to a adult hospital system. I also think it's important to survey them. We know now that their renal function may decline with time, especially as they grow in adolescence and in early adulthood. We know that there are late and unique malignancies that these patients suffer. And so it's important that they're surveyed for their renal function, for their lower urinary tract function, and for malignant issues. A lot of these patients will have had a complex bladder and bowel reconstruction, and those patients will likely have late surgical problems that will require a unique education in understanding these reconstructions and knowing how to treat them later on. And finally, our patients, thankfully, will want to go on and have an active sexual and reproductive life. And so consequently, we need people who understand this and the nuances of their care that their congenital problems will provide them. In terms of patient expectations, I think there are a number of patient expectations. Firstly, they want to be treated in an adolescent and adult environment. They don't want Disney characters surrounding them. They don't want to have toys given to them. They want appropriate magazines and literature. They want things to be told to them in an appropriate adult way. And so consequently, a lot of the pediatric hospitals do not provide them with the environment that ideally they should be treated in. They need to be given appropriate privacy. I think as pediatric providers, we're extremely good at including both the patient, the child, and the family in their care. But as adolescents grow, they need to have independence in healthcare decision-making. They need to become the primary health decision maker. And so consequently, parents who have for so long been accustomed to making these decisions for the families and for the patients, they need to relinquish that task. And it needs to go on to be the task of the patient. And as pediatric providers, we're not used to doing that. We're used to relying on the families to make decisions in the end. And so the simple act of getting a family, getting a parent out of the room so you can talk one-on-one with the patient is something that we don't normally do in our day-to-day work. And so it's vital that we have someone who understands that and is very comfortable with making that comment. And then finally, I think the patients are expecting that the expertise of the person who they're transitioning to will be equal or greater to the expertise that they're currently receiving. And ideally, the service that they get from a adult system should be similar to the service they get from a pediatric system. So what is my skill set or the skill set of most pediatric urologists? Well, personally, I spent 10 years in surgical training, and only 3 of those were managing and caring for adult patients. I understand that in the United States, a greater percentage of that time is spent looking after adults, but even so, it's usually at the beginning of training, not at the end of training. And so the decision-making, the complexity of the decisions you have to make will be less than you're expected to make in your practice. I've now gone on to be in practice for 20 years. And so my recollection and understanding of how to manage adults and the new advances that have taken place in adult care have certainly changed, and certainly leave me in a position where it's difficult for me to provide the same level of expertise to adult patients as it is for pediatric patients. We are extremely good at managing congenital anomalies. We understand them both from the fetus through childhood into early adolescence. And day to day, we manage infants and children on a very regular basis. If you look at most pediatric clinics and most pediatric operating rooms, you'll see that somewhere in the 80 to 90% of patients are under 8 years of age. And so we don't have a lot of experience in our day-to-day care in managing teenagers, late teenagers, and early adults, unless you have a fairly unique reconstructive bias practice in which you have these patients who need to transfer on as they age out of pediatric care. There are a very large number of conditions, congenital conditions, which continue to need care through into adulthood. I've listed some of them here, but clearly there are many, many more. So those patients born with a neurogenic bladder or developed a neurogenic bladder through cord injury or tumors, these are patients who either through the management of clean intermittent catheterization or through bladder reconstruction will need lifelong surveillance by a provider who fully understands all the nuances of catheter care, conduit care, and bladder reconstruction. People who understand that malignancy can be an issue after 10, 20 years and how to evaluate it. We also know that if patients don't catheterize, then their chance of getting renal impairment is significantly greater. And so the need to stress this is something that our transitional colleagues need. Increasingly, we're seeing patients with the extrophy complex surviving into adulthood, not just bladder extrophy, but also cloacal extrophy. Patients with posterior urethral valves or any complex urinary obstructive problem that will lead to late onset of renal impairment. Differences in sex development and those patients. I think this will represent an increasingly important area for transitional, especially as we start seeing less and less surgical reconstruction done in the infancy and early childhood, and that decision is delayed into late adolescence and early adulthood when patients can quite rightly make some of these decisions for themselves. We will need people who have that expertise in this reconstruction. And so it's vital that these providers get treated. Complex hypospadias is another area that we used to think once was corrected, went on without further problems in adolescence, and we know that's not the case. We know that patients get increasing problems with recurrent curvature in cord E. And finally, patients with anorectal anomalies, especially those with complex anorectal anomalies such as cloacas, and patients with bladder neck fissulas will need continuing urologic and gynecologic care way through adulthood. So this is a large cohort of our patients that can provide a great practice for people who are interested in transition care. So what is not my skill set? Well, I think I've shown that treating adults is not something that I have a lot of experience in now. And most pediatric urologists have little experience, and that experience gets less with time. we lose or we diminish our ability to communicate adequately and provide good healthcare education to these patients. And so it's important that we transition this. I think if we were honest, we know very little about sexual and reproductive function. And that is not surprising. It's not something that we need to know in our day-to-day practice. And this is an area that is technically advancing so rapidly that we will always be a little behind. The understanding of adult malignancies, the type and how to diagnose it, and then treat it or who to treat it. And this is an area that I think is really important, is that in our pediatric hospitals, we know who are the providers to refer our patients to when they have renal problems or GI problems. But because we're not living in an adult world, an adult care provider world on a day-to-day basis, we find it difficult to know who are the appropriate people to refer to, who are the people who understand these complex problems and who we should then transfer those patients onto. Finally, the independence that adult patients get from their healthcare system is different from the way in which we provide care for pediatric patients. We are much more likely to follow up, much more likely to ensure patients return than our adult systems. And so patients need to understand that and they need to advocate for themselves, which is something we don't have to do so much in a pediatric setting. In addition to us as providers, there are a whole host of providers in a pediatric and children's hospital who provide care to our patients who probably do not feel comfortable providing care to adult patients. So for example, in our outpatient setting, we have pediatric nurses and pediatric nurse practitioners. These are people whose only training has been in children. These are not people who've had experience like we have treating adults. And so they do not feel comfortable. They do not understand a lot of the adult problems. And in some cases, they're not actually licensed to treat patients over 18 years of age. So we need to be very cognizant of that when we get these patients back to see us, and further stressing the need of the value of transition. And finally, even our support staff, our schedulers and our assistants are used to dealing with patients. Parents, they're not used to dealing with the patients themselves. And so this is a whole mindset change. And they need to work in a different way to help our adult patients get the support they need. In inpatients, once again, we have pediatric nurses and pediatric subspecialists. And these people, in general, have not received any care, any training in adult care. And so they understand a lot about pediatric subspecialty care, but they really do not understand a lot about the more aging care that is needed. And this is really shown in our pediatric intensive care units, where these are settings in which everyone is geared to managing a patient or a small child and not a large adult. And finally, our anesthesiologists are experts in pediatric care, and while they have had adult care, this is not why they've gone into pediatrics, and they will lose their skills about managing adults, especially chronic conditions of adulthood and aging that may be vital to managing these patients. So I want to talk a little bit about managing clinic. When we were lucky enough to recruit Dr. Wood, we looked at our patient population, and we were seeing over 500 patients who are greater than 18 years old on a regular basis. And somewhere between 50 and 100 new chronic patients were being added to our increasingly busy clinic schedule every year. And so consequently, you can see that over time, because these patients will never get discharged, our patient population in our pediatric clinic will increasingly skew towards our adult patients. And I don't think this is good for our patients because we don't have that expertise, but I really don't think it's good for us because we trained as pediatric subspecialists. We obviously went into that because that was a patient population we felt most comfortable treating and most wanted to treat. And so it's vital that these patients are identified and transitioned out of your clinic so that they get the care they need from providers who have expertise and enthusiasm for that patient population. And we are able to continue to see the children and infants that we have expertise in managing. So there are a number of barriers to this. I think because this is a relatively new area, there aren't that many skilled physicians. I'm not aware of any current training programs for traditional transition care. So we need to identify and train physicians in transition care, and that will require us to us as pediatric providers providing care and educating people in the management and the congenital issues we face, but also adult providers providing education so they have this mix that enables them to bridge both sides. We need people who are enthusiastic. This is a difficult population. There are going to be very few simple patients these people see. They're mainly going to be complex patients who've had complex reconstruction. And so they need to be enthusiastic. Unfortunately, because many of these patients, certainly in the US, will have chronic conditions that will lead to federal insurance, their payer mix is going to be poor, which is going to have significant impact unless organizations and institutions can be very clever in how they manage this, in how these patients are going, how these providers are going to be adequately compensated for their work. We also need hospital partners to be enthusiastic. You know, adult hospital systems are not looking in general to get a whole cohort of poorly paid complex patients. That's not how they make their money and not how they therefore can provide an infrastructure for other things. And so we really strongly need to advocate for these patients. And finally, we need space. We need a space that is unique. It cannot be a pediatric space. It needs to be an adolescent and young adult space that has all the things that that population of people need and want to see in a waiting room, in clinic space. So finally, what are the benefits? I think for patients, clearly the benefits are in they get excellent transition of care that is lifelong. They get ongoing expertise by people who are really committed to their care, and they get an environment which is suitable for them. For providers, we get transition of care. We get expertise that we can rely on and we can provide to our patients, and our transitional colleagues are expert and they can provide. And finally, we can manage our clinic volumes knowing that we can, by doing this, consistently see the patients that are most appropriate for both sections to see. So thank you very much. Hopefully I've outlined why a pediatric urologist needs a transition care. I apologize that I cannot answer questions because I'm not doing this live. But if you have any, please email at duncan.wilcox@childrenscolorado.org.
So thank you very much to Dr. Wilcox for putting that talk together. It was, I think, a really comprehensive view of the importance of transition, not only to patients, but also to pediatric services. We're going to move on, and I'm delighted to welcome Dr. John Gearhart from Johns Hopkins, the Brady Urology Institute there. He has led and innovated in that center for more years than I care to specify for him. But he's shown great leadership, not only in his own center, but across many other countries in providing care for this fascinating group of patients. And he's going to talk to us about the adult extravy patient, current concerns and solutions. John, it's great to see you.
Dan and Andrea, it's great to be with you all this morning. So we're going to share our screen here. Okay. Okay, so I think this is a nice talk, and it's a perfect segue from Duncan's talk that we have about our adult urology, pediatric urology practice. I agree with Duncan 100% that after being a transitional urologist for 35 years, I think it's clearly become a scientific subspecialty of pediatric urology and pediatric surgery. And I think that getting a cadre of young people trained to do this is the wave of the future. So today I'm going to talk a little bit about the transition of care in the adult extravy Epispadias patient and some concerns and solutions for the future. I have no relevant financial relationships to disclose or conflicts of interest. I won't discuss any unapproved or off-label devices, but all the research findings that are discussed in this talk are supported by the Kwok Family Foundation of Hong Kong. So this is where we work. The hospital to the right is the Charlotte Bloomberg Children's Hospital, given to us by Mayor Bloomberg in New York 4 years ago, which is a lovely facility. They've sequestered all the pediatric surgeons on the 7th floor. And the nice thing about doing when you do transitional cases is that I can walk right next door into the Sheikh Zayed Tower, which is really the Johns Hopkins Hospital now. And I can do adults that I need to transition or adolescents that I need to transition right next door to the Children's Hospital. So what I'd like to talk about today is what I see in my transitional practice of my extravy group of patients: continued incontinence into adolescent and adult life, concerns about penile length and core D into adolescence and adult life, female genital and vaginal concerns, male fertility, female fertility, the risk of cancer and screening for cancer, and pelvic and hip joint issues as these patients get older. So we currently follow 1,421 patients with the extravy Epispadias complex. 1,135 are greater than 15 years of age, and 125 are greater than 50 years of age. So the goals, as Duncan said a few minutes ago, the goals of adult care are different than pediatric care. In the pediatric group of extravy patients, the goal is to achieve social continence. This is challenging in classic extravy patients, as the anatomy is greater divergence from normal. Typically, most are continent by 10 to 11 years of age, with a median number of 4 total urologic procedures to achieve urinary continence, including the initial closure. The goals in the adult patients are different: sexual satisfaction, the appearance of the genitalia, and fertility potential if parenthood is desired. And the challenges in the adults come to us a lot from the phenotype of bladder extravy. In the male, the penis is short and wide. Rich Silver, when he was with us, looked at MRIs of a group of 25 adult patients from the Baltimore Longitudinal Study of the Aging and compared those to age-matched extravy controls and did pelvic MRIs to measure the penile length in adulthood after extravy reconstruction. And we found that the anterior portion of the penis is 50% shorter than normal, while the posterior aspect is wider, 30% wider than normal. And that's depicted in this artist rendition of what your typical MRI looks like in the patient with classic bladder exstrophy. The challenges in the adults also stem in the female, stem also from their phenotype. The female vagina is shortened and widened. It's prone to stenosis, and it's common in adolescent females. Max Cervellione, who's just made professor this week at the University of Manchester in the UK, looked at this when he was here with us for a year, and he looked at 91 female classic bladder exstrophy patients. 29 had undergone vaginoplasty at an average age of 15 years. The reconstruction and properly selected patient had a low complication rate with durable results. No patients experienced vaginal restenosis, but all did undergo vaginal dilation daily postoperatively until they became sexually active. This is just from the Journal of Urology, a little artist depiction of how you do a Fortunoff flap and exteriorize the vagina in the typical classic patient with bladder exstrophy. You can also see a monsplasty. Even if they've had an osteotomy with their newborn closure, oftentimes the skin in the midline just above the clitorides is shiny, it's hairless. A lot of these girls want their escutcheon to be reconstructed and be a mons with hair on it, and this is fairly simple to do at the time of the vaginoplasty. What's really interesting is the differences in the clitorides between exstrophies and controls. Carl Benz, who's a urology resident at Harvard, looked at this when he was with us in the laboratory and looked at preoperative MRIs of 5 female classic bladder exstrophy versus age-matched controls with normal control anatomy. He found there was significant superior displacement of the clitoris, and the clitoris was separated as the pubic bones are in these ladies with bladder exstrophy. This is important because the clitoral body lengths were comparable. The classic bladder exstrophy patients have a greater proportion of their clitorides anteriorly, and they're more vulnerable to injury as less protected by bone. The controls are all midline with significant lateral deviation of the clitorides in the classic bladder exstrophy patients. And the thing to remember is when you're doing this, whether it's in a young infant or into an older adolescent, to avoid aggressive mobilization of the clitoral body, to avoid atrophy, because we don't want to see that. We have seen this in about 11 to 12% of the exstrophy girls that are referred to us after newborn closure with damage to the clitorides during their newborn early life exstrophy closure. So what do these findings mean for the timing of surgery in females? Well, adolescence is the ideal time to perform vaginal reconstruction in these girls. They hit their peak linear growth as the pubertal growth spurt hits around 9 to 10 years. And with the hormonal surge they see during puberty, this makes the vagina more supple, has it heal better, as you see in the DSD patients. And we feel that that's the time to reconstruction. Most of the girls come to us when they're around 13 to 15. They want to be able to use tampons and safely and comfortably insert the tampons. They're starting to think about boys and think about intercourse, and this becomes important. They want to gain greater confidence in their social aspects, as only 33% of our exstrophy patients were content with their genital appearance before surgery, and 56% of them exhibited anxiety over impending intercourse relations as they became older. The section during the bladder closure in the males is classically aimed to avoid manipulation of the prostate. It's difficult sometimes to identify the prostate gland in young infant boys, but you can do it. We looked at a bunch of men with classic bladder exstrophy and did MRIs of the prostate a number of years ago, and we found that the prostate is widened and flattened. It also is squashed a little bit anterior posteriorly, and you never see it wrap around the urethra completely as it does in the normal male. And this is why the old rumor, well, don't worry if they're not continent, when they hit puberty and their prostate grows, they're all going to be continent. And that's simply just not the case in our experience. The neurovascular bundles are displaced laterally in boys with exstrophy, and the spermatic cord is displaced laterally, but very near the margin of the bladder closure when you close the exstrophy, and you can harm the spermatic cord when you're closing the pubic bones together if you're not careful. Certainly, there are differences in the pelvic floor in males with exstrophy and males without exstrophy. Preoperative MRIs and 15 classic bladder exstrophies versus 16 age-matched controls. And we looked at the prostate and the pelvic floor. The prostate is larger in transverse diameter, and it's a bit squished anterior to posteriorly, as you can see this in the coronal view, and a controlled normal prostate versus a prostate in an exstrophy older male. Now, the timing of genital reconstruction in the males is important. In our practice, they come in and wanting penile lengthening, especially after they're dry of urine. Once they're dry of urine, they begin getting very interested in their penis for sexual activity. This usually occurs in later adolescence, not really early adulthood, when interest in intercourse becomes more important. They all want their penis to be longer, and oftentimes they want some cosmetic touch-up to have the penis look more normal. So we oftentimes use tissue expanders if the available penile skin is of good quality, and we can expand it use it as part of a penile lengthening procedure. Certainly full thickness skin graft. It must come from a hairless area below the navel that can respond to male sexual hormones. Native penile skin is preferred, albeit rare, because as you know, as you see these patients age, and even in the newborn period, the little bit of ventral foreskin they have is really all of the major decent skin they have. So you have to find a new way to make skin, because I really think at the end of the day, this really helps with penile lengthening. Patient maturity and participation for penile rehabilitation affects the ultimate success. Once we lengthen the penis, once we repair the dorsal chordee, they go on to a 3-month period of penile rehabilitation with penile exercises to help to maintain the length and also to help maintain the correction of the dorsal chordee. Tom Harris, who's one of our plastic surgery registrars, surveyed 28 patients to assess their perception of their penile appearance, their sexual function, their frequency of intimacy, and overall satisfaction after surgery. 14 were reconstructed with full thickness skin graft, 6 were reconstructed with tissue expander, and 8 underwent a neophalloplasty because their penis was so demure that it could not be used for intercourse. All patients were dissatisfied with their penile appearance before, with a median penile perception score of 4.5, which went up to 7.5 after surgery. While 23 of these chaps were dissatisfied with their penile length, 18 did report an improvement in penile length after surgery, and their median sexual health inventory score went up to 19, with no difference between the groups that underwent a full thickness skin graft or tissue expansion or neophalloplasty, which surprised me because really the neophalloplasty group do really get a really nice increase in penile length compared to those that get a graft or tissue expansion. But that's what the data shows. Not a huge study, but we're trying to accumulate more patients for this. Just some pre-op pictures to show, this is a tissue expander on the dorsum of the penis, which is then used, the expanded skin is used to cover the penis and brought ventrally to lengthen the ventrum of the penis. The B patient is a patient with a poor quality skin, especially on the dorsum of the penis, and he underwent a full thickness skin graft to lengthen the penis and straighten it. And then the last one's with a child who had the complete primary repair of exstrophy, the so-called CPRE repair, who lost the majority of the glands in both corpora, and he's had a neophallus repaired and made in figure 8F. And you can see a really nice cosmetic appearance and also a real nice length after this. So penile lengthening, you can see the midline scar here. This child was closed without an osteotomy, so there was tension on the midline, and that's why he's got that terrible midline scar. The penis is demure, as you can see, about 4 centimeters in stretched penile length after the skin was degloved. And then you can see with his graft and a little bit of a glandsplasty, he's got a reasonable increase in size from a full thickness skin graft and penile lengthening. And penile lengthening, as Chris Woodhouse has described, is just really going back inside, cutting all binding bands, cutting all remnants of the suspensory ligaments, which you often find intact even after newborn extravascular closure and epispadias repair, anything you can do to achieve extra length. Here's another guy who's got a midline scar and the penis is sort of trapped in this midline scar. We got rid of all that skin, repaired the midline dorsal to the penis, and added a skin graft. And you can see a fairly reasonable increase in penile size and length, rather. The neophallus, we're actually doing one of these today. This is a child who had a dorsal lateral flap used to make the neophallus. We're involved in this. What I do is deglove the penis, lengthen the penis as much as I can. I isolate the neurovascular bundles on the proximal end of the penis for the plastic surgeons, and the microsurgeons come along, grab the flap either from the medial aspect of the non-dominant arm or the leg, depending on their choice. And then you can see the neophallus that's constructed. We then have a tattoo artist come in a few months later, and they tattoo a corona around the base of the glands. And then at a year after surgery, the adult urologists come along and put a single cylinder of an inflatable prosthesis in this penis for erectile function. And they work pretty well. We found that in the group of patients that had an evaluation of their sex prior and after penile lengthening, either with a graft, tissue expander, or a neophallus, 22 of 23 were having sex after their surgery. Their overall increased penile length was 1.75 to 2 inches after penile lengthening in the group that had a full thickness skin graft or the tissue expander. Now, you have to moderate these people's expectations. When you say penile lengthening to these teenage boys, their eyes light up, but you have to be realistic that we're talking about 1.5 to 2 inches max with increased length. So you have to modify their expectations, but tell them the penis will be straight and it will be satisfactory for intercourse. So additional options for reconstruction. Tom Harris, again, our plastic surgery registrar, looked at intercorporal prosthesis plus a neophallus in 13 men. 10 had had a successful primary closure in childhood, 3 had failed. One, the patient we showed you, had significant corporal loss after the Mitchell CPRE repair. They had the initial penile prosthesis placed a year after their phalloplasty, and it averaged them to be about 23.2 years when they had that done. 76, almost 80% of them, we used an alloderm wrap around the inflatable prosthesis to support it inside the neophallus. And this worked really well. We did have 3 patients in our early experience who eroded their inflatable prosthesis through the glands. And those are early on patients that the adult urologist who placed the prosthesis didn't wrap the prosthesis in alloderm before they placed it. And I think that's really the key in helping prevent erosion. The IPP placement in neophallus has a low complication rate and morbidity, and they have successful outcomes, but you still have to take care as far as any risk for erosion of the prosthesis. This just shows you a neophallus here, a single cylinder wrapped in alloderm, which is going to be placed on the inside of the neophallus about a year after the construction of the neophallus. So long-term sexual function, our series from '96, an older series, all of the extra boys who became men had adequate erections for sexual activity. but 6 felt their penis was actually too small for intercourse. 78% were satisfied with their orgasms. Among the female group, all said they had a normal libido, they had normal menses, and were satisfied with their orgasms. In a larger series from a lady gynecologist from Denmark who came to spend time with us looking at their urogynecologic and obstetrical issues, 83 patients, all became pregnant who wanted to. They all said they had a normal libido. Most began their sexual lives about the age of 20. 85 of these 83 females said they had normal orgasms. 15% were unsure, and 6 did complain of dyspareunia. So what do they report? Tom Harris looked at a survey, and Kelly Harris, the two Harrises, looked at a survey of 144 adult patients with bladder exstrophy epispadias. 52 engaged in penetrative, 52% of the males engaged in penetrative intercourse. 15 of the 63 males reported biologic paternity, so about 23%. 8 required assisted reproductive technology, of which IVS was the most commonly used. 19 of 75 female patients surveyed reported a 25% reported successful pregnancy. All had a urologist present at the time of the cesarean section. Interestingly, several of them had leakage through their urethra after even a cesarean section delivery. 7% reported postoperative uterine and vaginal prolapse. And what's interesting among that group, the vast majority of the group had their primary exstrophy closure in infancy without an osteotomy. And I think that's key. And 40% required further urogynecologic surgery after their cesarean section. So I think the take-home message from ladies is that most will have fairly largely normal sexual lives. It's very important that they don't deliver vaginally, and they have elective obstetric or gynecological cases. Should always include a urologist at the time of reconstructive surgery, especially these ladies who've had continent urinary reservoirs and they're having a cesarean section. A crash C-section can certainly damage the continent stoma, it can damage the bladder, and this should be an elective C-section on Monday morning when everybody's fresh and there's an adult urologist there to help the gynecologist take the baby. Fertility in adult male patients is interesting. Classically, sperm parameters are diminished in males, likely due to iatrogenic injury to the vira montanum during closure or bladder neck reconstruction. In a large series, international series of 2,500 exstrophy epispadias patients, 38% said they had fathered children. Ejaculation seems to be affected by reconstruction of the genitalia, or there's no corpus spongiosum present. Many men have to antegrade milk their urethra to get their ejaculate out. So whether infertility is due to a damaged sperm transport, probably so, not a deficiency of sperm production, because when we've harvested sperm from the testes in these men, the sperm look normal, they have normal motility, they have normal anatomy. But when artificial reproductive technology is needed, IVF is the most commonly used modality, as we previously mentioned. So overall, in male patients, fertility is decreased. Tim Baumgartner, who looked at this and published this in the BJU in 2017, surveyed sexual health outcomes in men with classic bladder exstrophy. He had 113 respondents for a 53% response rate, which was respectable. Their mean age was 32 years. 85% of these males had been sexually active in their lifetime, and about 60% were moderately satisfied overall with their sex life. 23 of 32 men who attempted to conceive were successful. 27% of the men underwent semen analysis or post-ejaculation urinalysis, and they had sperm present. Only 4 men reported azoospermia. Now, this was a survey that involved multiple institutions. In our own particular Hopkins cohort, we've had 31 male patients have achieved pregnancy with IVF, and all fetuses, touch wood, so far have been normal. Very few of our patients have achieved pregnancy with intercourse alone. In our experience of women, 83 women over 18 years of age, nearly all were fertile who wanted to be. In one series, reported 45 women with classic bladder extrophy successfully delivered 49 normal offspring. I think one reason for the high fertility rate in extrophy ladies is because, as Chris Woodhouse showed us years ago, the cervix is not in the dome of the vagina, it's in the anterior wall of the vagina. And these girls have really not much trouble getting pregnant when they want to be. They all said their sexual desires, their libido was normal. Most were sexually active. Most girls began their sexual lives around 19 to 20 years of age. Some small group did report dyspareunia. Most reported orgasms. 10 reported decreased intercourse due to cosmesis, other external genitalia, such as skin bumps, bivots, bald spots, split clitorides, etc. But overall, their sexual lives, and for ladies, are pretty good. Pelvic organ prolapse, as we talked about, is usually a result of parity and age. The pelvic floor is, as you know, should be 50% should be behind the rectum, 50% in front of the rectum. But in the extrophy group, that's quite different. That the vast majority of the pelvic floor is posterior and very little of the pelvic floor is anterior. And this is what causes them to have uterine prolapse. We've seen uterine prolapse in our experience mainly in ladies who did not have an osteotomy at the time of their newborn extrophy closure. We have seen 2 virginal females who had pelvic organ prolapse before they'd even had an intercourse, and neither had a pelvic osteotomy at the time of primary closure. And these 2 patients, I helped one of the urogynecologists, who's a urologist by training, to suspend the uterus and the vagina so these young ladies could have intercourse and have a pregnancy when they desired. Social concerns, a nice paper from the Netherlands a few years ago. All of these patients were diverted, as Dan Wood was saying earlier. Most had a positive attitude towards life. All the males were concerned about their penile length, but all had good erections. All the females had orgasms, and all who wanted to become pregnant did have children. So emotionally, 50% of the males and all the females described their relationships as serious and long-lasting. And in our experience, about many of these people have higher degrees. We have 2 extrophies that work here at Hopkins. One is a child psychiatrist, a lady, and the other one is a surgical intensivist. And they have normal lives, and they have children, and they contribute to the health care of people. And these people can be educated and can have very, very good careers in life. Their adolescent quality of life, we did this a number of years ago. The good scores related to the reference populations from 2 prior studies in this questionnaire. And actually, most of them have a fairly good quality of life assessment. So the group that we're particularly interested in our long-term follow-up, are children and adolescent and adults who come to us who still have urinary incontinence. And we sort of group those into 3 groups. Incontinence never treated, and I've seen a number of these. A number of these come in teenage years. I had a 24-year-old lawyer come in who had been incontinent his whole life, and he finally came in to have his continence treated because his lady friends weren't liking having urine leaked on them when they had intercourse, and that's what drove him to come in. We've had others who've had multiple failed attempts. They've had failed bladder necks. They've had failed bladder necks plus augmentation plus stomas, failed augments plus stomas plus bladder neck transections, and some of those who've had a bladder neck reconstruction stoma alone who still leak. And finally, those, which I find a very interesting group, are those who have failed continence after achieving childhood continence, then become incontinent again during adolescence and adult life. So there are certainly available options on those patients who've had incontinence and never been treated. It's rarely a bladder neck reconstruction, as in these patients who enter adolescence and adult life who really don't have adequate outlet resistance, their capacity is usually always decreased, and the vast majority of these need a bladder augmentation. Certainly, people have used artificial urinary sphincter in these patients. I have minimal experience with the artificial urinary sphincter. My major experience with the artificial urinary sphincter is removing it after it's been placed in an extravascular patient. So those who have adolescent incontinence or young adult incontinence usually require something done to the bladder neck, a bladder neck reconstruction, a bladder neck transection, plus an augmentation in a stoma in order to be dry. And we've seen a number of those patients, and we have about a 92% success rate of getting them dry with some combination of the above procedures. So in the adolescents, the most common reason we see in our practice is a failed continence procedure in childhood. We published this in the Journal of Urology a couple of years ago. We looked at 432 patients who were evaluated over a 42-year period from a daily updated database. They oftentimes, when they did present in adolescence, they'd had a mean of 7 prior attempts to be made continent of urine during their lifetime. And we're able to get about 92% of those patients dry with some sort of outlet procedure, a bladder augmentation, and a continence stoma. Our dear and great friend, Dr. Doug Canning, when he was with us in 1992, looked at 50 failed bladder necks who were referred to Dr. Jeffs and I for reoperation to become dry, but only 20, these are all adolescents, only 20 of these had an adequate capacity and stable urodynamics, and only 8 were dry after reoperative bladder neck reconstruction, or 40%. So we've abandoned reoperative bladder neck reconstruction alone without augmentation and a continence stoma because the results are meager and they're going to need a more invasive operation after a failed bladder neck in order to become dry. The most intriguing group are those with a continence stoma and augmentation who've had an outlet procedure but remain wet. Dominic Trimberger, who's out at the University of Oklahoma, looked at this in 2003, and he looked at failure in continence from the stoma or the urethra in 92 patients. The main reason that they became incontinent after becoming continent earlier in life was desusception of the appendix from the colon or the bladder or the ileum that it was placed into, or desusception of the tapered ileal malone, which was used to make them dry, or they developed bladder neck incontinence. At a mean follow-up of 3 years, those patients had up to 8 operations ordered to achieve continence before they came to us, with a mean of 5. 40% of these patients required at least 1 revision of whatever we did to make them dry, and 32% required 2 revisions to make dry. This is a tough group of patients. 97% will become continent, but at a greater surgical cost, with a replacement Mitrofanoff, redo Mitrofanoff, tapered ileum, reoperative augmentation, whatever. Those that have had augmentation, a continence stoma, and an outlet procedure, and who become wet, these are some of the toughest patients you'll see to make continent of urine. Carl Benson, about 3 years ago, updated the series by Trimberger, found 166 augments with continence stomas, and 17 of these required reaugmentation. The sigmoid colon was the most common segment used to augment them, and ileum was the most commonly used segment to reaug them. But what was fascinating to us, in those that had a failed augment, from the original theater notes, the average sigmoid segment taken was 12 centimeters versus 19% in 19 centimeters in controls. In the reaugmentations that we saw, the mean ileum that we used was 19 centimeters. The mean reaugment capacity prior to reaugmentation was 100. The mean postoperative capacity at 14 months was 380 cc's. And clearly the reason for reaugmentation is at the time of original bladder augmentation, they had an inadequate bowel segment used. You can't be tentative. You've got to use a nice piece of bowel, a nice copious piece of bowel, to give these people the right amount of bladder capacity, not only to make them dry, but to protect the upper urinary tract. Nutritional concerns are not significant. Doug Canning looked at this when he was with us again, and we did not find a lot of B12 or carotene deficiency in these patients several years after their augmentation. Not a lot was used. You want to stay away from the ileocecal valve. If you are going to see a B12 deficiency, it can become manifest several years after the augmentation. Folate, you want to measure those in ladies who have been augmented, especially those who are preparing for childbearing. Low carotene levels, they can have fat soluble vitamin sufficiency. We have not seen this in the extravascular group, but we have seen it in the spina bifida group. Nutritional consequences are not a typical problem. Remember that many of these adults are exposed to a wide range of wide spectrum broad antibiotics as children, especially if they went under lower urinary tract reconstruction. Certainly, urinary infection rates are highest during the perioperative setting, as we mentioned earlier, as Duncan mentioned earlier, and Dan did too. Regular irrigation, if they underwent diversion, is important to decrease stones and urinary tract infections, but other speakers have addressed that. So what about the long-term fate of the upper tracts? Actually, they do pretty well. We have not found a big difference between our XV Epispadios patients and our non-XV Epispadios patients when compared to age-matched controls. Continent patients were more likely to develop reflux, which portends a higher risk of pyelo, but we need longer-term studies to evaluate these patients overall. But if their upper tracts are normal when they undergo their continent urinary diversions and they take care of themselves, the upper tracts overall tend to do very well. Hip and pelvic differences in adolescent adults. We certainly know that the hip and joint stress forces related to body weight and those without pelvic osteotomy compared to age-matched controls are increased. There's a score called the Iowa Hip Score, which measures stress to the XV hips in patients with classic bladder XV, and they found that to be markedly increased in XV patients who did not have osteotomy at the time of their newborn or early childhood closure. Dr. Sponseller has a longitudinal study underway to assess degenerative changes in XV Epispadios patients with and without osteotomy at the primary closure. And those patients are getting older, and I think we're going to have some really interesting data in the next few years about that. Paul Sponseller, our prof of pediatric orthopedic surgery, is following middle-aged Epispadios XV patients without osteotomy in childhood, and in a select group of these patients who are not obese, who exercise, who take care of themselves, he has found an increased risk of premature osteoarthritis of the hips. And this may impact what we recommend for childhood, and maybe everybody needs an osteotomy, even if they're closed early, just to offer more protection to the hips as they get older. Cancer risk and screening, we've certainly seen patients with males with prostate cancer. We've seen 5 patients in the last 20 years with prostate cancer. As it was interesting, as Dan Wood mentioned earlier, these patients get older and they develop unique problems. And, in the early XV group, they all died of chronic renal failure before they got old enough to get prostate cancer. Well, now they're living. And for these 5 patients that we saw with prostate cancer, their free PSAs were less than 25%. When they came to us, 3 were dry and voiding from the urethra, 2 were wet, and all underwent radical retropubic prostatectomy. Not by me, I assisted, but I have adult prostate cancer colleagues who do these all the time. They did open radical retropubic prostatectomies on all of them. Every one of them was wet after a radical retropubic prostatectomy. So the main thing is older patients actually need to be screened. They need PSAs. And if their PSA just bumps up a little bit, they should be carefully evaluated for prostate cancer, because their PSAs with prostate cancer do not go up as longitudinally as men with normal prostates do without exstrophy. So an interesting finding, an interesting thing that we all need to be concerned about, especially those of us who see transitional patients. Bladder cancer, this has been reported in multiple case reports, but no real big series. The histological types, as Dan Wood showed us, is adenocarcinoma and squamous cell. We have not seen any bladder cancers in our group in primary closures or augments, but we have seen 5 cancers in unclosed adult extremities who presented to us in middle age, and they had cystectomies. The interesting group that we're interested in, because we see a lot of these, are failed extravascular closures, because oftentimes when they have a failed extravascular closure, they develop cystitis glandularis. And many of those patients, because the bladders don't grow who have failed closures, who get reclosed, get augmented. And John Epstein, our pathologist, thinks there is an increased risk in those patients who have failed closures and who have bladder augmentations, who have cystitis glandularis. They have an increased risk? We don't know, but we recommend to them as they get older to have yearly urine cytologies and bi-yearly cystoscopy in their primary closures and augments, and yearly in the failed closures and augments in the office, fiber optic cystoscopy in the office after the age of 25. There's no science to this. I'm just telling you what we recommend to our patients, especially the group that we're concerned about, the failed closures who undergo augmentation. Chris Woodhouse and I looked at this in the World Journal of Urology in 2006. We looked at 103 patients between London and Hopkins who were born with extravascular. 42 had ureterosigs. 61 did not have diversion. They were either incontinent through the urethra or they were continent through the urethra and voiding from below. The cancer risk was 19% in the group with U-SIGs versus none in the group that were voiding or were incontinent from below. Chris updated that series over the 40-year follow-up a few years ago. He found 3 cases of bladder cancer in the uterus, cancer of the rectum, bladder cancer, if you want to call it, in the U-SIGs, and 1 in the non-U-SIG group. And he classified these into high risk and low risk. And they've recommended yearly colonoscopies in ureterosigs after 30 years of age. So the mean age of 40 years, the risk of cancer in the extravascular population is 694 times that of the normal population, but that is mainly in the U-SIG group. We don't know about the classic extravascular group who are either augmented or who void on their own, but that data will come with time. So I would like to thank you for sharing your morning with me, and I'd like to give our gratitude to our patients and their families. As Andrea said, you become their doctor and you become part of their family. And we'd like to thank these people for becoming our partners in discovery that have led us to improvements in the care and outcomes of all patients with bladder extravascular as we continue with this interesting group of patients. And these are the references, and they'll be available for you if you need any of these. Thank you very much for your time.
Thank you so much, Dr. Gearhart. I think we can all enjoy your experience, and you are one of the examples of what a difference it makes when you have a center of excellence, so you can accumulate so much experience in rare disease. I just want to emphasize that most of the talk was on bladder extrophy and Epispadia. I think the data is not as good in cloacal extrophy for some aspects that you mentioned. But I have a few questions, some from the audience and some from my own. So the first one from the audience by Dr. Maria Marcela Bailes. Would you advise uterine suspension during bladder augmentation to prevent future prolapse?
Yeah, I think that's, hi, Marcella. Marcella's a Hopkins graduate. Yes, I think that's perfectly reasonable. And if we are doing an augmentation and we do a pelvic exam and there's any evidence that there's some relaxation of the pelvic floor, we will prophylactically suspend them. Absolutely.
So do you mind if I just follow up on that question? Because that was something I wanted to ask you about from your talk. You mentioned doing these suspensions prior to pregnancy. I've always had a concern about that because in my mind, I'm worried that you're predisposing somebody to a revision surgery once they've had their pregnancy and it's undone your good handiwork from their prior suspension. Do you have any thoughts on that?
I do, Dan, and the vast majority of those that we suspend are ladies who've had a delivery, they've had a cesarean section, and and I tell them all, we can kind of guarantee you, if you've had an osteotomy at birth, one cesarean section without prolapse. But that's not always the case. So if they prolapse after delivery and they want more children and they don't like having uterine prolapse, then the urogynecologist and I will suspend their uterus. But the vast majority are after delivery. Yes, sir.
And I have a question about penile reconstruction in patients that are born with absent penis. That's the malformation that we see, that they have posteriorly deviated. I don't have experience, but what I imagine is that, yes, you can reconstruct a penis, but there will be no sensation. Is that correct?
That's correct. And that is correct. They will try, and those that we've dealt with, Andrea, they've tried to take the nerve. We usually use the inner aspect of the non-dominant arm, and they try to find some nerves in the femoral canal or somewhere, even the ilioinguinal nerve. They try to find a nerve to anastomose to, but they're not very sensate. That's absolutely correct.
There are techniques. So if there is an existing phallus with a glands, then they'll piggyback.
That's what we're doing today. That's exactly right.
Yes.
But if Andrea is saying there's no phallus at all, you
Correct.
can dig around the phallus. If you find some corpora, you might find some nerves. But the vast majority of those without a phallus are not sensate.
There are a huge number of very complimentary comments about your lecture, John. Obviously, it was superb. There are a couple of other things I wanted to ask about. I agree with you. That group that were continent initially and then become incontinent later in life, I think they're a real challenge, and I always worry that there's going to be some awful pathology there. To date, I've not encountered that. But I have encountered a number who have refistulated around their kind of early 20s or so. Again, interested in your comments on that.
Well, it's finished, and we've been scratching our heads about that the last few years too. And I'll tell you what we've done. We routinely in those patients, Dan, when we transect the urethra, transect the bladder neck, put alloderm, we routinely do a rectus muscle flap. And put a we've got a fairly good series of that we presented at the plastic surgery meetings, because those are difficult fistulas to repair, and the idea is to prevent them. And we've done it in the cloacal x-rays too, Andrea, who've had fistulas after some sort of bladder neck procedure, that we're pretty much routinely doing rectus muscle flaps in those patients. Yep.
And then you asked, or you mentioned about the kind of metabolic follow-up of these patients and the importance of that. I've always worked on the basis that it's cheaper and safer to check everyone's B12 every time they see us, because the consequences of missing low B12 are so significant that it's better to have that safety net. Is that your view?
That is my view, but we've been laggard in that in our practice, to tell you the truth. We get them maybe every couple of 3 years or whatever, but this is where I think that if we have, and we don't, but we're sending one to you, we're going to have a transitional urologist that you're going to send her back with better habits than I have, and we'll get more focused on that, because that's important.
Yeah, I think she's halfway between Baltimore and Denver at the moment, or about.
Right. In a moving van, yeah.
I haven't seen any more other questions come up on the chat. Andrea, I don't know if you had anything else. It's been, as always, a real pleasure to listen to you talk and to ask questions of you and pick your brains and your expertise. John, thank you very much for joining us this morning.
And Andrea, thank you so much. It's a pleasure to be with you all. Thank you for your kind invitation.
Thank you very much, Dr. Gearhart.
All right. Bye-bye now.
Bye, John. My suggestion is that we're expecting Dr. Misery in about 15 minutes. We've kind of been going for nearly 2 hours. My suggestion would be, or just over 2 hours, my suggestion would be that we give people a few minutes for a kind of comfort break and then resume in a few minutes. Would that be reasonable?
That would be perfect. Let's take a bathroom break and be back in 15 minutes.
Wonderful.
Hi, everyone. Can you hear me?
Yes, great to hear you,
Okay.
Rose. Yeah, how are you?
Thanks. Sorry, I'm good. I don't know how I look. I just took my hat off from the OR. So
I was just typing you a message to say that if you were held up, then we could swap things around. But great to see you.
nice to see you as well. I'll just.
So we've just given people a few minutes comfort break. So if you're okay, we'll hold on for a few minutes just to give everyone a chance to settle back in.
Is it okay for me to have my screen up so that
For sure.
you can see it? Okay.
Absolutely, yes.
Yeah, of course.
Yes, thank you.
Yeah, yeah.
Perfect.
I heard yesterday went very well.
It went very well. Yes, we had over 800 people attending. So
Did you say 300?
no, 800.
800. That's spectacular.
Yeah, it's we were delighted with the attendance and the conversation. It was good.
Okay, whose screen are we seeing now?
So
It's me, Rosalia's.
Oh,
yeah.
perfect. Okay.
Did
Yeah,
you want to bring? Did you want to bring up
everybody's
your
seeing
present?
the screen. So if you want to put your presentation already, that would be great.
Yeah.
Do you want to get yourself set up with the presenter view, Rosalie? Yeah.
I think
No,
if you double click your presentation, you should be okay.
I think I'm fine without the presenter view. So.
Oh, we can't see anything.
We don't.
Oh,
have
you can't.
No, we just got a view of kind of your
We
PowerPoint.
have like a dashboard in your PowerPoint.
Really?
Yeah.
How
There you
about
go.
now?
That's it. That's
Okay.
it.
Now we
Now
have
I
it.
it's perfect.
apologize. I apologize.
That's okay.
Hello, Dr. DeWin. How are you?
Good to see you, Gunter. Looks like Gunter's trying to connect to the audio, I guess. So shall we restart?
Yeah, why don't we?
Okay, sounds good. All right. Well, I'm delighted to welcome Rosalia Mazzeri. We heard from Dr. Rink yesterday about his experience overall in terms of the long-term care of these patients. Well, I know Dr. Mazzeri has worked alongside Dr. Rink for a number of years now in Indiana, where I think it's fair to say they offer a really very comprehensive transition service based around their long-term patients. So it's a real pleasure to welcome you, Rosalia, to talk to us about the management of the adult spina bifida patients. Thank you so much for giving your time.
Oh, thank you so much to the organizers, Dr. Wood, Dr. Bischoff, and everyone else who helped put this together. It's a spectacular program that you've put together, and certainly something that's necessary. It's with great pleasure that I do this work. I'm a pediatric urologist by training, and obviously, a board certified urologist. And so we're able to take care of these patients into adulthood. And I do work closely with Dr. Rink. In fact, many of the patients that I see are his old patients. So it's great to be part of this program. When we look at the adult spina bifida patients, some of the concerns are exactly those that are the concerns of kids. So continence, renal function, maintaining the urinary tract. But as kids get older and they've had surgeries, we also have to pay attention to some other things. For example, vitamin B12 deficiency or neoplasms, hernias. But then there are other things and things that concern sexuality and fertility that we're concerned with. So when we look at spina bifida, as people may have mentioned, there are more adults with spina bifida in the United States than there are kids. And with improved survival, we expect that there will continue to have a large population of adults with spina bifida in the United States. Many people have looked at what the potential needs of these patients are and how to best transition them. So 18 to 21 is decidedly the age that most people recommend. However, this timing has to be really flexible, and it's dependent upon so many things in these patients that we see. So if we look, really we have to take into account things like independence, and independence can vary not only based on age, but on the level of their lesions, on the socioeconomics of the family, their mobility, and the family stressors. We also have to remember that people's interests change. So just like any other teenager and young adult, people with spina bifida participate in risky behaviors, but they also want the same experiences that many of us do. They want to have jobs and relationships, and certainly they want to be supported and accepted by their peers and their community. Social structures change, and this primarily happens around the time of graduation from school. Because they have fewer friends outside of school, and social integration for many is difficult because of issues with mobility and executive function. Caretakers change as well. So as the parents age, siblings take on some responsibility, but so do some group homes if and when they're available. And the demands of taking care of a person with spina bifida, whether they're independent or they rely on others, really has some specific demands that are physical and technical as well as economic. As people age, we know that their compliance and adherence to care changes. Urologic care is available for about a third of these patients, or a third of them are the ones that seek it. And the reasons why they don't get the care is because of the ability to find providers in their communities that are interested, but also things that have to do with cognition and memory. There are other contributing factors, and these are similar to the ones that I previously mentioned. When we look at how these patients interact and function, there are some altered learning styles, and that poor executive function is one of the things that we think about in that making those appointments sometimes is difficult, or remembering to catheterize sometimes is difficult. And many of them haven't had the opportunity to experience decision making. They may also have issues with hydrocephalus and shunts, which may affect their cognitive independence. Their bodies change as they get older, so obesity and kyphosis might worsen. They develop osteoarthritis. They may have decreased abdominal strength related to overuse. And this all affects mobility, but it not only affects mobility, it also has some neurologic consequences. So if we start just based on what we do on a day-to-day basis, it becomes difficult to examine these patients, transferring them from a wheelchair onto a bed. They have difficulties catheterizing. Even if you've created a channel for them, it may have been done when they were a child, and now their bodies change. And as many of us, as we get older, know that sometimes it's a little bit harder to get to see some of the parts of our bodies that were very evident previously. Surgical complexity increases. Things as simple as positioning a patient for surgery become more difficult. And we know that the complications in adults increase as well. Healthcare is more highly utilized by these patients, and the complexity increases. And there are certainly barriers to care, including who makes the decisions for these patients and how do they get insured once they're over 26 and no longer available to have their parents' insurance in the United States. But particularly the urologic concerns are similar, aside from that of more focus on sexual function and reproductive function. But we also, as urologists, need to think about independence and support their quest for independence and their quest for an improved quality of life. There are some spina bifida guidelines, and these are relatively new. And when these were being put together, the questions were essentially those of, how do we optimally surveil the upper and lower urinary tracts? What cancer screening is necessary for these patients, and in whom and when? How do we define UTIs in the adults, and when do we treat them? And how do we minimize the sequelae of secondary incontinence in adulthood? So we have to keep thinking about those things that we thought about in childhood, but now we add on to that. So from this group that came together and came up with the guidelines, some things were put forth, and these really are simply guidelines, and most of them are expert opinion. So yearly ultrasounds are recommended, and renal and bladder ultrasounds when patients develop recurring UTIs or urodynamics identify some bladder hostility. So in addition to those yearly ultrasounds, a yearly screening serum creatinine, although that is quite controversial because it may not adequately measure renal function in these patients. Yearly serum chemistries with B12 if the bladder's been reconstructed, cystoscopy and appropriate upper tract imaging if the patient is augmented and has some of the things that Doug Koosman put forth as additional risk factors for cancers. So is there gross hematuria? Is there change in their continence? Is there pelvic pain? And renal transplant patients who have BK virus or polyoma virus. We have to evaluate the patterns of continence and incontinence and trying to assess the amount of incontinence, and also getting to the root of why there is incontinence. And again, supporting self-management and independent living when it is possible. So Professor Woodhouse, who Dr. Wood worked with closely and who is considered the father of transitional urology, really looked at things critically early on and was an inspiration to a lot of us who do transitional urology. And he said it was really important to understand the reconstructions and the revisions. And I think this is important for anyone who is either transitioning a patient to an adult provider or is receiving that patient. And you really have to know what tissues are in the urinary tract. You have to understand how the patient empties, whether they have any metabolic abnormalities, and also what's the status of their GI system. So if you look at this very old operative note from 1991, in the patient who I still follow, you can see that just in one procedure, she had eight separate procedures in one operation. So these patients could be very complicated, and I think it's important at least to have a summary of their care. Obviously, after making sure that someone stays alive, we want to make sure that the kidneys are protected. We know that renal impairment can affect 30 to 40% of these people, and was a leading cause of death in the past, and still can be a cause of death in many patients. And if left untreated, 50% of patients with spina bifida will develop chronic kidney disease. Renal function, as I previously mentioned, is a little bit difficult to evaluate, primarily based on their low muscle mass and their body habitus. And people have tried to come up with different ways to measure it. We know that we have to get the most accurate assessment of GFR that we can. And obviously, this is going to differ from institution to institution. We have to make sure that there's somebody who's surveilling their blood pressure and checking for proteinuria, as these may be the first signs of chronic kidney disease in some of these patients, and referring them early on to nephrology. But monitoring lower urinary tract function is important because we know that that might affect what happens in the upper tract, and certainly when stones are noted, to treat them promptly. So what are the risk factors for renal injuries in adults with spina bifida? Poor adherence to catheterization schedules, repeated infections, obstruction, changes in their bladder dynamics, but also obesity and hypertension. And sometimes as a urologist, I feel I'm not adequately trained or skilled to counsel people on how to avoid obesity, weight gain, and things that can contribute to hypertension. Recurrent UTI probably is the biggest bane of any transitional urologist's existence, because not only are they common, but the symptoms are atypical, and we have to really train people to understand how to differentiate between UTIs and colonization, and cautiously use antibiotics, as many of these patients already have multi-drug resistant organisms. If we look, up to 85% have chronic bacteriuria, and 34% will have symptomatic recurrent urinary tract infections. And this makes up for about 10% of all hospital admissions for adults with spina bifida. We want to make sure that treatment is limited to patients with symptoms, but importantly, it's important to understand what these patients' symptoms are, because they present in atypical ways. For some people, it could be that they develop GI symptoms, and some people with spina bifida may develop headaches or other changes that are not the typical symptoms that you see in UTIs in younger people without spina bifida. Dr. Ross and colleagues looked at trying to define what urinary tract infection is in patients with spina bifida, and came up with some guidelines. Certainly having a urinalysis and a urine culture that are positive are important, but also looking at those symptoms and whether there's fever. New or recurrent infections. So if you've had an adult who's never had a UTI and then suddenly starts getting UTIs, do require evaluation, and you want to evaluate for stones. How are they catheterizing? Are they putting their catheter in their shoe, which I have been told by some patients? Are they using saliva as lubricant? Do they have new vesicoureteral reflux? Have their bladder dynamics changed? Are they managing their bowels? And are there any anatomic problems? Could it be that their augmented bladder has an area of narrowing, so urine's getting stuck in it? So these are all things for us to consider. When we look at bladder function, we know that continence changes over time, and sometimes it actually gets better because prostates get bigger, but sometimes it gets worse, and it could get worse because of anatomic things, such as false passages, as we see in this picture. It could be related to obesity. It could be related to cognitive changes where they don't remember to catheterize, or even to dexterity where they can't get to catheterize appropriately. Tethering is less of a problem once a patient is a full-grown adult, but it can occur sometimes. There are consequences to incontinence, and skin breakdown with pretty significant wounds can occur. This can lead to infections, but it also affects self-esteem and health-related quality of life. And it can lead to social isolation and underemployment. So the consequences of incontinence are real, and they continue into adulthood. When we looked at the effect of incontinence on quality of life in adults, what we found was that when we talk of fecal incontinence, any amount of fecal incontinence is negatively affecting quality of life. However, when we talk about urinary incontinence, the more incontinence you have, the more it negatively affects your quality of life. Maintaining continence, however, is a tricky thing. You have to have a motivated patient with a good support structure. There has to be a person at home who can troubleshoot, whether that's the patient or a family member. And you have to have a team who can troubleshoot in the clinic, really knowing that if continence changes, what else has changed? Are they not getting their catheter shipped to their house? And always as a surgeon, making sure that the patient has an excellent way to empty. Is the catheterizable channel kinked now that their body has changed? Do they have some dilation? Do they have narrowing at the skin level? We know that fecal continence also changes over time in patients with spina bifida, but I'm not going to spend too much time on that, as I'm sure this is something that others think about much more than I do. But beyond the urinary tract, we have to think about the long-term goals and needs of these patients in regards to sexuality, sexual activity, and what their reconstructive goals are. We know that sexual function includes many things. It includes desire, motivation, arousal, and orgasm. And all of these may be affected in patients with spina bifida in varying degrees. We looked at the sexual activity, function, and desire of adults with spina bifida. And what we found was that they think about sex probably more than you would think they think about sex. So when we look, we know that their sexuality and sexual activity can be affected by many things that are associated with spina bifida, including their inability to ambulate and changes in cognition, but also incontinence and self-esteem and independence. Many of these patients live with their families, so they have lack of privacy. Men, we have interest in the opposite sex and sexual desire, as do women. When we looked at sexual education and activity, we found that patients wanted to know and learn about sex, both from their parents, but also from their physicians and healthcare providers. And Dr. Roth and Anne-Francois Spino and Dr. Hobecki looked and found that adolescents and young adults with spina bifida did not receive adequate education associated with sexual activity. And this becomes important not only for them to understand sex and sexual activity, but also to be aware of what is inappropriate sexual activity or sexual advances, things like rape, that we know that people who have disabilities are also more apt to have happen to them. When we look at men and their sexual activity, we know that the patients that we surveyed, many of them masturbated, and about 75% had partnered intercourse. These patients were more likely to be ambulatory and living independently, however. We know that erectile dysfunction affects 3/4 of men with spina bifida, and this also, this study noted that most patients with spina bifida had some impaired sexual development. And as we go on, we know that urinary incontinence is more common during sexual activity than in the normal population, but fecal incontinence can also occur. When we looked at the quality of erections, 40% of the people that we surveyed reported normal erections, but most of these people were patients who were able to ambulate. And so it's likely related to the level of their lesion. Ejaculation is also affected. And even in our study, we found that most patients reported their ejaculation as dripping rather than orgasmic. For erectile function, sildenafil seems to work quite well to improve erections. And in just over half of patients improved intercourse. Other modalities have been described, such as the Tomax procedure. However, this is pretty limited in that you have to have some intact nerve function. Paternity can occur in patients. However, those are the patients who have lower lesions, lower than L5. Switching gears a little bit to women, we know that genital sensation and orgasm is also level dependent in women. and that orgasm is rare in patients who have lesions at L2 or above. We've studied pregnancy quite a bit, particularly in patients who have had reconstructions. But in general, we do know that about 4% of offspring of patients will have spina bifida, and therefore the amount of folic acid recommended for these patients is quite high at 4 milligrams. I usually recommend preconceptual counseling to most of the patients. These patients have high-risk pregnancies because of their physical deformities and their VP shunts, as well as their prior surgeries. And we know that they do have quite a bit of effect on their urologic function with worsening hydronephrosis. Hydronephrosis, that's much worse than that in the general population, and potential injury to their reconstruction. When we looked at patients who had reconstructed bladders, we found that their hydronephrosis was quite impressive, and in about 46% of them, we had to put nephrostomy tubes in. They had urinary complaints that included inabilities to catheterize. And when Courtney Struer-Shepard looked at pregnancy in mothers with spina bifida, what she found was that these women were much more likely to have cesarean sections than the patients without spina bifida. And that's probably related to some abnormalities of the pelvic floor musculature that make pushing difficult. When you're doing cesarean sections in patients who've had reconstructions, it's kind of like walking into a bunch of landmines because they're all over. There are VP shunts there. There may be artificial urinary sphincters and slings. They may have enterocystoplasties that have vascular pedicles that can be injured. And they can also have channels that can be cut through. So it's our preference to be involved in these cesarean sections in patients who've had reconstructions. We work very closely with the maternal fetal medicine docs and the OBs here. And we kind of work together to identify what the structures are and step away when it's time for them to deliver the baby, and then make sure that everything is looking good. But even doing that, we have had our fair share of cystotomies and uterine ruptures, as well as delayed fistulas. So something to consider when these women are getting ready to deliver is to be available. These are some of the cute babies I've helped to deliver over time, and there are many more than these. But moving on from that happy occasion of being pregnant and having a baby is the fact that these patients do get sick over time. And if you look, all the rates of diseases in the study that Greg Liptak did are all higher than in the general population of patients where they could find numbers. So certainly much higher use of the healthcare resources that we have. When they looked at hospitalizations, about 10% of the patients that DiCiano and his colleagues looked at were hospitalized with UTIs. This is a telling cover of a program that I went to for one of my adult patients with spina bifida. And this is what her parents picked out for when she passed away suddenly and in her sleep, not of urologic disease. So I think that even though we do our best, that the families still really feel the enormous burden of spina bifida on their children's lives. When DiCiano again looked at death rates in 2004 to 2005, about 2.5% were related to renal failure, with most others being related to sepsis. We then looked at our deaths among patients with bladder augmentations. We found that 8 of 369 patients had died, and 4 of them were related to urologic disease. So pretty much on par with what we later saw in a multi-institutional group that looked at deaths in patients with spina bifida, where about 10% died of urologic disease. In summary, I think that taking care of children with spina bifida is certainly easier to do than taking care of adults with spina bifida. And I can say that with confidence since I do both. Parents do most things for them, and it's our job to get them to start to learn how to do some things for themselves. Being an adult with spina bifida is difficult. It's difficult to get around. It's difficult to find healthcare. It's difficult to find a job and to stay engaged in the community. And we know that follow-up is essential in these patients. And as a medical community, we should really work on trying to see what we can do in our individual communities to help these patients, because it's clear that we have different needs in different parts of the country and different parts of the world. I think the essentials are always the same, though: to protect the kidney, to protect the reconstruction, to make sure that the bladder augment that you did is not full of stones, that the patient is able to catheterize without difficulties. It's important to remember the quality of life of these patients, and that we can't measure quality of life based on our own personal values, but rather have to do it in a very disease-specific manner. We can't forget about sex. It is almost on everyone's mind. We have to remember that these patients will become sick and may die younger than expected. And from a urologic perspective, it seems that we've made some improvements in their care, and we obviously still have some room to improve further. But most importantly, we have to remember not to abandon our patients. Whether you have to take the lead and continue to care for them, or you find someone who is able to care for them in your community, or you train the person who's able to care for them in your community, I think this is essential. So I want to thank you all for your time today, for the opportunity to talk about something that I am very passionate about, and really to keep in mind that any little thing that we can do to help these patients live longer is greatly appreciated, not only by them, but also by their families. And so I thank you all, and I hope that you have a good rest of the meeting and a great weekend.
Rosalia, thank you so much. An amazing delve into some of the really complex aspects with these patients. I suppose one question that I had was, one of the challenges that I've found since moving to the States is that pediatric hospitals here do offer really excellent multidisciplinary clinics. And then when you come to try and move these patients into an adult sphere, it's much more difficult to replicate that. How have you solved that in Indiana?
We solve it sometimes temporally. We get a great team together. We get the physiatrists and the neurosurgeons and the urologists together, and then inevitably someone leaves and moves on, and it's very difficult to find somebody who has a similar interest or time. And so sometimes it's a moving target, but it's really getting out there and identifying patients who have the same passion that you have. And it's a challenge, and it's a challenge because, as we all know, multidisciplinary clinics are difficult, right? It's coordinating lots of busy people together in one spot. And sometimes having some downtime where, you know, you're waiting for somebody to be done with something else. From I know from a fiscal standpoint, it is difficult for some people to support it as well. So it certainly is a challenge, and I wish that there was a group of people that you keep engaged at all times. But you know, we still struggle and kind of try to put it into people's ears that, you know, how great it is to do this work, and sometimes you win and sometimes they leave.
Yeah, I agree. I think it comes down a lot to individual legwork and getting people interested. And I think it was Hadley Wood said that she'd offered a lot of kind of favors and support for colleagues that she wasn't sure whether she'd be able to repay in her entire lifetime, just to kind of keep the clinic and everything going. Thank you so much.
I have just a quick comment. It's not necessarily a question, maybe a comment and a suggestion, because you briefly touched that depending on the lesion level, you will have different sexual function. And I think we owe for the spina bifida community better stratification based on their lesions, so we can predict the future for those patients. We are part as a colorectal team in the spina bifida multidisciplinary clinic, and I always like to meet patients, moms during their first visit and predict. So our expectation is that your child will not have bowel control, and those are the steps that we're going to follow. But I think we own the community. I cannot predict what patient, and some patients do have bowel control or function as having bowel control because they stool once a day in a predictable time. But I still could not pinpoint which patients are this. Of course, the ambulatory ones are the ones that do better for everything because their lesion is very low. But I think we as a community treating patients with spina bifida should categorize that so we can better advise families and patients.
Absolutely.
Well, thank you very much for the lecture.
Thank you so much for having me, and congratulations on this endeavor.
Great to see you. Thank you so much.
Thank you. Bye-bye.
So we move on to the next part of our program, and I seem to have the privilege of welcoming a lot of people today. I'm very grateful to friends and colleagues who've offered to give their time as part of this meeting and to make it what I think has been so far and will remain a comprehensive overview. Gunther de Vin was my fellow in London. I quote him often because he during one of our very complex redo revision surgery said to me that there wasn't much point in reading an anatomy textbook before coming to work with you. I don't think that was a slight on my surgery. It was a recognition of the complexity of the situation. But Gunther and I have maintained a long-term collaboration. He works between now Antwerp and London. It's always a pleasure to hear him talk and a delight to collaborate with him. So Gunther, welcome.
Thank you, Dan. Thank you for this very fantastic introduction. I'm in Denmark at the moment where my PhD student just defended, so not in my usual habitat. Sorry for that. I hope you can see my slides at the meantime.
We haven't got them yet, no.
Okay. That's strange.
Did you select share screen down below?
Yep, I clicked on share screen.
Okay.
And I clicked on the green button and I'm sharing them now. Do you see them now?
No.
No.
On the screen that comes up, if you click on your slide presentation, and then on the bottom right-hand corner, there's another share a blue button thing. If you hit that, then it will share that.
I did do that as well.
Okay. Huh. I have no idea then what's going on. Can you try it another time? Give it one more shot?
Yep, I can do that.
Do you have your presentation open?
Yeah, the presentation is open.
Okay.
share.
There's a continued problem. You can email it to me, and I can put the slides up if you want to.
Yeah, I will do that because this is a.
So if you send that to my Children's Colorado address, then I can open it up.
Yeah, sorry for this struggle because it worked before. Does it work now?
No, it's the same thing.
No.
Okay, sorry for this, for the bother.
So you're coming down and selecting share screen, the green thing at the bottom, correct?
Yeah.
Okay, and that brings up a new screen. And then among that screen, you'll see a presentation to select.
Yeah, is there another presentation ready already that can start now?
Could we ask Dr. Della Torre if he would mind giving his talk while Gunter sorts out his technical glitch?
I can do that then.
Would you mind?
No, don't worry.
I'd be very grateful. Thank you so much.
Yeah.
Gunter, yeah, let us know when you're sorted.
Okay, so it is my pleasure to introduce my partner, Dr. Luis de la Torre. He helps us manage this population of patients with anorectal malformation, Hirschsprung disease, idiopathic constipation, spina bifida, and he will be talking about a very important portion that is the bowel management for these patients. So Dr. de la Torre, welcome.
Thank you, Andrea. Okay. Can you see my screen now?
Yes, we can.
Yes.
Thank you, Ray. So, good morning and good afternoon, everyone. We have to talk about a very, very important portion in the treatment and management of this patient, which is the bowel management. I always said that when a patient born with imperforate anus or Hirschsprung disease, we have a very nice time in the OR trying to fix these patients, doing the repair. We enjoy the surgery. We can spend sometimes 2 hours. Sometimes we can spend probably 12 when it's a complex case like a patient with cloaca. But this time is very short because at the end, the patient is going to have, most of these patients will have bowel problems. So, and these problems are not just 2 hours or 12 hours, are forever. So the bowel management in reality is the most important treatment after the repair of these conditions. So we can see patients with different bowel problems, including patients that born with imperforate anus in all the spectrum of this malformation. Hirschsprung, unfortunately, every day we are seeing more patients with Hirschsprung with fecal incontinence, patients with neurogenic bowel due to spina bifida, caudal regression, trauma, etc. And we have, at least in the United States, a pandemic problem that I call the idiopathic constipation problem. Every day we have more and more patients with idiopathic constipation, complicated with fecal incontinence. And we are going to talk about more about this issue. So bowel management is not just for patients with spina bifida, it's for all patients that are born with all of these conditions or the acute condition that is the constipation or idiopathic constipation or functional constipation, whatever you want to call it. The problem starts at any age. So we have patients that we need to do bowel management when the patient is an infant or a newborn. The patient is in the scholar age, teenagers, and adults, as we can see at the end of this conference. So bowel management, in our opinion, in our philosophy, should be started as soon as possible. We don't have an age to start bowel management. Once the patient starts to have problems, we need to start to do the bowel management. In other words, we already know that a patient that was born with a rectal bladder neck fistula, sacral agenesis, and then we close the colostomy when the patient is 6 months, 7 months, 8 months, 1 year of age. This patient is going to have frequent bowel movements. Unfortunately, these patients are treated like diarrhea, chronic infection, intolerance to lactulose, intolerance to proteins. We already know that these patients have fecal incontinence with hypermotility, most of them. And these patients need bowel management, even when they are 1 year of age, because they have the most severe diaper rash that you can see. This is the main the target organ that we are going to treat in our bowel management. This large bowel or the colon, as you already know, they have several portions. So you can see here the left, the transverse, and the left colon. The two most important segments in humans are the rectum and the sigmoid. The rectum and the sigmoid are the natural reservoirs for poop. So it's the same. You have a bladder, so the bladder is the natural reservoir for pee. So you can pee 3, 4, 6 times a day if you have a normal bladder function. But if you don't have a good bladder function, you can have 20 times pee a day. The same thing happened in these patients. Patients that were born, for example, with Hirschsprung, they lost. We have to remove the rectum because the rectum is always affected. But anyway, the colon is very, very important in this situation. So we need to know what is the function of the colon. So the colon has 3 elements that you need to know. Number 1, everybody talk about the sphincters. So some patients have weak or almost no sphincters. And everybody says, oh, this patient is going to have fecal incontinence. This patient is going to have accidents. And in the opposite side, we have patients with a perfect sphincters. They can have beautiful anatomy, and we can assume that this patient can have fecal control. The second one is the sensibility. If the patient born without sacrum, probably with any other anomaly, myelomeningocele or whatever, this patient can lose sensibility to feel the urge to defecate or the sensation, the delicate and fine sensation that we have to discriminate between gas, solid, liquid, pain, etc. in the anal canal. And the third one is how fast or how slow is the colon. So the motility of the colon is very important. A normal colon is usually like this colon that is driving, I want to say 55 miles per hour in a good freeway. Usually this colon is going to have 1 or 2 bowel movements, usually after a breakfast or dinner or lunch. Usually the patient is clean, and that's the normal motility. Some patients have a very fast colon. The colon moves faster than usual. There's a speedy colon like this one. So this colon runs like 150 miles per hour. And there are another group of patients that they have a very slow colon. So the colon can have a bowel movement every 10 days, every week, sometimes every 2 weeks. So this is very important in order to understand the problem of this patient. If we consider the sphincters, the sensibility, and the motility, you need to know that the most important is the motility. If you have a racing car, a Formula One car, running 250 miles per hour, and you have the best sensation and the best sphincter, you will have involuntary bowel movement. In other words, you will have a bowel movement when and where is socially inadequate, even when you have a perfect sphincters and great sensibility. So the motility is one of the most important things that we need to evaluate before we start a bowel management. And when I said we evaluate the motility, we are not doing manometries. We have thousands of patients with fecal incontinence and constipation. Most of them already have motility studies like manometries, and at the end, the patient continue with the same problem. Fecal control is a very important concept. Fecal control is when a human can feel the urge to defecate, and then he or she can hold this bowel movement for a decent period of time. I want to say minutes. He can go to the bathroom. If the bathroom is occupied, is busy, they can find another bathroom in another place, or they can hold it completely. If they are in a airplane, they can hold the bowel movement until they go to the hotel. This is 100% fecal control. And we have patients that they have very good colons, very good sphincters probably. They have sensation, but they cannot hold any bowel movement. Even though they can say, I can feel when I need to poop, but they need to have the bathroom right there, close to the area where they live. So fecal control is on a spectrum. It's not just 0 or 100%. So some patients can have 20% fecal control, 50% fecal control. But even though when this patient had 50% fecal control, the other 50% produce accident. And this is the main problem. Now, with these little cartoons, I want to show you the problems that you can treat with the bowel management program in adults. Patients with constipation. Constipation is primarily a motility problem. So the patient can have a lot of stool in the rectum, the sigmoid, and the left colon, or even when he's sweating and straining and trying to have a bowel movement, you can see here there is nothing. Patient cannot have a bowel movement. Usually these patients have a big rectum and a big sigmoid. The other group of patients with constipation, usually patients that they have a lot of stool accumulated in the rectum like a fecal impaction or hard, big and dry balls of stool here. And they have, for example, you are giving polyethylene glycol. These are going to produce liquid stools. And these liquid or soft stool are going to pass around and produce real involuntary bowel movements. So the patient is going to poop anytime, anywhere. And we call this pseudo-fecal incontinence, which is a fake fecal incontinence. Because once you do a clean out of this portion of the colon, the rectum and the sigmoid, Now the patient is constipated. Now you can treat the constipation, but no more accidents. That's why we call this pseudo-fecal incontinence. Patients with true fecal incontinence are two groups, big groups. One is a group of the patient that the colon moves very fast, a very speedy colon, and the patient cannot hold the bowel movement. So we call this true fecal incontinence with hyperactive colon, or a patient with true fecal incontinence with tendency to diarrhea. And the last group is the same, is the true fecal incontinent patient, but the colon moves very, very slow. And we call these patients with fecal incontinence with hypoactive colon, with hypomotility, or with tendency to constipation. How can we define every group that you can see here? With experience, with the history of the patient, and the most important, with the contrast enema. Our philosophy to do a bowel management is to spend at least a long week. We call it the long week because we start on Friday and we end Friday. Before Friday, we perform many studies. If the patient needs an MRI, if the patient needs a contrast enema based on the history of the patient, we do the studies 1 or 2 days before. On Friday, the workshop or the education session is very, very important. If you don't provide education to the patients, to the families, you are not going to be successful. You are not going to have good bowel management in this patient. Patient needs to know everything about bowel management. And you need to be very honest with this patient. Sometimes surgeons, we don't want to say, oh, I did the perfect operation, I did the perfect pull-through, but because he was born with a rectoprostatic fistula and the sacral ratio is 0.1 or whatever, now the patient is fecal incontinent, because the surgeons believe sometimes that fecal incontinence is because they perform a bad operation. Even when you do the most beautiful and perfect operation, some patients will suffer fecal incontinence. And you must say to the parents, your child is going to be fecal incontinent. So that's why we give a lot of education before we start our bowel management week. Then in the afternoon, we have clinic, and we start with the plan based on the diagnosis. The patients practice this treatment for 3 days, Friday, Saturday, and Sunday, and Monday we have an x-ray. And then in the afternoon, we can have clinic, you can have a phone call, you can have telehealth. You need to have a communication, direct communication with the patient, and explain the x-ray and explain what happened and discuss if the patient was clean or have accidents, etc., etc. And then the same thing happened Tuesday, Wednesday, and Thursday. At the end, on Friday, usually the patient is clean, has bowel movements with laxatives or enemas, and then we discuss the plan for the future, if the patient is going to need a malone, if the patient is able to use laxatives for many years, etc., etc. So the most important in the bowel management, and I'm going to repeat this several times, is you need to spend a lot of time with the patient every day, at least during a long week. That's why in many places they don't do bowel management, because the surgeons are very busy like us. But we dedicate 1 week doing bowel management, doing this conference and doing operation, trying to help these patients. The contrast enema is a key study in these patients. If you have a patient with a huge rectum and the history of constipation and the history that was born with an imperforated anus like rectoperineal fistula, probably this patient is going to need enemas for days or weeks before we start a laxative trial. And a big enema. If you compare this rectum in another patient also that was born with perforated anus, you can, since now you can say this patient probably has fecal incontinence, or if the patient has constipation, he's going to need at the beginning a very small enema. Bowel management is a trial and error. It's not a scientific treatment. We are not going to do a treatment of an UTI based on the urinary culture where E. coli was grown. No. Trial and error is the base of this program. So to be successful in this program, you need to have experience, you need to stay with somebody that have experience doing this program to learn how to adjust every day your treatment. That's why it is not working if you do, I want to say an enema, and you say, okay, you are going to do an enema like 300 of the saline, 20 of glycerin, and see you in 1 month. That doesn't work. We received many calls saying that, for example, Dr. De La Torre, I have a patient with a rectovestibular fistula. The patient now is 18 years, 20 years. She cannot have a bowel movement. She has a lot of constipation. What enema is for this patient? She's 20 years and is 45 kilos. That doesn't work. We cannot prescribe by phone this enema because we need to know how is the patient, how big is the colon, et cetera, et cetera, et cetera. The X-ray is the only way to know if the trash container is full of stool or is empty. You cannot do a very good evaluation of the residual stool after a bowel movement. The X-ray that we use is an abdominal X-ray, AP, one view. And the idea of this X-ray is to obtain this image after a bowel movement with the laxative or after the enema. The X-ray before an enema, the X-ray before a bowel movement is not useful. The idea of the X-ray is you prescribe your bowel management, your program, and then you need to see the result. The goal is if you prescribe an enema or a laxative and the patient has a bowel movement, you cannot have this type of image because this patient has a lot of residual stool. So this patient needs an adjustment in the bowel management. So if you increase the laxative or you increase the enema in this patient, then the next day you have this X-ray, which is completely clean, and the patient is not having an accident. That's the perfect amount of laxative or the perfect recipe of the enema. And this happens every day. We adjust every day during a week. Usually Wednesday is when all the patients are very good. We found the amount of laxative or the adequate enema for every patient, usually on Wednesday. This is an example how to prescribe the laxative. For example, you have a patient with constipation and fecal control. You need to give 4 tablets of the laxative. We use Senna. So you give 4 Senna. So the patient has excessive response, so has many bowel movements. Then you have a patient with an adequate response. The patient had good bowel movement and the X-ray is clean. And the other patient has insufficient response. The patient has a lot of residual stool or no bowel movements. What happens if you have an excessive response? Okay, it's very easy. You go down to 3 squares, and then you can have the 3 possibilities. If the patient has an adequate response, you need to continue with the 4 squares. It is very easy. If you have insufficient or no response with 4 squares, the patient needs an enema and you need to increase to 5 squares. And again, a re-evaluation with the 3 possible responses. So this is the chart how you can find the amount of laxative in these patients. We never prescribe laxative based on the age or the weight of the patient. The enema, the rectal enema, is very important, and you need to learn how to do the enemas. I'm not going to spend time doing this. We have a lot of videos in our channel and on YouTube, but I want to stress something in this diagram. This is a step-by-step how to do an enema. The most important is you need to use a catheter that has a balloon, a big balloon, not a 5 or 10 cc balloon, a 30 cc balloon, to create a plug here and avoid leakage, and then run in 15 minutes the enema. The position is very important. How to place the patient, you need to take advantage of the gravity, depending on the age. In adults, we use this position, the pelvis elevated. If the patient is going to need enemas for the rest of their life, we usually talk with the family or with the patient, if he's a teenager or an adult, and we suggest to create an AC, an antegrade continent enema procedure. This is an appendicostomy. You already hear about that yesterday. So we place the appendix in the belly button and we create like a valve implicating the cecum. If the patient already had an appendectomy or was used for a mitrophanol, we can create this flap of the colon. We do the conduct, or we tubularize this conduct, and then we fold and create the valve to do the neo-appendicostum. And this is the aspect of a neo-appendicostum. When the patient is, we decide that the patient needs an enema program, and you have different options. Number 1, the rectal enema. Number 2, the antegrade enema or the flushes. And in order to do an antegrade enema, you need to do an appendicostomy, neo-appendicostomy, a cecostomy, and you can place a J-tube or a low-profile button or just a straight cut in the cecostomy. And the other system that works for many patients is the Peristeen anal irrigation system. This system works for some patients, is expensive. We use in few patients because the insurance doesn't cover this system. And how to create an enema. This is the most important slide for you. The most used solution that we prescribe is saline solution. We don't use tap water. You can use tap water. We have patients that they use tap water, but some patients that they use tap water, they have many issues with the tap water. We want to use a isoosmolar solution, which is the saline solution. You can use between 150 to 100 to a liter, sometimes more. This is just number that we can suggest. And if the patient has a slow colon, you need to give an irritant. The most common that we use is the glycerin and the castile soap. In severe cases, in cases with a severe hypomotility colon, patients with a very, very slow colon, we can add a small amount of phosphate or bisaccharide. So you can mix whatever you want, but the saline is going to give you the volume. If the patient has a small rectum, you can use 200 to 150. If the patient has a huge rectum, he has a true megarectosigmoid, you can use 500, 800, or 1,000. And then you can mix the glycerin with the saline. If you have weak response with the enema, you can increase the glycerin. So you are doing 250 of the saline plus 10 of glycerin, and the patient has a weak response, and the X-ray shows residual stool. You can do 250 and 25 of the glycerin, and then the next day you need to see the response of the patient and the X-ray. If the X-ray is clean and the patient is not having accidents and he has a good bowel movement, you already found the enema recipe for this specific patient. So what patients they need to go to an enema program. Usually patients with fecal incontinence and slow colon. This usually happens in patients with neurogenic bowel. Patients with spina bifida, usually they have a non-dilated colon, but the colon moves very, very slow. So they have the advantage that if you give a good enema once a day, the patient is going to be clean 24 hours. Sometimes it's so slow, the colon, that the patient needs an enema every other day. So it depends from patient to patient. Patient with idiopathic constipation, long-standing chronic constipation, we give enema to this patient for days or weeks until they realize that they can have a daily bowel movement, and then we move the patient to the next step, which is the laxative trial. We never start a laxative in a patient with long-standing constipation and fecal infaction. Then the laxative trial, when we decide this patient came for bowel management for laxative trial, we call laxative trial because we don't give a specific amount of laxative based on the problem, age, gender, or weight of the patient. It's completely different from patient to patient. And then the last one is the enema program with loperamide. It's patient with fecal incontinence and fast colon. Is when we use the loperamide. Finally, to give an enema or laxative, you need to spend a lot of time explaining to the parents. It's not easy. Sometimes we need to fight with the patient to give an enema, but sometimes it's the only way to keep the patient clean. This is an 83-year-old male that came to our bowel management with idiopathic constipation and pseudofecal incontinence. He saw for 72 years different providers, used many laxative and diets. He was doing 1 or 2 enemas a day. And finally, he came from Hawaii. And in a week, we found that he was having a good bowel movement, no accident, taking 5 tablets of Senna. He never used before Senna. And he said, "You changed my life and my family life." This is our oldest patient in our program. Thank you very much. If you have any questions, you can type in the chat, or you can send me an email, luis.delatorre@childrenscolorado.org.
Thank you so much, Dr. De La Torre. This is a very, very important topic. There are several questions in the question and answer. I think if we can answer them online, Dr. De La Torre will do that so we can move to the next talk. Dr. Wood, do you want to introduce the next speaker?
Absolutely. Thank you so much. With technical glitches and things, we're just swapping the program a little bit just to accommodate everybody else that's got to do stuff after the timing of their talk. I'm really grateful to Pete Herbecker from Ghent for giving up his time to talk about an area in which he's internationally renowned, male genital reconstruction. He's done a huge amount of work relating to this, and so we are, of course, fascinated to hear your talk. Pete, thank you so much for joining us.
Okay, thank you, Dan. I hope you can hear me. It's okay. You see my slides also. Okay.
We're not on presenter's view yet, so you might want to switch your displays if you can do that.
Oh my God.
At the top of your screen, you should get the option. You'll see 2 arrows pointing in opposite. That should switch your displays.
If not, this way works too.
Okay, I will take this way. Okay, thank you.
Here we go.
Thanks again for the invitation. I'm very glad to be here to run a presentation of the title Options for Male Genital Reconstruction in Adolescents and Adults. And I will mainly focus on phalloplasty, but phalloplasty in a wider sense than just creating a new phallus. I have no conflicts of interest. So phalloplasty, phallo means penis or phallus, and plasty is repair or restoration of a part or function, molding or shaping. So phalloplasty is surgery of the penis to repair injury, replacement of an absent penis, like in sex change. The word was first used by Sprengler in 1858 to describe the reconstruction of a penis after degloving after trauma. So what I'm going to take you through in the next 30 minutes with less is an introduction. I will explain you indications and techniques. And at the end, if we have enough time, I have a short video about the procedure of a phalloplasty. First of all, good primary care of underlying congenital pathologies should avoid future need for phalloplasty. That's something I realized in my career. Many of the phalloplasties I do in cis male patients are really not necessary if they would have taken the care from the beginning. Of course, there are some patients who will need it anyway, and male gender assignment in males with extreme small penis, like in Coextrochy or some 46XY DSD conditions, is more feasible with phalloplasty. Always remember, if a patient needs a phalloplasty, try to provide them a good-looking, sensitive, and erectile structure. And the question will be, do we reach these goals? This is what we have to avoid. This is a cripple extrophy. Maybe it looks okay, but this boy had no corpora anymore. The corpora were just destroyed by the primary closure. So we had to do a phalloplasty. This is what we have to promote. This is a boy with a cloacal extrophy who was nicely reconstructed in the primary time, but had, of course, no phallus because it's very small from the beginning. And we ended up doing him a phalloplasty from an ALT flap. So once again, if a patient needs a phalloplasty, provide good looking, because I've seen terrible results of phalloplasty too, sensitive and erectile structure. Unfortunately, in the world, there are many, many patients with a disastrous situation after surgery. I don't going to read these emails. I can tell you on a weekly basis, I receive emails with desperate stories of patients that have no penis. And one of the issues there is that there is not enough care providers who do phalloplasty, and that will be at the end of my talk, one of the questions. Please let us have more centers to do it. And the techniques, first of all, you should always consider to do I call it here a penisplasty, but it's also actually a phalloplasty. This means with the tissues available, try to improve the situation. If that's not possible, then you go to a phalloplasty with either a radial forearm flap, anterolateral thigh flap, or some other. And the decision, I will go into that during my lecture, but the decision mainly depends on the anatomy. This is an example of what we call a penisplasty. This is a maybe not so nice situation after primary epispadias repair, but this boy had a corporal body. So one of the tricks that I always use is Z-plasty on the prepubic area, which gives you much more skin to bring the penis in a better position. Look at the good reconstruction of the penopubic connection and also the penoscrotal junction, and then you can reach reasonable results. This is another example where after dissection, it looked like we had not enough skin, and when you don't have enough skin, then you can consider taking a skin graft. And skin grafts, you should take them really split thickness skin graft. You can mesh them, but the mesh should be one-on-one because you have different types of mesh, and that works really well. So the surgical principles of penisplasty in my hands are increase prepubic skin with Z-plasty. When you're there, remove all scar tissue that's there from the primary surgeries. In reconstruction, reconstruct the penopubic and penoscrotal angle, and in case of shortness of skin, have STG skin graft available. At the end of the day, you always have a normal functioning short penis of your own. Then they have to give you a phalloplasty, which is look like and function like a penis, but will never be a penis. And therefore, often in those patients who still have erectile tissue and still have some possibilities to develop these, we will always first propose to do what we call penisplasty, which is also phalloplasty. If we're going to take a flap, and in our center, we typically use radial forearm flap, which is a free flap, or we're going to take an anterolateral thigh flap, which is a flap from the thigh. Well, the vessels are determining which we will use, and I come back to that later. This is just an example of the Chinese flap, which is the most used. I will not go into the details, but if you need a urethra, which is not often the case in those patients, but because they often have a Mitrofanov, it's the principle of a roll in a roll. So you make the urethra from the skin from the arm, and you turn the other skin around. Just some examples. This is on the arm. With this will be the urethra, and this will be the reconstruction around the urethra. Here is another example of the penis, the phallus reconstructed on the arm, because it's connected with the vessels before the transplantation. And for us, it's really the standard technique, because it's much more reliable for nerve connection. It's much more reliable for later implantation of the erectile prosthesis. And it looks better in the way, because proportionally, radial forearm flaps are better than anterolateral thigh flaps. You will see some examples later. One issue is the donor side morbidity, because when we do these surgeries, we take it from the arm. This leaves us with a big scar. We have a big cohort of patients, actually today more than 1,000 trans men in whom we did surgery. So we have a lot of material to rely on. But you can have quite good results. Some patients will put a tattoo on it. This is a recent example. Sometimes you have hair growth on the flap. You will always see there is no hair, because we miss the hair, because this is covered with a split thickness skin graft. The ALT flap is for those patients who don't want a scar on the arm. You need to have enough skin on the thigh, because it's really an area, it's a very good flap. It's a thick flap. He has a good pedicle, has a good sensibility. However, it's very difficult to connect the genital nerves to it. Disadvantage, you have a scar on the leg. The flap is thick, urethra is difficult, and the flap transfer, you will see in the video, whichever. So this is a perforated flap. You can mobilize an island of skin on perforated arteries in the leg, and you should do a preoperative CT scan to identify that this is available, that perforated artery. So this is mainly the difference. If we do a free flap, then we're going to connect the vessels with the femoral artery, femoral vein. Sometimes we need some extra vein and artery to connect. This is essentially when you do an anterolateral thigh flap. So when the distance is too big, for instance, this is an extrophy, sometimes the distance between the pubis is too big and you cannot get the flap there, then you shift to a free flap and you cannot use a pediplated flap. Options for the urethra, if you need one, a tube within a tube is difficult. We have done tissue expansion. I'm not so happy with that. The prefabricated skin graft, which you push under the skin, not perfect. I think the best, if the patient really wants an ALT flap, is to give him a radial forearm free flap for the urethra. So you take another flap from the forearm and there, which you reconstruct the urethra. This is an example of an extrophy boy with a Mitrofanov. I think maybe it's here, the Mitrofanov. This is the flap taken for the penis, for the phallus. This boy didn't need a urethra. This is another example, and you see these ALT flaps, they look okay, but they're quite large. And my personal meaning is that a too large phallus is also cumbersome for some patients. So it's better to have a good proportionated flap. This is another example of an extrophy where we always, if we have sensitive tissue, we will include it into the phalloplasty. If we compare the two flaps, for ALT flap, you have no microsurgery. The urethra is difficult. The flap is rather thick, so the phallus becomes thick. There is no forearm scar. There is, of course, a scar on the thigh. And atrophy, which we sometimes see in radial forearm flap, is really rare in ALT flap. So that's an advantage. Radial forearm flap, you need microsurgery, an easy urethra, it's a thin flap, it's a forearm scar. You have another thigh scar because you need to cover the area in the arm, that is a split thickness, and you can have long-term atrophy. Sometimes we do lipofilling or we put the prosthesis. There are other flaps, the fibula flap, the groin flap, the abdominal flap, latissimus dorsi flap. And just to tell you something about the abdominal flaps, it's something that has been used by Roberto Di Castro for neophalloplasty in children and adolescents with acquired penile loss. I think this can be a good technique, but I can tell you that the abdominal flap applied in infants will probably not be sufficient when they become adult because there is no extra growth at puberty. And this is one of the examples of Roberto's patients, which I was assisted the first surgery in Bologna with him. And the patient came back when he was 19 years old and complained of having a short penis, hair bearing. So the length is 7 centimeters. The girth was okay, but we provided him with an ALT flap for which he is extremely thankful and extremely happy. So this neophalloplasty in infants, personally, I think if we can avoid it, we should avoid it. The major advantage is that the child can identify as a boy, but if you give good psychological support, probably this works too. You can do whatever you want. You can do tattooing. There is many tattoos now. There is also tattoos that tattoo a vein on a phallus to make it look more natural. This is some examples of phalluses that have been tattooed. And then for sensitivity, what we will do, we will typically connect two nerves. We will find an ilioinguinal nerve to connect. We will try to find the dorsal penile nerve in cis men or a clitoral nerve in trans men. Here you see, this is actually a clitoris, and here you see the dorsal clitoral nerve running here, and this is the one we will connect, and here you see a nerve connection. Of course, you should have a good idea of how the anatomy is in congenital anomalies. For instance, in extrophy, the neurovascular bundle is not running on the dorsum of the corpora, it's running on the lateral side, so you should look for the nerves on the right place to get the right connection. To give them an erectile structure, you have to do an implant, preferably. This gives good results. There are many. This is a very old implant, which is no longer on the market. It's called Dynaflex, but these are the modern. This is Ambicor, this is Spectra, this is the AMS, but nowadays we have newer systems. The problem with these devices is that they do not last very long. And these are examples of problems they have due to frequent use, because these are young men under normal testosterone with a high sexual interest who want to have frequent intercourse. And these devices are constructed for men with erectile dysfunction who are in their 70s or 80s and have minimal sexual activity, or some of them minimal sexual activity. You see, you have aneurysmas, you have everything. These prostheses are really not working very well. Long ago, we did the first review. I'm going to go to the Kaplan-Meier curves. And that's some real problem. You see that whatever type, we tried all kinds of prostheses, but after a few years, you will see that it's really a 100% failure. I must say, after 10 years, you have to start over again at 100%, especially for all hydraulic systems. We sometimes shifted to semi-rigid systems. This is an AMS Spectra, which we embedded into a Gore-Tex sleeve to put it into the phallus. This is a result in a trans patient who was very happy with that, but still it has also limits because often it doesn't fix very well to the pubic bone. There is a new prosthesis specifically designed for phalloplasty. It's from a Swiss company. It's working very well, but it has the same problems that it is not long lasting because of the hydraulic system. When you use it a lot, it will break down anyway. So which patients are good candidates? Cripple extrophies, bladder and cloaca, which we should be avoid, cripple epispadias. And for me, when you have 6 centimeter erectile length from yourself, you can better keep that and not have a phalloplasty. These are examples. This is just no corporal bodies, a little bit of glands, a very ugly looking urethra. Another example, just skin, no more glands, no more corpora in an extrophy boy. This already you have seen. This is another patient with no more corpora. I've seen many dramatic cases where I think personally, when they close the pubic bones in extrophy, they take the corpora in their suture and then the corpora will of course be destroyed. Other example, this person has a nice glans but had no corpora, crippled penis. And other examples, I have too many. I can go on for hours showing pictures of like these, which are of course to be avoided. This is situations that could have been avoided. Another example of this, and another example, and I can go on. And this one you have seen, this is the cloacal extrophy, and that's correct to do this. You try to do the best with the material you have, but if you are not successful, then you end up with the phalloplasty. We had some tumors. This is a very sad story of a boy with an epithelioid sarcoma who needed a penile amputation, in whom we did phalloplasty. A real micropenis can be really a good indication to do a phalloplasty. This is an example of a complete penoscrotal transposition, where in the first stage I did a correction of the penoscrotal transposition. Actually, this boy is now 19 years old. He still has this penis which is not functional, but he's still waiting to have his phalloplasty. He wants to wait longer. This is absent penis. This is due to a circumcision accident, and this is, of course, the penile agenesis. The patient you've seen, the result of Roberto Di Castro's phalloplasty. This is a boy I treated after gunshot. This is a terrible situation. He now has a phallus, but it's for the erectile device. We have no scrotum, so we have to give him a semi-rigid device. Electrocution can ruin your penis. Bad surgeons who try to do phalloplasty for micropenis can ruin your penis. This was a really bad phalloplasty. So when you should you do it? I prefer to do it after puberty or in adolescence, to talk with the patients. And boys must be able to explore their proper erectile and sensitive function so that we can keep all the tissues that are important for them. And never forget that growth at puberty can be important. And this is one of the cases that opened my eyes. This is a DSD patient, which we followed during a childhood, and he had a very short penis. And I already promised him that I would provide him a phalloplasty. But then at puberty, he started to increase length and get to 7 centimeters. And now he has a partner, he's very happy, so he doesn't need phalloplasty. And I was wrong, because I told before puberty that he would need a phalloplasty. Specific considerations: any erectile function should be incorporated, any sensitive glandular tissue should be incorporated, just like we did here, incorporate the glands, or just the same patient actually that we do. Here we have no glands, so we try to find the nerve. We found the nerve and we connected everything. This is the end result of this boy. Other examples, we have many. We did like 40 cases. This is a Colorectal with no penis, in whom we did an ALT. Of course, he had the Mitrofanov, so he doesn't need a urethra. And when you don't need a urethra, you can obtain a reasonably good result with an ALT flap. And this is another example of an cloacal boy actually with an ALT flap. Good. If I have time left, I will show you a very small video of 4 minutes about the procedure. I hope the sound comes through. Let's see. Is the sound okay, Gunther?
It is not playing for us.
Oh, the sound is not playing.
The video is not playing.
It will soon play.
Okay.
But I will give some information. Yeah. What can I do to just wait the surgery comes? So you see a 6-year-old biological male with colorectal, and we do an aterolateral thigh flap without ureteroplasty. So this situation, we will put the phallus there. So I excise the skin over there. This is corporal bodies we identify. So we try to find corporal bodies, corpus cavernosum. And he had a urethra, which we kept there for ejaculation, because he had to be Mitrofanov for urine. And this is the plastic surgeons taking that ALT flap. So you see it's quite thick flap. They try to find the arteries and the nerves. So here I'm dissecting I try to find the nerve in the penile structures. Here is the nerve, dorsal penile neurovascular bundle, and that will be connected with the nerve of the flap. Yeah, so the corporal bodies that are left here will be incorporated into the base of the phalloplasty. Here is the flap prepared. And now they're gonna, yeah. in this case, yeah, I remember, this was a funny case. We had to free the flap. So the ALT flap, the pedicle was too short. So we had to free it and connect it with the pudendal artery, and that was done. This is the nerves anastomose. Yeah. So no ureteroplasty, and for the ejaculation, you don't need a urethra. So this is microvascular stenosis. So you really should imagine this is an ALT flap, which is normally a pediculated flap, but as the pedicle was too short, we had to do instead of a free flap. So the external pudendal and dorsal penile arteries were anastomosed with the lateral femoral and circumflex artery. Happily, it went well with this patient, I can tell you. You see what's still there. So here we're gonna try to reconstruct the phallus. We don't do a granuloplasty at this stage. The granuloplasty, making the corona, we do this mostly 6 months after surgery, because especially when it's a free flap, the vascularization of the skin. Here you see the split thickness thin graft on the area of the thigh, which is then connected. So no ureteroplasty. We close the native meatus stays there. Yeah, this is probably hard to read. I'll stop it here. Gives you an idea of what we can do. So to conclude, I think we can offer a good-looking sensitive and erectile structure that looks and functions like a penis to males without a penis. The technique is exceptional for bladder extrophy as good primary surgery of voice crippled situations. It's standard for boys with cloacal extrophy raised as boys and for some 46XY DSD conditions. And what I said in the beginning, some centers of expertise are needed throughout the world, as I get many, many patients from everywhere in the world. So thank you for listening to me. Thank you.
Pete, thank you so much. I think we've got time for one quick question, which is in the Q&A. In terms of a forearm flap, how do you manage hair that might be on a flap?
Yeah, the hair in the urethra is, if you make a urethra, you can have hair in the urethra. So boys that have a lot of hair on their arm, first of all, we try to take the inner side. Yeah, you don't see that. The inner side of the arm has nearly no hair. That's the advantage. That's the area where you take the urethra. But if there is hair, you can do preoperative laser. If you don't have preoperative, if despite preoperative laser, you still have hair in the urethra, we put epilatory cream in the urethra with the boys with the full bladder. And then when they can pee, they have to keep it in for 5-10 minutes and pee it out. And then most hair is removed, because hair in the urethra is really a problem. It creates stones, it gives a bad smell. So avoid to have hair in the urethra, choose the right spot on the arm to make the urethra, preoperative epilatories, and if not, then do the epilatory cream in the urethra.
Pete, thank you very much indeed. A wonderful presentation. Really good to see you.
It was my pleasure, and I'm still in time for my next meeting. Thank you for Gunther. Thank you very much for letting me go in front of you. Thanks. Bye-bye.
Wonderful. Thank you. So I introduced Gunther earlier, who is a wonderful friend and colleague from London, works between London and Antwerp now, and he's going to talk to us about assessing male infertility. Thank you, Gunther.
Yeah, I suppose that you can see my screen now then?
Yeah, it's all good.
Okay, perfect.
Yes.
I'm very happy. The problem is that my computer started updating this morning, and my safety settings changed by the update, and I wasn't aware of that. So really sorry for that. So I'm happy that we can speak about male fertility today. This slide you probably have seen. I mean, the whole conference is so wonderful, and it's all about normality and what goes on in all these boys and girls who had a serious congenital anomaly. And having kids is part of their feeling like they want to be normal. This study was actually interesting. This is a study about patients with congenital anomalies, and they interviewed them. They gave them a camera and they could record their thoughts at home. And like all these patients, all of them, when they were recording their thoughts, all of them recorded something about fertility and having kids, not being sure if they could have kids. They were talking to their girlfriend about stuff, and she was telling me that I have to do some type of surgery or whatever to give her my sperm, because that's one thing about the disability. It slows down certain people's sperm count. I've known quite a few from the hospital school who have children of their own, you know, with surgery and stuff, but I don't know if I can do that or not. Well, no, I can do the egg, but I'm not sure if I can pass sperm or whatever. And these things are very important for our adolescents and young adults. But we have to be aware, and this is a Belgian situation, when we look at the general population and we see how many couples, healthy couples without any congenital anomaly, are actually struggling to have a kid of their own, it's quite a lot. It's 1 in 7 at Belgium, and these numbers are from 3 years ago, so maybe it increased already. 1 in 7 in the normal, healthy population. It's really a lot. And sometimes it's just the male, sometimes it's because of the female, and often it's both partners together that are the issue. And these numbers we have to take into account as well when we're going to discuss fertility in our adolescent congenital lifelong patients. And yes, to make a baby, to make an embryo, you need a sperm cell, you need an egg, you need these 2 gametes, and yeah, it will happen. That's the basics. But is it the basics? When we look at the WHO definition about infertility, they say that it's a disease of the reproductive system defined by the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. And that is maybe an issue in our patients as well. Regular unprotected sexual intercourse, actually, can they be sexually active? We had already a very nice talk of Rosalie before I started struggling sharing my screen. And we have seen there already in spina bifida patients, that's not always that easy. Because it's about the sperm cell, it's about the egg, but it's also about the erectile function. It's about the orgasmic function. It's about regular unprotected intercourse and about knowledge. That's also a very important thing. From the same article that I just showed, also this one is actually quite interesting. There are some people that can't get erections and there are some people who can, and doctors will never talk about that because it's like a forbidden thing. And then they say, those are just some ideas I'm thinking that doctors don't focus on, and they don't ask a lot of questions on that because it's not important to people, but it is for us because some of us don't know what it's like to do that. I know I can get semi-erections. I don't know if I can ejaculate. I have no idea. I don't know if I can have kids. And that might be the only way they can learn about it because some people are not comfortable about it. So actually, we have to ask them more questions. We have to discuss these issues with them. It is so, so, so important. Rosalie mentioned the erectile function and the sexual intercourse and things like that briefly already, and I'm not going to go in full detail. But yes, our patients do have erections. The bladder extrophy patients we recently reviewed, they have good erections. They have issues with the curvature, they have issues with the length, and the length is more important than the curvature for them, and that's very important to take in mind when we are going to keep on reconstructing them. It's the length that counts. And also, spina bifida patients have erections, and like Rosalie also said, it's dependent on their ambulatory level. But all of them are quite good responders to the BDA5 therapy if needed. We had a small discussion about categorizing these patients depending on the lesion of the spina bifida. Now that's quite difficult. It's much easier in spinal cord injuries to classify them, who will have erections and who will have not, especially when they have a full spinal cord lesion. But in spina bifida patients, it's very difficult because some nerves go through and others don't, and we don't know which kind of nerves are actually passing through. So it's very difficult. It would be wonderful if we could do that. Also, regular unprotected intercourse is important, but we often wonder, are they sexually active? Well, for bladder extrophy patients, we know that once they have a stable relation, and It takes years to reach that state because there's a lot of shame in the beginning. But once they have a stable relation, they have regular sexual activity. And we also recently reviewed the pregnancy rate in our patients. We reviewed around 64 patients. Only 13 of them tried to have a child. And from these 13 men, 8 succeeded, and this resulted in 15 pregnancies. And we are actually very surprised that only for one of these pregnancies, a testicular biopsy was necessary. So actually, they can have a good fatherhood, but not all of them will have. Some of them will have an issue. Sexual activity in our spina bifida patients, yeah, that happens as well, but they also start dating later. We have to take into account incontinence, as we heard in several other talks, because that has a negative effect, and also the age, the level of the lesion, smoking, and things like that, that will correlate with having sexual intercourses. But more important is the basics of the sperm and the sperm development. So here you have a microscopic image of how sperm cells are produced. It happens in the testicle, as we all know, in the tubular seminiferi. We have the spermatogonial stem cells, which are at the outer layer of this area, and to the middle area of that, the spermatids are developed. And this you can see here in this slide as well. You see the spermatogonium stem cells, you see the interstitial cells with the Leydig cells, where testosterone is produced, and you see that in the middle of the tubula, the sperm cells start appearing. So next to the arrow of the seminiferous tubuli, they are the stem cells, they are still diploid, and step by step we get haploid cells, and that are the sperm cells. Important is that the full process will take up to 64 days. That's one thing to keep in mind. And the second thing is that actually the maturation of these sperm cells only happens when they leave the testicle and come into the epididymis and the vas deferens. It's only then that they mature, which means that a sperm cell coming out of the testicle will not move. It has no movement. It doesn't move at all. And that's very important to keep in mind when we are going to think about assessing fertility. Apart from the anatomical development of the sperm cell, we also have to look at the hormones. We know that our hypothalamus is producing gonadotropic releasing hormone in a pulsatile way when our puberty starts. And then our anterior pituitary will produce FSH and LH. FSH will have an effect on our Sertoli cells, and there our spermatogenesis will appear. When the spermatogenesis starts, then we have a production of inhibin B, which will have a negative effect on the anterior pituitary. At the same time, LH is produced, which will have an effect on the Leydig cells. Those will produce testosterone, and testosterone will have a negative effect on the anterior pituitary and on the hypothalamus. And this negative feedback is very important to keep in mind, because it's not only about the hormones, it's not only about the sperm cells itself, but it's also how it's all regulated and how we can interfere and how we can diagnose. Not all our patients just have an open bladder neck or can't ejaculate, but in some of them we have a problem with sperm development as well. And these hormones will be very important to understand where the issue will arise, and we will come back to that a little bit later. Actually, when there is 6 months to 1 year of regular unprotected sexual intercourse and still these couples don't succeed in fathering a child, then a sperm analysis is quite important. And a conventional semen analysis is actually the way forward to start. In a conventional semen analysis, there are several parameters we look at, but mainly the concentration, the motility, and the morphology are the most important things we look at. And we are doing that for years, and every center is doing that. The problem is when you look at the value of a conventional semen analysis in predicting male fertility, and especially in predicting fatherhood, actually our conventional semen analyses, they only have a very modest value. It's very difficult to predict based on a semen analysis on its own. Newer tests like sperm function tests, like DNA fragmentation, they are probably a bit more important, but this is all quite new, and in our population, not many studies are done with DNA fragmentation. And they will tell us something about the function of the sperm. What we do know is that when DNA fragmentation is high, it will be associated with reduced pregnancy rate, and there will also be an increase in pregnancy loss. So these things we know, but we haven't done enough studies in our congenital patients. We have done a study in varicocele patients, and there we know that varicocele patient, young adult 10 or 5, compared to the healthy population, the conventional semen analysis is similar, and also the DNA fragmentation is similar, but that the peak retrograde flow in those patients will have a negative effect on the DNA fragmentation. But actually, to analyze that sperm sample, we need a sperm sample, and they have to produce it. And their hygiene, fresh sample, and it has to be complete. It has to be complete. We have to ask for it, because most sperm cells will come out in the beginning of the ejaculation. And like the third or the fourth shots are usually just some liquid, some fluid, which is coming out of our vesicles and things like that. So it's the hygiene, it has to be fresh, but it has to be complete. It has to be produced by masturbation, very important, and sexual abstinence during 3 to 5 days is also important to analyze a sperm sample. If the abstinence is too short, the concentration will be really low. If the abstinence is too long, the motility will be really bad. So that's the reason that we usually use 3 to 5 days. But masturbation is important. Do our patients masturbate? Yeah, this is the general population, a study we did last year when we were looking at associations between pornography consumption and male sexual health. 7,000 people participated, and then we see that actually people below 35, they masturbate quite a lot. It's like 70% does it several times a week. We did an observational study on our extrophy patients as well, and there you see that the results are actually quite similar. But for the spina bifida population, and this is actually very important for us to consider, when we do studies about sexuality and masturbation, we ask them if they masturbate, if they once did it in their life and things like that, and they all masturbate. They all have ejaculation? No, only 30 to 80%. But I didn't find any study that can go into detail to check how often they are really doing it, like we did in the general population and in the extrophy population. And I think that's important to know as well for the quality of the sperm. And the other thing is that there is serious lack of knowledge in these patients, but also for us, because we don't know very well how they are experiencing these things. Extrophy patients, it's more a matter of controlling the frequency of masturbation when you're going to analyze the sperm. Then it can happen that we want to analyze a sperm sample, and these patients have an orgasm, but only a little amount, and there are little to no sperm cells. Well, in many of our congenital anomalies, we have to deal with retrograde ejaculation because the bladder neck is quite open. And for an open bladder neck, then when these people have an orgasm, instead of the sperm coming out through the meatus, it can flow back to the bladder. That's what we call retrograde ejaculation. Few things we can do. We can prescribe them alpha agonists like pseudoephedrine, 60 milligrams, which they have to take 4 hours prior and 1 hour prior to collection or masturbation. Of course, abstinence, hygiene, and things like that are similar. And we can also use imipramine instead, because imipramine also has an effect on the bladder neck. It helps. It's not a perfect solution, but it can help let them ejaculate in a forward way. If that doesn't work, then we can try to retrieve sperm from the bladder. But urine is quite acidic, and that can kill the sperm cells. So we have to make sure that the bladder environment is quite hostile for our sperm cells. Same thing, abstinence, 3 to 5 days. And what we actually tend to do is give the patients 15 grams of bicarbonate the day before and on the day of collection. Then they empty the bladder, they drink a few glasses of water, and then they masturbate and produce a sperm sample and a urine sample, and then we try to look for the sperm cells and to filter them out in order to use them. This is our protocol. There are other protocols published, like for instance, the modified Hodgkin's technique. This is not what we are using in our center, but here they bring a special buffered medium into the bladder and they try to culture it afterwards. Anejaculation is another issue, and that we see more in neurogenic patients. The thing is that in these complete spinal cord patients, we know that neurostimulation will have good success to ejaculation if we use it in a kind of stepwise approach. And there's a lot of information about spinal cord injury patients, but not that much about our congenital patients. What we learn from patients with a complete spinal cord injury is that when they have a lesion above T10 and an intact dorsal penile nerve, then penile vibratory stimulation can work and can have a good success. But when the lesion is below T10, then we have to go ahead with electroejaculation because the effect of penile vibratory stimuli is quite low. The thing is, I'm not totally sure that all the lessons that we learn from spinal cord injury patients can be applicable to those spina bifida patients, and that's exact for the same reason that I earlier said, that these lesions are not always complete. And sometimes patients have more result and more effect than we would thought just based on the lesion. So the vibratory stimuli, the Verticare is approved for it. You can see a metal membrane here below, and that metal membrane will start vibrating. You can set an amplitude and you can set a frequency, mostly to start an amplitude of 2.5 and a frequency of 100 Hertz is used. Then they can put a membrane against the ventral side of the glands, especially where the frenulum is, at least if they have a frenulum. And usually they will ejaculate within 2 minutes. If they don't ejaculate within 2 minutes, just wait a bit and start again. Sometimes you need 5-6 cycles before it actually happens. You can also use 2 of these Verticares at the same time, one at the ventral side, one at the dorsal side. If the bulbocavernous reflex is intact, the success rate of this vibratory stimuli is much better. But I think it's important that we learn patients to work with it at the hospital, especially for the high lesions. It's important that we are sure that there is no autonomic dysreflexia. But once they are able to use it and there are actually no issues encountered, then they maybe can try it at home. Then you don't have the negative feedback, the cortical negative feedback, because they feel a bit ashamed to do this in the hospital. So we often lend these machines. We have a few in our clinic and we lend them to the patients to try it at home. Electroejaculation is another option. We tend not to do it that often. For that, you need general anesthesia. There is a special metal probe which is inserted into the anus, into the rectum, and then they put an electric current into it, and you need 15 to 35 stimulations. And then the ejaculation will happen, but it's important. I mean, if you look at the nerves that help with ejaculation, it's in 2 phases. If the men that are listening to, we probably know the point of no return, and that's actually when our ejaculation is going to happen. But the point of no return, when we feel that we are going to come, it's actually the emission of sperm in the posterior urethra. And then next, we have the contraction and the expulsatory sperm that comes out. That's the next phase of the ejaculation. What we have with the electroejaculation is actually the emission, and then afterwards the sperm will dribble out. And often it can also happen that they have retrograde ejaculation. So the protocol that we use for that will have to be applied here as well. And often we have to catheterize the patients to get the sperm out. So yes, there can be a problem with the ejaculation, can be retrograde, there can be no ejaculation. But sometimes we have fluid and there are no sperm cells, also not when we look for retrograde analysis. Well, we have to keep in mind that we have to assess our patients, because fertility in male, it's not only about the bladder neck, and it's not only about the erection, it's not only about having an orgasm. I mean, we can have sperm problems at pre-testicular level, testicular level, or post-testicular level. Yeah. Post-testicular level, it's easy. Patient with a vasectomy, that's a typical example. But of course, our patients can have had a chlamydia infection, which is also a reason for a post-testicular problem. And surgery in the past can also block a vas deferens or whatever. It's important to keep that into mind. There can be a testicular problem as well, like for instance, boys with Klinefelter or boys who had cancer when they were little and got radiotherapy or chemotherapy. And there can be a pre-testicular problem. It's not because our extrophy patient is quite good and healthy and sports a lot that he is not abusing testosterone to have the muscles like this man here in this picture. To make sure if we are dealing with a pre-testicular, testicular, or post-testicular problem, we can look at the hormones, and therefore it's important to keep in mind the feedback system that I explained a bit earlier. When we have low FSH and LH and low testosterone, we have to think of the Kalman syndrome. When the testosterone is high combined with a low FSH and L high, but extremely high, we have to think about testosterone abuse. Post-testicular problems, they have normally a normal FSH, LH, testosterone, and inhibin B. But the testicular issues, then we usually see that the FSH especially is quite high. So when the FSH is quite high, then there can be a testicular problem. And in those patients, we sometimes go on with taking biopsies. But in those patients with a pre-testicular issue, there is no point in taking biopsies because you're not going to find any sperm cell. You first have to treat them in a different way. So never take biopsies when there is a pre-testicular problem which you are not treating. I will come back to that a bit later. But in the other cases, you can go for testicular biopsies. You can do that with a microTC under the microscope. You can do it with an open biopsy. In some centers, and we do that as well, especially if the testicles are very good, we can use this TrueCut needle, which we puncture into the testis. And then actually step by step, as you can see in this picture, we suck everything out and we get sperm cells. So if you can take a biopsy from the testicle and you can find sperm cells over there, why do we have to bother with electroejaculation? Why do we have to bother with retrograde ejaculation and so on and so on? Because there is assisted reproduction, and that's true, but it's important that for assisted reproduction, there is a female side as well. And that's the reason that we have to make sure that the sperm of our man is as good as possible. Because if it's good, we can use it probably for intrauterine insemination, which is much easier for the female. Then we have to switch to the in vitro fertilization or the ICSI. Especially when we take a testicular biopsy, I told you earlier, sperm cells coming straight from the testicles, they don't move. Yeah? So we have to inject them into the egg. That's the only option. While when we have a normal sperm analysis, and we want to do IVF, the sperm cells have to move to have IVF. So also for IVF, sperm cells have to come from an ejaculation sample. ICSI results, especially for men who don't have that much sperm cells, are quite okay, about 16%, and it's easy to repeat. But we need 2 million of sperm cells at least. For IVF, we need about 10,000 sperm cells. For ICSI, we need 1 sperm cell, but there is a female side, because if we want to go on with the assisted reproduction, we need a sperm. If we do it via a biopsy, we have to puncture the female gamete as well, the female egg. We have to find with a vaginal probe, and then we puncture to get them. Then there is the insemination. Then we have the embryo cleavage, the embryo selection. Then we have the intrauterine embryo transfer. And then again, we have to put it back. So these are 2 important procedures for the female partner. And yeah, they need a lot of hormonal treatment before it's possible to harvest these eggs. And we all know the effect of hormones on our mood and how it all feels. So it's very important that if we can avoid this situation, I think it's best that we try to avoid it. For the ones with a pretesticular issue, like for instance the Kalman syndromes or the hypogonadotropic hypogonadism, those patients, we have to try to stimulate the testicles to develop on their own. These guys have small testicles because there's a problem at pretesticular level, and we stimulate them with ACG 2000 units twice a week and FSH 75 units twice a week for 8 weeks. Remember, I told you it takes up to 64 days before one cycle of spermatogenesis is finished. Up to 8 weeks, then you re-evaluate with hormonal testing, with testosterone testing, with inhibin testing. You can look at the sperm cells. Sometimes sperm is coming out, but often when they are never stimulated before, or they were on testosterone treatment before, testosterone has a negative feedback, so it will block the spermatogenesis. It's important to keep that in mind as well. If you give testosterone to a patient, it will block spermatogenesis. So these patients have to stop spermatogenesis, have to stop testosterone because they were on testosterone because of delayed puberty. We have to stop it. We have to stimulate them for the testicles to develop their own sperm cells and hormones. Sometimes it can take up to a year. Sometimes we have to up-titrate the ACG and the FSH. But most patients, after a long while of stimulating with hormones, they are able to produce a sperm cell. Mind the offspring. For all obstructive issues, it's sometimes important to look at chromosome 7 for the cystic fibrosis gene. Patients with complete azoospermia, it's sometimes important to look at the AZFY chromosome. Patients with spina bifida, mind the offspring, because they can have spina bifida as well, and especially if both parents had spina bifida. We had enough talks about that. And in hypospadias who have fertility issues as well, I mean, there's not that much consensus about it, but maybe it's also interesting to check for the WT1 gene. What about fertility preservation in our adolescent patients with cancer and in patients with neurogenic issues? I mean, cryopreservation of spermatozoa is absolutely possible, and it's possible in tenor 4 and 5, adolescents and adults. Absolutely. Yeah. Oh, but doctor, my son has cancer. Oh, but he doesn't masturbate yet. Well, he does. I mean, speak their language. Here I have a lot of different Dutch words for masturbation. Speak the language, speak with them on the 4 eyes, without the parents, assume they do, and I'm quite sure they will agree that they will give a sample, which is much better than a testicular biopsy in those patients. I don't find many adolescents who are part of this no-fap community, so yes, they do. Usually 1.5 years after the onset of puberty, it's happening, and we can collect sperm cells. Here you can also see when you look at the age curves, I mean, azoospermia is still quite a lot when they are 12 years old, but when they get to 13 and 14, we don't find that much azoospermia anymore. The problem is when we have to do cryopreservation for prepubertal boys who are not producing sperm already and who are tenor 2 or tenor 1, so they are not producing sperm cells. For those, we can take testicular biopsies, but we will not find any sperm cell in those biopsies. But what we will find is these spermatogonia. These spermatogonia stem cells we will find, and we can do cryopreservation of these spermatogonia stem cells. The thing is, the fertility potential of that at the moment is still under investigation. But we do know that from certain animals, when we have the spermatogonia stem cells, few years later, after cryopreservation, we can put them back and they will migrate back to the right location in the testicle, but also they can start dividing these spermatogonia and develop sperm cells in the lab. So I presume that in a few years, there will be a lot of stuff we can do with harvested spermatogonia for prepubertal patients. And that means that in Belgium, in most centers, we tell the parents already that we can collect the spermatogonia stem cells. We are not sure what will happen later, but if they get chemotherapy and all spermatogonia die, then there is never a fertility potential. We can harvest them, we can freeze them, and then hopefully science will evolve when they are at the age they want to have a child and they don't succeed on their own. The question is, do we have to do that with neurogenic patients as well? Because many people tell us that neurogenic patients, their sperm cells and the sperm quality will decrease with age. I mean, it's a very difficult topic and not enough studies about this. What we do know in spinal cord injury patients is that when a spinal cord injury happens before the age of 9, it will interfere with spermatogenesis. And when it happens before the age of 9, often these patients will not develop any sperm cell at all. When the injury is a bit later and a bit closer to the onset of puberty, mostly these patients, when they are adults, they produce sperm in the same way as adults. That's important to keep into our mind. Because we also know that our spina bifida patients, the sperm quality is much worse, and that can be that for spermatogenesis, you need some neural control as well. And our spina bifida patients lack the neural control from when they are born, so it's perfectly possible that that into place. But there's actually no real proof that sperm in neurogenic patients with a spinal cord injury is really declining. And also cryopreservation with fresh sperm a cryopreserved sperm and fertility after a fresh sperm or cryopreserved sperm, there is a real difference in these neurogenic patients, which we don't observe in healthy couples. And we don't think that it's really declining, because what we also see is that when you give this vibratory stimuli to these spinal cord injury patients weekly for 3 months, then they will have a higher concentration of sperm cells, more progressive motility, they will have a decrease in abnormal morphology, and they will have an increased penetration capacity. So regularly exposing them to this vibratory stimuli has a very positive effect. Probably they will produce much more new sperm cells, and therefore the sperm quality will probably be much better. But the thing is, we don't have such a study in spina bifida males. No, from spina bifida males, as I said in the beginning, we do know, and we are very happy to know, that they masturbate and that they have sexual feelings, that they lack education. But actually, that's what we know. How often they do it and how they do it, we didn't ask that much at those patients yet. And I think we need to go into much more detail when we are assessing sexual function in these patients. It may be true that when they stimulate themselves a bit more, that sperm quality can be better, but also there we have no proof. Only thing we know is that when the lesion is above azoospermia, and that's based on one study after electroejaculation, that all of these patients had sertoli only and azoospermia, but we also see that when the sacral reflexes are intact and in lower lesions, that there is some chance in fertility potential. So a lot of topics that we still have to study, but I hope I gave you a glimpse and an insight in how we approach this kind of patients. In summary, assess the sexual function, assist in sperm collection, think about the pre-testicular, testicular, and post-testicular issues, think about the female side of things, and assisted reproduction, and the role of cryopreservation, a lot of discussion about that. I want to thank my colleagues in Antwerp from the Fertility Center, and I want to thank Pippa Sangster from UCL in London. And I want to thank all of you to invite me for this wonderful online conference. Thank you.
Gunther, thank you so much. Again, an amazing and comprehensive overview of actually a really complex topic. Thank you very much for doing that. I can't see any immediate questions in the chat or the Q&A at the moment. I'm going to suggest that if people have questions, just in the interest of time, they put them in the chat, and Gunther can respond to them directly. We're going to move on to to listen to Tai Higuchi, one of my new reconstructive colleagues here in Denver. It's always a pleasure to see and to talk to Tai, and I'm delighted that he's able to join us to give us a presentation about assessing urinary incontinence in adult congenital patients. Thank you so much, Tai.
Well, thank you, Dr. Wood and Dr. Bishop. Is that showing in presenter mode or is that the correct one?
Not
We don't
yet.
see your slides yet.
Oh, okay. Well, let's fix that. 1 second.
There you go. We're not quite in presenter mode yet. Are you able to switch your screens?
Yeah, just 1 second. Sorry. Is that correct now, Dan?
Great work. Thank you.
Okay, thank you. Again, thank you for inviting me to present here at this meeting with these international experts. I was asked to talk about assessing urinary incontinence in the adult patient with congenital bladder anomalies. I don't have any disclosures. So when I was thinking about this talk and how to present this to this illustrious panel of people across the world, I thought about, what does clinic look like for us here in the United States? And so certainly this is just a representation of the Friday afternoon transitional urology clinic. You've had a great afternoon. You're seeing these patients with urethral stricture, with erectile dysfunction, congenital penile curvature. You also think that you're coming off call of the week. It's Friday afternoon, here in Colorado, the Colorado Avalanche are in the Stanley Cup Finals. So we're all getting excited to watch that this weekend. And you look at your last patient of the day at 4 o'clock, and it's a new patient with urinary incontinence. And as you're pondering seeing this patient, your medical assistant brings in this stack of records for this patient, says, here are the records. Could you please review them before you see the patient? And you're still wondering, what's this going to be about? And then you see this was referred by an illustrious pediatric urologist named Duncan Wilcox. She knows certainly, it's not going to be the most straightforward consult. So as you sit there, I start to think, like, what am I going to do with this patient as we're trying to do the best we can for her? And then you realize, as this has been talked about, I'm sure over and over, there's been so much progress made in patients with congenital bladder anomalies. Specifically, this article by Professor Woodhouse looked at, children with spina bifida. We know at least 50% of them survive now to the age 35. And importantly, up to 40% of them who reach the age of 40 will die of renal failure, indicating the importance of urologic evaluation and long-term follow-up. In addition, when you expand that to all congenital issues, you can see that greater than 90% of children with chronic childhood conditions will expect to live into adulthood. So still you're sitting there thinking, well, what am I going to do? What are my residents looking at me? What are we going to do with this patient? Everybody's thinking about, moving on to the weekend. And so I always think of going back to the basics that we all learned in medical school, how to do like a really good history and physical examination, because certainly I think that's at the center of getting to the bottom of what the incontinence is truly about. So as you're walking to the door, I think about this and all the patients that I see is what's the history of reconstructive and congenital bladder anomalies. So if you look way back to the 1800s, that's when ureterosigmoidostomy as well as enterocystoplasty were first described. The next big landmark for these patients was when broad spectrum antibiotics were developed, as well as the ileoconduit and refluxing anastomosis. So this started the era of patients undergoing these types of urinary diversions from about 1950s until the 1970s, when Dr. Lapidus, brought a game-changing idea into practice with intermittent catheterization. Likewise, during this decade, that's when oxybutynin was released. So that also led to a lot more medical management of these patients. By the 1980s, our practice models from the 50s started to show some signs of wear and tears. We started to see upper tract deterioration from the refluxing anastomosis. This is the first time adenocarcinoma and ureterosigmoidostomies was reported, and so certainly that raised some concern. And this led to this quote-unquote era of undiversion, where patients who had these incontinent diversions were starting to get undiverted. And that persisted for the next few decades until in the early 2000s from the Indiana group, Sorgel et al. Reported the first case of bladder cancer in patients with spina bifida. Importantly, these cancers showed up with a median time delay of about 10 years. These were all young patients, and a majority of them were lethal. So it really caused the community to pause on whether it was just the augmentation or the neurogenic bladder itself that was at risk. So you could see how that kind of changed practice over the next decade, now 2 decades, as the rates of bladder augmentation certainly decreased by up to 25% and led to the increase in other medical management, including Botox as well as beta-3 agonists. So we think about our patient, she's 28 years old, she was born in 2004, and so certainly we don't know what she's going to have when we talk to her. And so certainly you have to be willing to think about all the different possibilities. So then you go and you take your history. Obviously, you're going to figure out which of the congenital bladder anomalies this patient may have. Could it just be spina bifida? Could it be spinal muscular atrophy, Down syndrome, spinal cord injury, or the classic Hinman's bladder? So of course, next you're going to ask about previous treatments, including medications, including the anticholinergics, currently like beta-3 agonists. And here in Colorado, a lot of patients are utilizing different naturopathic remedies just due to the availability of things like CBD. So certainly surgeries become important. Have they had a urinary diversion? Which one do they have? Do they just have a continent stoma? Have they gotten Botox before? If they got Botox, they know how much Botox they got. Did they undergo sacral neuromodulation, which became sort of popular in the early 2010, or have they had an enterocystoplasty? And then you really have to dive in. Are they voiding or catheterizing through the urethra? Do they have a continent stoma? But again, this starts us thinking about the process of how we're going to reconstruct these patients. Then certainly very important is, have they had a bladder neck reconstruction? Is that open or is it completely closed off? Have they had an artificial urinary sphincter, specifically a bladder neck sphincter, or a urethral closure? Which segment of bowel was used? As we know, there are different segments of bowel which pose different risk factors for different metabolic abnormalities as well as different malignancies. So it's very important not to forget the bowel history. Also, don't forget the mobility, the body habits, and physical function, as I know Dr. Del Toro talked about earlier and Dr. Wilson yesterday. But we won't cover those today. So the next thing we're going to talk about is, what are you doing now? And I always think of this as, where are they now? And it was perfect timing because for those of us in the US, a big movie for us was Top Gun that came out in the 1980s. And so certainly the young Tom Cruise shown on the left, certainly he has been doing well and has aged well over the years, as shown here on the picture on the right from the recent release of Maverick. And if you haven't seen it, it's a wonderful film. But certainly you want to know what the patient has been doing over the past couple of decades to get them where they're at. That's where we'll really dive into their what's their bladder management. Is there an indwelling catheter? Are they doing CIC? Where are they doing it from? What type of catheter? Are they latex allergy, non-latex allergy? Frequency of catheterization? Are they irrigating? Are they using normal saline? Are they using tap water? Are they using well water? And then certainly you also ask if they're credavoiding, which certainly was very common. And then lastly, of course, urinary diversion type and location. It's really nice because in a recent report from Sean Elliott's group out of Minnesota, they said, up to 77% of patients were doing CIC, which certainly is very helpful to the transitional urologist because sometimes that can be a large obstacle to overcome. So now, can we quantify this incontinence and see how bad is it really? We really want to know, how bad is it? Since we're all, researchers and like to look at data, we want outcomes measures. So the first question becomes, are there patient-reported outcome measures for neurogenic bladder? And the simple answer is yes, there are a lot of them available. This is just showing a Cochrane review of several different studies that are available and what they can help you determine as you develop your study. But what about a patient-reported outcome for congenital bladder anomalies? And so this, Rosalie talked earlier about this, but really the group from Indiana has really done a fabulous job developing a specific quality of life assessment for patients with spina bifida, and specifically looking at the urinary incontinence as well as the overall quality of life. In the Qualis A study, they asked 5 questions about bowel and bladder incontinence. You can see here, worry about pads being noticed. Are they bothered by the urine leak? Urine problems stop you from fun things, or are they bothered by bowel leak or bothered by waiting for bowel? And so this allows a quantitative measure of their urinary and fecal incontinence. But what if we did something a little bit simpler rather than being so specific? And this is a really clean study that came out of Sweden recently, where they looked at retrospective evaluation over 16 years from their patients. And they simply broke urinary incontinence down into, are the patients satisfied, meaning they leak at a max of 1 per month? Is it acceptable, meaning they leak every week? Or is it inadequate, where they leak daily? So certainly there's more simplified approaches that you certainly can undertake. But of course, we're all wanting a little bit more objective data. And so certainly, again, the Indiana group took their quality study one step further, and they looked at specifically 3 questions related to incontinence, looking at their dry interval. Was it less than 4 hours? Was it greater than 4 hours? What's the quantity of the incontinence? Is there none, a little bit drip, or a lot? And then how many daily pads or disposable underwear do they wear in a day? What they did was they took the answers from these 3 questions and then also utilized their quality study to come up with some quantitative data on how this affects patients' lives. And importantly, what they found out was the quantity of urinary incontinence was the greatest predictor of the lowest quality of life. In other words, if a patient has a lot of leakage, their quality of life is very poor. It makes sense, but it's nice for us to be able to at least say that it's true and not just assume that our patients feel that way. So other things, is there an objective measure of urinary incontinence in this patient? Likewise, just like a patient-reported outcome measure. You certainly can ask your patient, do they wear pads, do they wear pull-ups or depends? But what about something even more objective? The International Continence Society has come up with a pad weight testing and evaluation of urinary incontinence, where you give a bolus of fluid and then you weigh the pad at different time intervals after the patient has had an opportunity to have some incontinence. Certainly in my practice in reconstruction, this is important as I'm trying to determine which patient after a prostatectomy is going to undergo a sling versus an artificial urinary sphincter. So is there something that we can do for these patients? And of course, all of us know there's not really a universal method for this type of assessment in congenital bladder anomalies. So we are taking our patient's history and we get all of this data. And so patient talks to you about they've only been on CIC since birth and just oxybutynin. She is doing it herself, which is fabulous. She's had 3 to 5 UTIs over the past year. She's not sure how many exactly, but that's her estimate. She's tried Botox ×2, doesn't really think it's effective. She doesn't have any history of bladder stones, thankfully. And her incontinence, she describes about 4 to 5 depends per day. They're fairly wet when she changes them, but she changes them frequently because she's afraid of any type of embarrassment that could happen. For a bowel movement, she uses this quote unquote herbal tea from a local shop that she feels works well. Her shunt has been revised twice. Fortunately, it's now plural. And then her mobility, she is mobile with AFOs and crutches. And then when she goes for distances, she'll use a power assist chair. So if a resident has gotten this history for me, I'm thinking that's fantastic. You nailed it out of the park. But I always ask them one question, which is my caution question, which is what's their skin like? Have they had any skin breakdown? Do they currently have any skin breakdown? I think everyone here knows the importance of skin in incontinence, because urinary incontinence and even fecal incontinence certainly raises the risk of pressure ulcers. As you can see from these 2 studies, this was a hospital-wide study. If you have urinary incontinence, you have about a 2 to 3 times increased risk of having a stage 3 or 4 decubitus ulcer, which those are typically surgically managed. In addition, the group from the spinal bifida research groups found that for patients with spinal bifida, if you have urinary incontinence, the odds ratio of developing a pressure ulcer is about 1.4. So then you have to do sometimes a difficult thing, depending on your patient's body habits, is you actually have to get them out of their chair or up onto a table so you can really examine their skin. And I think this is so important, because you can see the patient on the left where her current cecostomy tube comes out. You can see that's actually a Mitrofanoff catheter on the right, but you can see how irritated her skin is, which is likely an incontinence-related dermatitis. In comparison, you can see the patients on the far right, those are very aggressive decubitus ulcers or pressure ulcers. The one on the right is a sacral ulcer. The one in the bottom right, that's one of the worst that I've seen, where this is actually a male patient. You can see the anus at the bottom of the screen. You can see a Foley catheter. The direction of the Foley catheter is where his urethra used to be. He's eroded all the way down, basically to the membranous urethra. So exam is critical. But then understanding what you're seeing, of course, is also critical. There's, plain incontinence-associated dermatitis that classically just occurs in the perineal areas, compared to pressure injuries, which are going to occur over bony prominences. So now we've really getting through the meat and the potatoes of this patient to try and get through our clinic, and we have a great history and we start our exam. But the next question is, what's the standard evaluation for patients with congenital bladder anomalies? Is it labs? Is it urine culture? Is it upper tract imaging, lower tract imaging, urodynamics, cysto? Do we think about cancer in these patients? How do we approach them from a standardization status? So I would tell you that I think there is a very good standard protocol that was developed by Dr. Doug Hoosman of the Mayo Clinic. He was my mentor throughout residency and still collaborate with him. And he came up with this protocol that he was insightful enough to start in 1986 when he started doing transitional urology, and has followed those patients, for almost 3 decades. So this is just a schematic representation. What this protocol is the annual surveillance with interval history. It's physical exam. Everyone gets a renal bladder ultrasound as well as a KUB. They'll do a CBC, electrolytes, a cystatin C. As we know, most of these patients have muscle wasting, so creatinine may not be reflective of their overall GFR. A B12 for patients who have undergone urinary diversion, and he usually got, or almost always got, a urinalysis as well as urine culture to get a baseline result. The only time you would defer is if the patient had new onset urinary incontinence, or if they had worsening renal function. That's when we would do a video urodynamics and sometimes a cystoscopy. But as you know, Dr. Hoosman was very big into looking at what's the risk of cancer in these patients. And so in the interval history, if they had any of these 6 factors, that prompted us to do a CT scan or a cystoscopy on them to really try and identify if we could even have a chance of seeing a cancer in an early stage. So what does it mean if you develop a protocol 30 years ago and you follow it? It means you do develop a lot of information about patients as well as practice management. So certainly the Hoosman protocols led to numerous, publications. I was very fortunate to catch this protocol and the data as it was ripening, and really looked into the controversy over bladder augmentation and cancer, as well as should we be using cystoscopy for it. Certainly that in itself could be a talk, but I thought I would just go a plug for Dr. Hoosman and all the great work he's done for these patients over the past decades. So what are you looking for? We all know what we're looking for when we see these patients, specifically incontinence. Is there stomal issues? Is there a UTI? Are there bladder stones, metabolic abnormalities, B12, renal deterioration? Bladder perforation, is certainly a complication of these. More so catch those in the middle of the night than early. And certainly, again, I brought up bladder cancer. So how do I look at these patients when we're seeing them? Irrespective of how they're voiding, if it's orthotopically with the Foley catheter, with catheterization or continent stoma, if they show up in the clinic and they're incontinent, the first thing we're going to start to think about is what's the bladder evaluation once we've ruled out something like a urinary tract infection. And so what are we going to do with this bladder evaluation? Well, of course, we're going to do video urodynamics. We like to do video urodynamics at our center. Obviously, I can't underscore the importance of video urodynamics and how much information you can glean from them. But we're going to start with video urodynamics on the patient. So you get a good look at their bladder shape. Do they have reflux? You can also see where hardware is. Sometimes you'll see where the shunt is. But for like this patient, very small capacity bladder at 140 cc's, with poor compliance. So clearly not a safe bladder that we're looking at. Then of course your ultrasound is going to look for upper tract deterioration, stones, as well as the bladder. Similarly, we'll look for stones, any thickening, or masses even sometimes. And then certainly a KUB can be very telling if they have large bladder stones inside. Malignancy, again, that's the one thing I think we all fear in these patients. Unfortunately, in my career, I've taken care of 5 patients with bladder cancer and that have had augmentations. Fortunately, about 4 out of the 5 are still living, but they all required very aggressive treatment. So if the bladder is bad, obviously with stones, UTI, or cancer, you're just going to treat that bladder. You're going to talk to the patient, and there's certainly a multitude of different treatments that can be started depending on the patient preference. If the bladder happens to be good, which is phenomenal, then you really have to push your patient. Is it this more of an overflow incontinence problem where they're not managing their bladder correctly? And so they either need to manage with CIC or they need to manage with time voiding or even double voiding. So if the bladder happens to be good, and then you start also thinking about, is this the urethral bladder neck or continent stoma that's really driving this process? And so certainly you definitely, again, I can't underscore physical exam on these patients. You really have to look at them. So this is a patient, obviously female patient with neurogenic bladder who had a Foley catheter in her for the past 5 years. It got changed monthly, but it got changed to the point where it's now 24 French catheter with 60 cc's in the balloon. And she would push that balloon out every now and then. And we all know that the female urethra can become very capacious in these situations. This is another patient of mine that I saw. She actually had extrophy. She was born in a refugee camp. I think they did the best they could, and she got partially closed. However, if you go and do, a female exam on her, what you'll see is they actually created a cloaca for her, where her urethra now just drains directly into her bladder. Stomal stenosis, this is one of the lucky ones. I got lucky when I fixed this one, but this is what it looked like once we were done. The stomal stenosis is typically pretty obvious. I think that, we're starting to see more lichenoid changes to these patients. And so I think that several centers have looked at using buccal graft to help with stomal stenosis, because it's the only tissue known that will resist lichen sclerosis. Retrograde urethrogram certainly is helpful in the patient that's had a lot of urethral reconstruction. This is a patient who had a complete hypospadias, proximal hypospadias, had it reconstructed as a child, kind of followed up, didn't follow up, but you can see multiple concentric strictures throughout. When we scope this patient, there's hair throughout the urethra. You can see a completely blown out posterior urethra. Unfortunately, this is a patient, when we got to him, he was already in stage 3 chronic kidney disease at the age of 28. And then certainly you'll see the very unusual situations. This is a patient of mine who was managed with an indwelling Foley catheter. The problem with the neurogenics is certainly if they do have a component of detrusor sphincter dyssynergia, it can be difficult to catheterize. So this patient had a catheter put into their urethra and it was blown up in their bulbous urethra, which then led to a large diverticulum forming, which you can see here. And you can see the Foley catheter in the diverticulum. And eventually that eroded into his ischium, which led to an ischial osteomyelitis. So certainly these patients can present with some very complex channel management. So going back to our patient, right? You really want to try and figure out, how can you help her? And certainly most of these patients, I'll tell them, well, we aren't going to be able to figure everything out on the first visit. But her, we eventually found out, luckily her skin was normal. She was very diligent about her skin, which is fabulous. And I think the more we can teach these patients this at a young age, the better. You saw her UDS, very poorly compliant bladder. She didn't have any stones. So the question became, what do we do? And I think that we all are moving in the adult world, as well as the pediatric population, to more of a joint decision making. Once we talked to her about her true catheterization regimen, she's like, yeah, when I was doing Botox, it was a little bit rougher time in my life. I might not have been as good. So she opted to try Botox another time. And if that didn't work, we would talk about doing, a bladder reconstruction with possibly a sling. So to conclude, again, urinary incontinence is such a large range of different things for all of these patients. And I always go back to basics, just like Bill Murray in Stripes, if you saw that movie from the 80s. Definitely getting a great history, talking about their surgeries or even getting their operative reports. I learned a lot from one patient who had a lot done at CHOP back in the 80s, reading through the op notes, what's their current management? Are they really sticking to it? Trying to quantify the incontinence. And I definitely think this is where this group can certainly come together and really start to look at developing, standardized patient reported outcomes for these individuals. I can't overemphasize the skin and how bad it is, just because unfortunately I've taken care of a lot of patients with osteomyelitis through a joint team that we have here at University of Colorado. And then again, get the patient onto the table and look at them, even if it is 4 o'clock in the afternoon on a Friday. And lastly, again, I have to give credit to my mentor who really got me interested in this, Doug Hoosman. Certainly, again, the imaging, the labs, just having a protocol and just doing the same thing for 30 years has provided so much wonderful data for us to be able to build off of. And then certainly also, I think in the back of my mind also always lurks the idea of cancer. Maybe this could be a topic next year, Dan, but it certainly is something that we all fear that one day we'll find. To give a final conclusion, we see such a diverse patient population. And while we would hope they all fit into the one size fits all store, we certainly know that they don't. And you have to be very pliable in how you evaluate and treat these people. Thank you.
And thank you very much, Dr. Iguchi. I think you touched several important aspects. One of them that I always worry about is the amount of records that we have to review. I receive patients, and most of our patients are not local, so I cannot tell them next visit we'll figure out. So I think people don't know how much time we spend in preparation for that visit, just reviewing records. It may take hours, and I don't think that the electronic medical records have made our life easier, because frequently when they send from other institutions, it comes thousands of papers all mixed. So you cannot even differentiate what is an operative report for the common daily progress notes. So it is a lot of effort. And the other point that you mentioned that I felt guilty during your presentation is the physical exam in adult patients with spina bifida. Of course, a large portion of my practice is kids, and it's very easy to carry them and examine, but I thought that most of the adult patients with spina bifida, I feel that I examine them less because I'm afraid of how hard it will be to move them, to put in bed, and to ask them to change. So I thought of my own practice that I probably should do better. Let me see if there is any questions for you. I don't see any questions. So I would like to thank you very much for this wonderful presentation.
Thanks again for the invite.
Hi, thank you so much.
So now we are going to welcome our next speaker, Dr. Megan Adams. She is a transplant surgeon here at the university and the Children's Hospital. So she does all the livers and all the kidneys transplants. So Dr. Adams, welcome.
Thank you so much.
And while you're pulling your slides, I have to say, if there is one team that has figured out how to treat patients at different places, is the nephrology team, and how they are able to coordinate dialysis. I know you're the transplant surgeon, and we'll have a nephrologist talking after, but I have always been impressed on how well dialysis can be coordinated. Welcome.
Can you see my slides okay?
Yes.
Perfect. Thank you guys so much for inviting me. I'm really excited to talk a little bit about multidisciplinary care and transplant surgery. Like Dr. Bischoff said, I am an adult and pediatric transplant surgeon. My job is mostly at the Children's Hospital, but I do take care of adult patients, both liver and kidney. And I have to say, I think at Children's, we really have figured out multidisciplinary care much better than we have on the adult side. And partly this is probably, we just have smaller volumes at Children's. And I'm mostly going to focus on how we, as a center, focus on the urological workup, and then the steps we have put in place in terms of transitioning to adult care. I have no financial disclosures. So when a patient is referred to us for a kidney transplant or a liver transplant, for this purpose of this talk, I'll be mostly talking about kidney. I kind of think of the transplant as 4 different phases. There's the referral and the initial evaluation phase, where we get to know these families if they aren't already from our center. And once we feel like they are ready to be listed, then they go into the wait list maintenance. And most kids are fortunate to get transplanted relatively quickly. However, if there's a highly sensitized patient or a medically complex patient on the wait list, there's a lot of wait list maintenance and making sure that we still have our finger on the pulse of what's going on with these kids. There's the perioperative care around the time of transplant and their initial hospital stay. And then there's the post-operative and post-transplant care, making that these kids stay on the right track and then start thinking about transitioning them to adulthood. The end game in transplant is to make sure that patients are as prepared as possible and that they can keep this graft as long as possible. Organs are a finite resource, and we want to make sure that the patients are prepared to take care of it and have all the tools in their toolbox to make sure it lasts as long as possible. So when somebody comes to see us for a kidney transplant evaluation, they meet a whole slew of our team. They meet a welcome coordinator, a financial coordinator, a transplant pharmacist, a transplant surgeon, a transplant anesthesiologist, a transplant social worker, a transplant nephrologist, psychologist, infectious disease, a dietitian, urology. They may see cardiology if they have an indication. They may see hematology if they have a family history of coagulation problems, or they themselves have a history of clots. And then there's a whole slew of labs and tests that we get to evaluate them. And this really, not everybody is ready for a transplant, especially if they haven't been followed at our center forever by the time they're referred. This might be the first time the family is hearing about immunosuppression. It might be the first time that they're hearing about cathing post-transplant. I remember I evaluated a kid last year who had a history of an augment with a Mitrophanoff, and they were referred from elsewhere, not within our state. And they said, "What do you mean I have to cath?" And so it's starting the conversation early with the family and letting them know our expectations and starting to get to know their familiarity with the process. And this, talk will mostly be focused on kind of what we as the transplant surgeons, the nephrologists, the infectious disease, and the urologists have come up with in terms of a workup. Our workup for urologic issues has gotten much better. I would say over the last 7 to 8 years, we used to not pay so much attention to what their urologic status was pre-transplant. I am not a urologist, and so I can't claim to be able to interpret these video urodynamics as well as our urologists that are on the call. But anybody who has a suspicious, if they're not a person who lost the ability to pee relatively recently or haven't had any urologic surgeries, they may not need video urodynamics. But if there's a prolonged history of anuria or they have an augmented bladder, then they almost all get video urodynamics to kind of help us determine our perioperative plan with the bladder. This kid was an 8-year-old with a long history of anuria. Due to a bunch of other medical comorbidities, he stayed on dialysis for longer than we would have preferred. But he only had a bladder capacity of 90 milliliters. And when we put a brand new kidney into this system, we want it to be a low pressure, easily drained system to maximize the lifespan of the graft. And so after our urology colleagues performed this urodynamic study, we decided that this kid was probably a great candidate for either a vesicostomy or a suprapubic tube to allow us to have time to grow the bladder and have it adequately drained so that we could make this graft last. And this kid was transplanted earlier this year and he ended up getting a suprapubic tube. He's doing great. He has excellent graft function. On the other end of the spectrum, this is a 16-year-old, more along the lines of what we've talked about here today. history of spina bifida and neurogenic bowel and bladder with a prior augment. And he had a bladder capacity of 500 milliliters, and was unable to void any on his own. And his cathing technique was unable to completely empty the bladder. And so working with him pre-transplant, we were able to come up with a better cath technique to optimize his long-term outcome. So after we come up with a good plan, they're on the wait list and they get an offer. Their inpatient stay is very multidisciplinary. We round every day with a transplant surgeon, the transplant hepatologist or nephrologist in this case, a transplant pharmacist, the social worker, the dietitians, and our coordinators. And our coordinators really bear the brunt of this multidisciplinary care because they're the ones that were, saying, you set up Bobby Joe to go see so-and-so for their whatever 2 weeks post-discharge. But it's a requirement by UNOS that we round in a multidisciplinary fashion every day, but it also really helps to streamline their care. After they're initially discharged, they visit clinic at least twice weekly while we get their immunosuppression dialed in and gauge their comfort with everything. And if they're from some distance away, we transplant a lot of patients from the region that aren't necessarily local to Colorado. And even those that are in Colorado and live on the western slope might live a 5 or 6 hour drive away. And so once we feel like we have that kind of relatively ironed out, they're allowed to return home at 4 to 6 weeks post-transplant. They get labs locally and see their local team, but we continue to manage their labs and their immunosuppression. And one good thing I think that came out of the pandemic was the use of telehealth for these more remote patients. If they're otherwise cruising and their labs look great, then we don't need them to drive 6 hours back for us to say, hello, your tacrolimus looks great. We don't need to make any changes. And so now I'm going to transition a little bit to what we have done with our transition program at Children's Hospital of Colorado. We begin the transition process at age 14, and there's actually a tool built into our electronic medical record that starts getting reviewed with the patient and their family at age 14 to kind of gauge their level of readiness. And ideally, these patients are transitioned to adult practice between the ages of 18 and 21 with definite completion of transition by their 22nd birthday. Our transition program has been heavily modeled after the American Society of Transplantation. They have a great website with 4 different age groups: young adolescent, mid-adolescent, late adolescent, and adult. And it breaks it up into 4 or 5 different categories. There's a checklist for the patient themselves, the kid, so that they can start understanding where they are in the transition process. There's one for the provider. There's one for the parent. And then there's a 4th just kind of explanation sheet for each of these different age groups. And it covers these different domains. Why did you have a transplant? What medications are you taking and why are you taking them? What do they all do? What things can you do to help make adherence easier, especially if these are kids going on to college and won't have adult supervision? So are they going to use a pill box? Are they going to use a phone timer? What's their adherence mechanism going to be? Talking about risky behaviors that they might start engaging in as they enter young adulthood. Managing my health and what I need to do to stay healthy. And then also a domain on self-advocacy. We emphasize heavily that once you're 18, you are an adult. You need to learn to advocate for yourself and, your body best. Reproductive health, school and work, identifying who their support system is, and then issues regarding self-image and also paying for healthcare. I certainly at 18 had no idea how to pay for healthcare. And so this is something that we introduce early. in the transition period. This is a quick little video that we made and has been, our transition process has been presented at many national meetings, and we're kind of the front runners at Children's Colorado of how we transition to adult care. This is a video that's on our YouTube website, and it's part of our transition day when we meet with the families and patients looking at potential transition.
Going from a children's hospital to an adult hospital can take some getting used to, but your team of doctors, nurses, pharmacists, and transplant coordinators are here to help you. You will need to call the Adult Transplant Center to set up an appointment. There are many adult programs that may be right for you. Your pediatric transplant team can help you find the right program. Always make sure you arrive 30 minutes early to your appointment in case you need to get blood drawn. Call the main operator at the number on your screen if you might be late. If you have any problems throughout your visit, you can ask that your transplant coordinator or the on-call coordinator be contacted. If you get lost, please ask for help. Before your appointment, make sure you write down questions to ask your doctor. This will make it easier to remember what you wanted to ask them. During your appointment, you will meet similar providers to those who cared for you at Children's Colorado, such as a doctor, pharmacist, transplant coordinator, dietitian, mental health counselor, and social worker. They may not all be at your appointment, but if you would like to meet with anyone in particular, just ask. Once your appointment begins, you will get your weight and vital signs taken first. During your appointment, you will be asked if anything has changed with your health. It's important to be honest so they can give you the best care possible. Depending on your visit, you may have to get an ultrasound, x-rays, or other imaging done to look at your kidney, heart, or liver. You may also need a biopsy. When you're done, you will get some papers with your instructions on it. Be sure to stop at the front desk on your way out to make a follow-up appointment. When you leave, you may have to pick up medicine at the pharmacy. The doctor's office may call you if they need to change your medicine or change the time of your next appointment, so please make sure you answer your phone. My Health Connection is also a great way to see your lab results, upcoming appointments, and to send messages to your doctors and nurses. If you don't have My Health Connection, ask your transplant coordinator to help you set up an account. If you need to change your appointment or you have questions about medications, call your transplant coordinator. For questions or concerns that need immediate attention, call the on-call coordinator. For more information about transitioning to adult care, visit the website on your screen.
This is every year we do the culmination of the education of our parents is hashtag adulting transition to adult care conference. It used to be in person. It's still virtual for us this year. But it's essentially a half a day where all the patients that we are intending to transition from solid organ transplant over to the adult center to go over the nitty gritty things that you might not think about or that your parents have taken care of for you this entire time. The education materials that we have in place and they're consulted on is the transition overview, a parent checklist, insurance resources, medications, safe over-the-counter medications that can and can't be used after transplant. These are all available in English and Spanish. And then where we're going is also adding resources about reproductive health, drug and alcohol use, what to expect in adult care, smartphone usage, and who to see, like, well, who do you see when? When do you need to see your primary care? When do you call the urgent care? And when do you need to go to the emergency room? And this is certainly a huge group effort, and none of us can do it alone. And I think, you know, the relationship that the surgeons, the nephrologists, and the urologists have developed over the last 7 years has really helped our patients keep their grafts as long as possible and have the best possible outcomes in the long run. And with that, I am done and would welcome any questions.
Thank you very much, Dr. Adams. I think the transplant team has certainly led the way in transition. I think the fact that you do transplants in adults and transplants in surgery, meaning that in pediatrics, I think makes the transition a little more smooth than when we try to transition patients with congenital diseases that in the adult hospital they are not familiar with. But regardless, I think you have a good pathway that we should all take advantage, and I'll certainly take some ideas from your presentation. Let me see, I don't see any questions. There's one question, is there a contraindication for a patient with a cloaca to have a kidney transplant?
No, we transplant patients with cloacas all the time, as long as their urinary tract is deemed safe pre-transplant. There's no contraindication.
Perfect. Well, thank you very much. If there are any questions, please continue and type in the chat. I'm sure Dr. Adams can take a look and answer them. And now we're going to invite our other speaker from nephrology, Dr. Eric Benz. Welcome, Dr. Benz.
Thank you so much, Dr. Bishop. I appreciate it. And I really appreciate the invite from both of you guys to come speak with you guys about transitions of care in children with chronic kidney disease, dialysis, and kidney transplant. Let me just get everything hooked up here. All right, everyone, is my screen showing okay?
Yes, it is. Looks good. Thank you.
Excellent. Thank you. So again, my name is Eric Benz, and the title of my talk is The Transitions of Care in Dialysis and Kidney Transplant, Pediatric Nephrologist Perspective from Graduating from Pediatric to Adult Care. I'm one of the pediatric nephrologists here at Children's Colorado, and I work with our urology colleagues and our transplant surgery colleagues as well, and the care of the patients that I see. So I also have no disclosures. And so the objectives today is I want everyone to hopefully understand modifiable factors that can lead to chronic kidney disease progression in children and young adults. I also want to have everyone hopefully know some barriers to successful transitions to care in children with chronic kidney disease. And then discuss ways to promote successful transitions of care from pediatric patients with chronic kidney disease to the adult care. So first, just a little bit of background, CKD in children with anorectal malformation. So congenital anomalies of the kidney and urinary tract is the most common cause of chronic kidney disease in all children. The incidence of end-stage kidney disease is very low in children, about only 12 per million in the United States. But of those 12 per million, 30% of them are due to congenital malformations of the kidney and urinary tract. The incidence of chronic kidney disease is likely much higher in children with anorectal malformations and other bladder issues due to the underlying frequency of these GU anomalies. And so in some studies, they've seen up to 25 to 60% of children with anorectal malformations having GU anomalies. And then also it's important to point out is that children with abnormal kidney anatomy, but still having normal kidney function are still classified as having chronic kidney disease with the potential for progression later in life. I tell many of my patients that, everything looks excellent with your kidney function, but because we know your kidneys, may not be formed completely normally, we need to follow you or make sure we follow and check things throughout your life to make sure that we don't see disease progression. And if we do, figure out ways that we can slow it down. A study by some other esteemed colleagues here also on the call did find that 2.5 to 6% of children with anorectal malformations develop end-stage kidney disease. And so you can see it's a much higher frequency than the general population. And also recent studies have also shown decline in GFR in patients with CKD going through puberty. And so that's even more important in this talk here about transitions of care, knowing that the most at-risk patients are the ones that we're going to be transitioning over to the adult side in their care. So what are evidence-based modifiable risk factors to help preserve kidney function in children with CKD? I think one of the most important things that we've done is trying to find actual evidence for the preservation of kidney function in children with complex GU anatomy and chronic kidney disease. And so the first is to treat the underlying cause of chronic kidney disease. Second, trying to avoid additional kidney injuries. Third, trying to slow the progression of CKD, because again, we unfortunately don't have ways that we can fix or reverse CKD, but we do have things we can do to try to slow down the progression. And to help do all those things, one of the most important things I want to talk about is regular follow-up and lab monitoring. From our nephrology, myself and our nephrology colleagues make sure that we talk about that lifelong with our patients, that even if things are perfect and wonderful and excellent, whether it's coming to see a nephrologist or a specialist, but even just going to your primary care doctor once a year to get regular checkups, to get your blood pressure checked, get that physical exam, and get labs if necessary is essential to make sure to preserve kidney function in children with chronic kidney disease. So first, for treatment of underlying cause of CKD, unfortunately, many of our patients with complex GU anatomy do have some dysplasia and hypoplasia of their kidneys, and unfortunately, there isn't much we can do to reverse that. However, reflux or bladder management by a urologist is imperative to help reduce potential for kidney scarring and fibrosis to maintain and preserve the kidney function that's already there. And the multidisciplinary team that Dr. Adams just talked about is essential to optimizing care in all these complicated patients. And so I think it's not going to be one person who is able to fix everything, but understanding that it's going to be multiple people over time that's going to help slow progression and maintain the kidney function that we have. Next, there are various ways of avoiding kidney injury. And the first thing is there was a study just recently published out of New York that looked at events of AKI in patients with chronic kidney disease. And they noted there was faster progression and decline in your kidney function for those who had episodes of AKI compared to those who did not. So I think it's essential to understand how you can get AKI and how you can avoid it. And so along those lines, prevention of UTIs and pyelonephritis. Infections are an easy way that we see frequent AKI. If it's not from the infection, it's from hypovolemia or fluid loss, not enough fluid intake, diarrhea that can cause acute kidney injury, thereby helping or causing progression of chronic kidney disease. Also, nephrotoxic medications are big. And so, a lot of these medications, not vancomycin, but NSAIDs are over the counter. Those can cause kidney injury if not taken appropriately and not used judiciously in patients, especially those with chronic kidney disease. And so I think being mindful of who your patients are, what their kidney function is, and whether or not NSAIDs would be the right medicine for them for what ails them is important to make sure that we maintain and preserve kidney function that's left. Additionally, as patients with complex GU anatomy can get frequent UTIs, understanding that vancomycin, especially a combination of vancomycin and pip/tazo, can really exacerbate and cause AKI, which then can cause progression of chronic kidney disease. Aminoglycosides as well are troublesome. And so importance of doing regular drug monitoring and also just acknowledgement of sometimes we have to use these drugs, but acknowledging their risks and how we're going to try to prevent AKI in these patients. Also radiographic contrast. Again, the question, it's not that radiographic contrast can't be used. It's more that I always ask patients or ask the other providers, do we need to use it? And what's the benefit of having it versus not having it? I think the important thing is understanding and acknowledging those questions will then help us reduce the incidence of AKI, which then can propagate kidney function decline over time in patients with CKD. And last, we also can we have things that we have found through studies that can slow progression of CKD. So one is excellent blood pressure control. I think like people have mentioned, doing the physical exam, also getting a solid set of vitals and taking good blood pressures is essential to recognition of hypertension, and which then can cause progression of chronic kids who have chronic kidney disease. And so a study was done in Europe called the ESCAPE trial many years ago, which found that intensified blood pressure management, so looking at children with a blood pressure less than the 50th percentile for age, actually slowed the progression of kidney disease over time. And so I think blood pressure monitoring is essential from all providers who see patients with chronic kidney disease or those at risk for chronic kidney disease. Additionally, reduction of proteinuria has been shown. So a wonderful prospective cohort study that is called the CKID study, so the children with chronic kidney disease cohort, found that looking at urine proteinuria, that children with heavy proteinuria had faster decline of their kidney function compared to those who had no proteinuria. And so recognition of patients who have proteinuria in the setting of chronic kidney disease, and then using therapies that we can administer to help that. So ACEs and ARBs, which are antihypertensive medicines, but in this case, we use them as anti-proteinuria medicines. What I usually call them as kidney protective medicines to my patients and say, hey, we have a little bit of proteinuria. We know if I can try to reduce that, that can help slow the decline of your kidney function. And so we'll call this your kidney protective medicine that we put you on. And usually what we'll do is titrate up to tolerance of the patient, whether we see either patients get AKI from the medicine or get hypotensive, we'll try to titrate it to effect to help reduce proteinuria. Last is correction of metabolic acidosis. And so randomized controlled trial was done actually in adults, looking at giving sodium bicarb to patients who had hypertension and acidosis, and seeing if their kidney function declined at a slower rate compared to those with placebo or using sodium chloride tablets. And they found that there was a slower reduction in their kidney function over time. And similar, they saw actually a slower production of proteinuria or albuminuria, as well in those patients, leading to the fact that if chronic patients who may have chronic metabolic acidosis, either from kidney functions or from CKD or issues with their bladder, having a normal pH and not being acidotic can definitely help preserve kidney function in children with CKD and slow the decline and progression of chronic kidney disease. So with all those things in tow that we know have evidence behind them to help preserve kidney function in children with chronic kidney disease, how do we create a successful transition into adulthood? And I think the most important thing that we do up front is recognition of the barriers. And so wonderful colleague out in North Carolina at UNC Chapel Hill, Dr. Ferris, has been working on this for nearly her entire career, the last 20 or 30 years, and putting together ways that we can better assess transitions of care, better assess barriers of care, and recognition of how we can improve the care for patients with chronic medical conditions, specifically those with chronic kidney disease and kidney transplantation and dialysis. So initially, the barriers can fall into sort of 4 categories: patient barriers, caregiver barriers, provider barriers, and system barriers. So looking at patient barriers, patients have psychological and risk behaviors that can become problematic, whether it's anxiety and depression from having a chronic medical issue, from having difficulty with adherence, that can be a big issue. Health literacy, so understanding your underlying medical condition, I think, is essential. What we try to do and spend the time with our patients, especially those who have more complex needs, the kidney transplant dialysis populations, is just talking to patients directly, and whether they're 10, 11, 12, or 8 or 9, and trying to have them understand why we're doing the things that we're doing and why they're doing the things that they're doing as part of their medical care. And then the last one, which I think is really important, is the underlying disease process can cause cognitive impairment in these patients. Every patient's a little bit different, but recognizing that patients may not understand things at the same level that their parents do, or the same level that their siblings may, because patients with chronic kidney disease have issues have neurocognitive defects at baseline. Additionally, caregivers, so understanding the psychological issues of caregivers, whether it's anxiety and depression for them, and the unwillingness to let go of management. Parents have been taking care of their kids in most of these congenital anomalies since they were born. And they've been doing an excellent job, and the kids are doing great. And why would we change what's working? Well, the answer is, unfortunately, the parents aren't going to be around forever, and kids need to also, grow up, graduate, go to college, have a job, do a lot of these great things that we've seen in these lectures, these talks the last couple of days that we want them to do. And so, understanding that at some point you're going to have to let go of the management, and working through that is important to help with the transition. Provider barriers. So one is having a transition plan in place. You can't have a successful transition without a plan. And at the same time, having a transition plan in place can help reduce systemic biases that we see in our medical system. Because we all have favorite patients as providers, and we don't want to let them go. And unfortunately, I think that we do a disservice to many patients because we don't let some patients go, even if they're the most ready, but we maybe are attached to them because we've been taking care of them for 18, 20 years. Low trust of adult providers. Many pediatric providers don't interact with adult providers. I'm fortunate from my being as part of one of the transplant nephrologists here at Colorado, that I get to work with Dr. Adams, Dr. Wax, and our urology colleagues who take care of adult and pediatric patients. And so we have helped bridge some of those gaps, but a lot of pediatric providers do have some low trust in the care that adult providers may provide. And then again, unwilling to let go of management. We provide, very intensive care for our patients for many years, and we also don't want to let go because we like seeing our patients do well, succeed, and do all the great things that we know they are capable of doing. But at some point, we also have to recognize that as being a barrier. And lastly, is systemic barriers to the medical system. Insurance coverage is a huge one, mostly in the United States, unfortunately. But insurance coverage just to get a primary care doctor or find another adult care from anywhere is really important. And lastly, there are systemic issues in our medical system that affect underrepresented race or ethnic groups. So I think acknowledging those barriers is essential. So a great resource for transitions that I think help set up a framework to think about how to help create a transition program is the Got Transition website. So it's gottransition.com. It's certified by the APP, and it gives 6 main domains to look for into creating a framework to help with transitions. So first is the standard framework, and trying to help develop it to be specific to patient and disease centric to your transition program. And then you want to continue that framework to promote healthy habits and therapies for this preservation of kidney function as children age. So understanding that they're tracking and monitoring their urine and why they're doing it. Understanding that they're looking at we're getting labs regularly and why, and what labs are we looking for. Understanding we care about their growth and what medicines they're on, and how are we following those things up. And you can see that they recommend starting between the ages of 12 to 14. So as Dr. Adams mentioned, we start our transition plan, our kidney transplant program at the age of 14. But even here, you can see going down to age 12 is something that they would recommend. Again, starting early, I think, is essential for helping transition patients with complex medical needs, specifically complex kidney, kids with complex kidney disease. And then again, a study that was done a couple of years ago was very interesting, and they found that children with CKD actually prefer to hear medical information first from their parents and then from their healthcare providers. So, I talk a lot about, and with my patients, of trying to make sure they understand their disease, but they're often hearing the disease from me, but they're going back home and asking their parents, wait, so what's wrong with me? What's going on? Why am I on these things? And they're actually getting the education from their parents. So I think it's essential when you're seeing patients and you're talking about working on transitions to understand you have to explain things at 2 different levels. There's a patient level and the parent level, and both those levels matter because patients themselves are getting the information from their parents and then coming back to you with questions for your healthcare provider. Lastly, they're also getting stuff from the internet, I'm sure, as we know, and that's sort of an evolving thing as technology advances. And then lastly is recognizing in your transition program the unique challenges in patients with CKD. So the comorbidities I've alluded to previously of CKD can also make transitions of care pretty difficult. So understanding your patient population and their specific needs can really help tailor these tools to promote successful transitions. And I think the important thing with children with chronic kidney disease is to understand the fact that a lot of them have cognitive impairment, poor executive function, some learning and mood issues that go along with their underlying disease process. And understanding that, it's going to take more time, it's going to take more intensive effort, and going to take a multidisciplinary team to help overcome those barriers in order to have successful transitions. And then one thing that that's in our literature in pediatric kidney disease for transitions is finding specific providers who have experience working with patients like this. So whether it's a social worker or a therapist who has taken care of other patients with solid organ transplants and understands their unique needs, understanding patients who are on dialysis, or understanding patients just with chronic disease in general. So identifying providers that have an interest or an understanding of those needs is essential really to have a successful transition. So what can we do? How can we actually, we have all these things and we have these tools at our disposal. So what can we try to do? So what I try to do here is sort of set up how we as nephrologists like to think about these sort of 6 steps and what questions are we asking when trying to set up a successful transition for our patients. So number 1 is develop a local transition policy. And so with that local policy, the important is that you introduce that policy early to your patients. You may not transition your patients until they're 21, 22, 23, but it's important to introduce that policies early around ages 12 to 14 to get everybody ready to know this is coming and here's why we're doing the things we're doing to get you ready. And then supporting the patient's medical home. I think that's something that's probably one of the most difficult things to do, because the patient's medical home consists of multiple providers in multiple different domains. We take care of very complex children, and they also have pediatricians who take care of them as well and do their regular general health needs. And so does the patient even have a PCP? If they don't have it, because oftentimes the subspecialist will function essentially as a medical home, but it's essential that patients have a PCP, one, so the parents know they can trust another provider with their complex child. And two, we're not always available to see patients at a drop of a hat when they may have an acute issue that needs to be seen quickly by a physician. And also make sure that all providers are accountable. Patients in the medical home have multiple providers and subspecialists, and making sure that we're all on the same page and accountable for the care and promoting the same things, that we want a successful transition for you when it's time and it's ready. And here's the steps we're taking to help get you there. Next is empowering the patients and their families to manage their disease process. Again, it's hard to let go because we all know what to do, but it's important that we teach and educate our families. And so regularly explaining disease processes to patients and their families during these clinic visits. And again, that reiterates the importance, I think, of follow-up care over time, especially for kids who we know have complex medical needs, especially complex GU anatomy and chronic kidney disease, so that they understand what's going on and what we're doing and why we're doing it. Early identification of barriers for families and patients to care, and then trying to address them. And again, that also involves seeing the patient regularly in clinic, making sure you check labs regularly, monitoring their blood pressures, and then having dedicated transition clinics. So it's been shown in the literature in pediatric nephrology, and transplant, having these dedicated clinics and providers to help promote transitions helps allow for successful transitions of care to the adult world. Again, then create partnerships between pediatric and adult providers. And so I think one of the big things that we do in nephrology is working to speak the same language. Our patients as children are on the same medications that they're going to be on as adults. Our patients also know as adults that chronic kidney disease can be progressive and what the things we're looking for to help slow the progression of disease. We also, in our dialysis world, we may use different dialyzers and machines, but we talk in the same language with our lab results and with our goals of care, because our metrics and our what we know is successful for helping keep patients healthy and happy is very similar between the pediatric and adult world. And the things that we have that are different, we've identified adult providers and we educate them from the pediatric side about things that they should look for that are unique to our patient population. And lastly is using tools to assess readiness. I think that's another big thing that we've done and seen in our field, is finding tools and questionnaires that we can fill out to make sure that we think patients are truly ready to transition, and making sure we find those barriers and address them. And then following up after successful transfer. So once you transition, it's not, the process isn't quite done yet. It's really important to go back and see, is what we did it work? Are the patients successfully transferred? Do they have any outstanding needs that we missed? And what can we learn from what we did to help the next set of patients? And again, this all comes around utilizing a multidisciplinary care team. Nurses, social workers, pharmacists, dietitians, and physicians all can partner together to help improve the success of a transition for a patient from the pediatric to adult side. And so I mentioned some tools to assess transition readiness. I want to highlight one. And so it's the University of North Carolina STAR program. And so they say it's a tools to develop and improve self-management skills and disease knowledge among adolescents and young adults with chronic health conditions. And so they use evidence-based forms to track transition readiness, and they're all available freely online. And so they have a 10-domain, 32-question questionnaire that goes through similar things that Dr. Adams mentioned for our transplant program. But this can be used for any patients with chronic medical conditions and complex medical needs to get ready to transition to work on transitioning to the adult world. And you can do these transition scales over time, maybe even annually, starting at a young age, and have different cutoffs. You can monitor and look at progress, and again, helps you address those barriers and understand the risks that are going to come in the way of helping for or allowing for a successful transition. So in summary, there are several modifiable risk factors to promote preservation of kidney function for children with chronic kidney disease and complex GU anatomy. So one is treating the underlying cause of the CKD, avoiding additional kidney injuries, and then slowing CKD progression. So recognition of abnormalities in labs, blood pressure, and proteinuria during regular clinic follow-ups, I think is essential. A successful transition from pediatric to adult care requires a solid policy and structured planning. Again, it's easy to have, especially with let systemic biases creep into our medical care, but having policies and structured planning around these things helps level the playing field a little bit, and also gives you a better chance of success at having a good transition of care from the pediatric to the adult world. Then empower your patients and families, especially to understand that disease process and management at an earlier age. I truly think it can be a little too early when they're a few toddlers and in grade school, but really early on empowering your children or your patients and the families to understand what's going on and why you're doing the things you're doing and why we're looking for what we're looking for to help them live a happy and healthy life. Also ensuring the patients have primary care providers and partner with adult providers to create that successful transition program. I can't stress the importance of having a primary care provider. Again, it's easy as a subspecialist to be the medical home for these complex patients that we take so much care of, but having a good primary provider and ensuring that patients go see them is undoubtedly, I think, essential to having a successful transition to the adult world from pediatrics. And last, assess readiness with evidence-based tools, and also follow up to ensure the transition was successful, and then use that as a quality improvement initiative if you're having issues afterward. So thank you very much, and I really appreciate the invite to come talk with you guys.
Thank you very much, Dr. Benz. This was fantastic, and I love that we are finishing the lectures of this meeting with a program that has a successful transition of care. I think we're all following your footsteps. And as I mentioned on Dr. Adams' talk, that for us, it's not, I love all the tools and everything, but we also have to ensure that we have a place to transition. And I think that's where most of our specialties are having trouble with. It's a work in progress, but your lecture gave a lot of insights and more ideas. So thank you very much, and congratulations on such a successful program. And we love to partner, and we feel good that when we call, we have nephrologists on board for our patients.
My pleasure. Thank you for the invite.
So now we're going to finish the meeting with the case discussion. So we're going to bring again Dr. Gaisior and Dr. Anthony Noah. I hope they are both there. Do you see them, Dan?
Yeah, they're both there.
I'm here. Hello.
Perfect. And Dr. Gaisior, for those that were not on the meeting yesterday, she is rare because she is trained in pediatric colorectal and adult colorectal surgery, making this transition perfect and easy. So yesterday she was the second to present. Today she will be the first to present. Welcome, Dr. Gaisior.
Thank you. Thank you again for having me. Hopefully I'm able to have a little less technical issues. Are you able to see my screen okay?
Yes, perfect.
Okay, very good. I'm going to go ahead and get started. This is a case discussion of one of our transitional care patients. So this is a 22-year-old male. He had a past medical history of Hirschsprung's disease. He had an uncle with Hirschsprung's disease. Pertinent history was the suction rectal biopsy at 3 days of life that was supposedly normal. And then at 3 months, a colostomy with colonic mapping was performed. And he was at that point diagnosed with total colonic Hirschsprung's. In 1998, he underwent a laparoscopic appendectomy along with an ileostomy. The following year, had a lap total colectomy with Duhamel pull-through. He had this complicated by an anal stricture requiring balloon dilations. He had several procedures thereafter, had a perforation from a balloon dilation requiring repair of a rectal perforation, followed by ischiorectal abscess in 2001. A month later, he had a flex sig with ceton placement and a fistula tract, and then he had that ceton in place and replaced several times afterwards. He represented at 16 years old, this is now about 2015, with frequent incontinence. His rectal exam demonstrated thickened, scarred anal canal with weak sphincter function. He had a contrast enema that showed a focal stricture with a blind-ending Y-type posterior fistula coming from a distal aperistaltic segment. And again, here's that stricture. The first thing that was tried for this patient was dietary modifications. That didn't help. He then had another flex sig that showed a rectal stricture 9 centimeters from the anal verge, measuring 1/2, that was found to be very inflexible. He had a posterior rectal sinus and again underwent a balloon dilation of this rectal stricture. Postoperatively, his plan was for rectal enemas, Imodium, and fiber. He did not have much improvement with that. Again, he had a contrast enema as shown here with the radiographic green arrows showing a short segment stricture with maximum diameter of approximately 1 centimeter and measuring over the length of about 22 millimeters, a blind Y-type posterior fistula rising from the distal aperistaltic neorectum. In 2016, he had an XLAP lysis of adhesion, excision of the Duhamel pouch, redo of an ilioanal pull-through with a covering ileostomy and a duodenal derotation. He was found to have a dilated left ureter. He had left ureterolysis. At that time, it was found that he had 20 to 30% loss of the dentate line prior to the redo. There were dense adhesions posteriorly between the neorectum and sacrum in the area of previous presacral abscess from the previous leak. He was eventually discharged on pectin and Imodium. Postoperatively, he was found to have healed well at the EUA exam under anesthesia with no signs of stricture at the bottom. However, in his follow-up thereafter, he was very happy with his ileostomy and he did not want it reversed. He declined ileostomy reversal from 2016 to 2018. He occasionally had some drainage from the rectum, occasionally wore a liner. He had a telephone follow-up in 2019, was found to be doing well, happy. He again declined reversal, happy with his ileostomy. He again had a follow-up in 2020 in February. He was again happy with his ileostomy. He did say there was some mucus discharge per the rectum, occasional pink streak, but no blood, no rectal pain. He had slight perineal irritation, but the anus appeared to be patent on exam. He did complain of lower back pain at that visit. He was seen by his primary care doctor, and it was given Motrin for muscular pain, which had helped. Of note, the patient is a farmer with over 2,000 pigs, that he does a lot of heavy lifting, so it wasn't thought to be that abnormal that he might have lower back pain. He had a renal ultrasound that was obtained, however, for this back pain with that history of left ureterolysis and was found to have stable upper pole hydronephrosis. About a month later, the patient called his office, his primary care doctor, saying that he was noticing surgical staples spitting from his 2016 posterior sagittal surgical scar. There was redness and pus at the site. However, his back pain was improved. He was treated locally with antibiotics by his primary care doctor. In July of 2020, he was seen by a local surgeon for a pilonidal infection. The sacral pain that he had been experiencing was worsening, so they got a CT scan done locally. His local CT scan showed a presacral mass that was 9 by 6 centimeters, eroding majority of sacral body, extending into the epidural space of the sacrum that was contiguous with the rectum. The PO contrast did not appear to enter the mass. He subsequently had an MRI that was performed showing this mass. It was thought to be osteomyelitis with large, expansive, destructive mass involving the presacral space with invasion and destruction of the majority of the sacrum. There was marked inflammation with the ischiorectal fossa and involvement of the neorectum, including dehiscence of the posterior wall. There's some micro abscesses throughout the paraspinal soft tissues, posterior soft tissues with involvement of the gluteus and paraspinal musculature with a lot of cellulitis. Invasion of the mass into the central spinal canal with extensive epidural inflammatory changes, filling the spinal canal neural foramen. At this point, neurosurgery, infectious disease, and surgical oncology were consulted. He underwent an exam that showed a sacral wound with purulent drainage. His ilioanal anastomosis appeared to be intact and smooth without mass internally, and he had no inguinal lymphadenopathy. An IR biopsy was done showing bone and soft tissue inflammation, chronic inflammation consistent with osteomyelitis with reactive squamous epithelium and keratin debris. AFP was 3.1, and ID recommended a long course treatment for the osteo. He had a plan for surgical resection with neurosurgery after a trial of antibiotics to reduce the inflammatory burden. However, he is readmitted with fevers. Oncology was again consulted with the differential diagnosis of SCT, Ewing sarcoma, rhabdomyosarcoma. The suspicion, however, was low for malignancy. He underwent a repeat biopsy that demonstrated granulation tissue, abscess, and fibrosis. He was then discharged again on antibiotics, hoping to reduce some of that inflammatory burden. However, he represented again with fevers, and here's his CT scan with rectal contrast. He then, at this visit, underwent a combined case with neurosurgery, urology, and colorectal surgery. He had a cystoscopy with placement of stents. He had an X-flap, lysis of adhesions, dissection of that neorectum from an abdominal approach, as well as irrigation and debridement of the presacral abscess. He had intraoperative fluoroscopy as well. There was takedown of the loop ileostomy, completion enterectomy, and small bowel distal to loop ileostomy. And then transition to an endoileostomy with abdominal perineal resection and placement of wound vac in the perineum and the pelvis. So we had that APR resection with the neorectum and the anus. Posteriorly, the pelvis was entered. The resection was complete. There was found to be a large cavity. The pelvic muscles were very scarred and unable to come together. There was additional presacral infected necrotic tissue sent for culture and pathology. There was a right subcutaneous tract posterior to the sacroiliac joint encountered with pus that was drained. They irrigated the tract for fluid and bone and pus from the sacral canal. There's a complex pelvic and sacral defect. They used fluoro with intraoperative images as well with neurosurgery. And in doing this, the sacral abscess was thought to be adequately identified and demineralized where the sacral bones were. They were able to pass the finger into the sacral canal via the pelvis and thought to have irrigated all of the abscess and suction it out. The pathology for this case revealed invasive squamous cell carcinoma with moderate features with keratinizing, moderately differentiated with keratinizing features. The carcinoma involved the entire external surface of the anus and the neorectum, and it was P16 negative. The distal anal and proximal small bowel margins were negative. However, the circumferential radial margin was not able to be assessed. And in the presacral fascia, there also were fragments of squamous cell carcinoma. And this is an image of the wound. The patient was then taken back to get additional frozen margins and were found to be positive in the anterior posterior sacrum. The anterior sacrum, posterior sacrum was negative, and the left deep paragluteal margin was positive. At this point, musculoskeletal oncology was involved. The patient was discussed at GI tumor board with plan for radical excision of sacrectomy for R0 resection with curative intent. The discussion was not to proceed with any kind of neoadjuvant therapy as the patient had ongoing infection and an open wound, and so it was thought to proceed with surgery, again with an oncologic curative intent. So the patient went then to the operating room with musculoskeletal oncology, with urology, colorectal, and plastic surgery. However, intraoperative findings showed multiple frozen sections of biopsies around the bladder and iliac vessels that were positive squamous cell carcinoma. It was decided that in order to achieve an actual R0 resection, it would require removal of the bladder, the bilateral ureters, as well as amputation of at least the right, if not the left leg, given the extensive involvement of the retroperitoneum. This was discussed with family intraoperatively, and palliative care and comfort measures were then pursued. I bring this case up to discuss because I think as pediatric surgeons, There can oftentimes be complications with these operations, but certainly this patient's long-standing history of having inflammation in that presacral space certainly came to cause chronic inflammation and eventually squamous cell carcinoma. And unfortunately, it wasn't recognized early enough to be able to have an R0 resection.
Wow, Dr. Gacier, now we're gonna leave us depressed because this is a very sad case. And I have to say, usually I counsel my patients that the chance of cancer for them is similar to the normal population. And I'm trying to pull my mind. I don't remember or I don't recall any of our patients with Hirschsprung or total colonic ganglionosis and cancer. So I think this was an extremely sad case. And I don't have experience in oncology to comment, but since this case brings so many things, I'm going to comment a few things that I think the audience could take advantage. One, the patient underwent a Duhamel procedure, right? Usually the advantage of the Duhamel is the preservation of the anal canal. Somehow this patient had this strange fistula posteriorly, which is certainly the initial surgery that was not done by your group did not go well, I would say. And then in patients with total colonic ganglionosis, so when we remove the entire colon, when those patients have fecal incontinence, we usually don't recommend enemas because enemas are just for the colon, not for the small bowel. I understand in this case, probably a small enema was tried just in the rectal stump to try to improve. And what I think it's the reality for this case is that the patient suffered for such a long time that when he had the ileostomy, he enjoyed the benefit of the ileostomy. And that's something we as colorectal centers are extremely proud of our results with bowel management, but I always try to keep my mind open that enostomy is not necessarily bad. Many patients actually like it. And I think this patient demonstrated. And the other point that I want to make it is when you do a posterior sagittal incision in a patient with Hirschsprung, when they have an intact anal canal, you end up with a circular anastomosis. So you end up with a T anastomosis from the posterior sagittal and the circular anastomosis, technically in a competent sphincter. So it almost acts as a distal obstruction. So those patients are very high risk for fistula formation. Of course, the fistula of this patient was before that, and I don't know when this carcinoma developed, but what a difficult case and what a sad case. Anybody else has any comments or questions about this case? Let me see here.
And I think it speaks to, complications can occur with any case. However, this case kept being managed by the local surgeon and perhaps seeking earlier care at a higher level, tertiary or quaternary referral center could perhaps have changed this outcome. But I also think it is very difficult for a pediatric center to treat some of these adult cancers. And at the time the patient presented to us, we, of course, have the fortunate relationship with the adult cancer center, and we were very much able to get them plugged in and move very quickly. However, unfortunately, we weren't able to achieve the result we would have liked.
Yes. Well, thank you very much. This is a very sad case, but I think it highlights the difficulties of that some of our patients have finding good care in the adult side. Thank you very much. Dr. Wood, do you want to introduce?
For sure, yeah, no, I'm delighted to welcome Dr. Anthony Noah. He and I worked together in London just before I left, and he now is in charge of the practice over there. It's a pleasure to see you, Anthony. I think that from what I've heard, we're not going to be discussing a dissimilar theme with this case, but also I think it kind of highlights some of the things that Dr. Higuchi was talking about when he spoke earlier. So I'm really grateful for this, Anthony. Thank you very much for taking the time to join us.
No problem whatsoever, Dan. Thank you very much for asking me, and thank you everyone for your time. As Dan has said, not straying too far from the theme. Are you able to see my screen?
Yes, perfect.
Excellent. All right. So my name's Anthony Noah. I'm a urologist in London. As Dr. Wood said, I worked with him. I was his fellow. Then I took over the practice when he moved over stateside. So this lady is actually a patient that's actually quite close to my heart. To be honest, I've gotten to know her quite well over the last 2 years or so, and she's very friendly, and I like her a lot. So I'm talking about a rare consequence of urinary tract reconstruction. So she's a 37-year-old female. She was born with spina bifida, but she is ambulant. She had a cystoplasty and Mitrofanoff channel for her neuropathic bladder. She's also got a VP shunt in situ since birth from her hydrocephalus. Of note, she is morbidly obese. She presented maybe 2.5 years ago with difficulty catheterizing the Mitrofanoff channel. She underwent an endoscopic examination of the channel, which showed that the channel was completely obliterated. She then had a cystouretheroscopy to have a look at the bladder, and there was no access from within the bladder either. So she had a urethral catheter inserted and was taught to self-catheterize urethral afterwards. For the next 2 months, she had some intermittent exudates coming from the channel, and then she represented with discharge from the channel. She was admitted, and sorry, I'm struggling with my slides. And the question is how to proceed, whether to treat with antibiotics, review, ultrasound, CT, or just arrange to remove the obliterated Mitrofanoff channel. Initially went for antibiotics with an inpatient ultrasound scan. So she had an ultrasound scan of her abdominal wall, which essentially showed no drainable collection. However, there was a 7.5 centimeter hyperechogenic area, or some material was how it was described within the Mitrofanoff tract. And this thing clearly looked infected at the time. So we arranged for a CT scan. This was the ultrasound scan in the first place. So this sort of, almost triangular wedge of material. So we got a CT scan. Ultrasound scan was done by a very, very good interventional and uroradiologist. So the CT scan confirmed 7.5 by 6 centimeter soft tissue mass at the site of the obliterated Mitrofanoff channel. And that is it. So if you can see, I don't know if you can see my mouse, but obviously you can see the slice of the CT through the pelvis, and outside of the abdominal wall muscles and within the subcutaneous fat, there's this mass, and you can just about see the entry of the Mitrofanoff channel into that. So she was discussed at the multidisciplinary team meeting. This confirmed a solid mass on review, and she had initially we'd hoped to try and get an MRI scan. However, there were some issues regarding knowledge of what type of VP shunt she had, and we struggled to get the information from her pediatric center that transitioned her to us. As it was all taking a long time, we went ahead with the ultrasound-guided biopsy. And unfortunately, the results showed a primary adenocarcinoma of the appendix, which was now the Mitrofanoff. She went to the colorectal MDT, and the decision was made for an excision of the Mitrofanoff channel, which wouldn't be a small undertaking, and we were time limited. She had a CT colonoscopy arranged, which showed no other abnormalities. She then underwent a laparotomy an en bloc excision of the tumor and the Mitrofanoff channel, and the formation of a new Monty-Mitrofanoff channel with an abdominoplasty. That was a joint case between urology, colorectal, and plastics. So looking at it, so this was pre-op. On the day of surgery, this is what it looked like. So it's, it looked a bit angry and red again. And it's looking at that entire area, it's sort of measured around 7 or 8 centimeters. This was after we'd made our initial incisions to separate the tumor mass en bloc and take a wedge of the abdominal wall with it. Intraoperatively, we found that there was a loop of the small bowel which was entering the mass and adherent to it, so that had to be resected as well, and she had to have an ileal anastomosis. This is the specimen after it's been removed. So her histology came back as an adenocarcinoma of the appendix. Her follow-up CT showed some bladder wall thickening, but no evidence of tumor recurrence. There had been a question of whether there'd been a positive margin on the histology at the bladder end. And the review of the histology had suggested that the tumor went right up to the resection. Therefore, she had another interval CT, which showed ongoing bladder wall thickening. And then we scoped her bladder via the new Mitrofanoff and took biopsies of the thickened area. That came back as a benign changed non-keratinizing squamous metaplasia. She had another repeat CT and the bladder wall thickening had resolved. Great. But unfortunately, she had a lung nodule, which then went on to have a PET CT scan, and it was added. Currently, we're waiting for her to have a lung biopsy. And the reason I bring this case forward is actually malignancy in, first of all, it's an interesting case. A primary tumor of the appendix in the first place is rare. Reconstructed bladders, an increased risk of developing tumors in it. We do think that this risk is, beyond 20 years, and we generally don't advocate regular endoscopic checks in the UK. I'm not sure what happens over stateside. But these patients do need to have regular imaging in the form of an ultrasound scan, blood test. They do need to be kept on someone's book, someone who knows what they're looking for. And if there are any questions, I'm happy to take them.
Yeah, thank you so much, Anthony. As you know, we did this case together, and I've never seen a primary tumor of the Mitrofanoff before. It's my first and only one. And I asked around and I didn't come across anybody that had come across something similar. I've seen endometriosis in a Mitrofanoff before in a young lady, but never a primary tumor. But I think it illustrates that, we're dealing with a group of patients that have rare problems that we have done complex work with, and they do need follow-up and a group of people around them who can think of and look for slightly unusual presentations. At UCH in London, we're gifted with extraordinary uroradiology team that will help us with all kinds of imaging and support in answering questions about these sort of situations. And the combination case with the colorectal team was essential in terms of making sure that she got the appropriate oncological clearance. It's disappointing to hear that she may have a lung nodule that's significant, but I'm not sure what else would have been achievable in her case. Thank you, Dr.
Yeah, I agree.
For this presentation. Again, I have never seen a case of cancer in an appendix conduit, but I think those two cases highlights the importance of, if there is a problem, we should think outside the box and we should consult specialist because it will not be our primary diagnosis. So thank you both for bringing those two cases, just to alert everybody in this meeting about the importance of consulting with the appropriate team so we can provide good care for these patients. So thank you all for joining. I think this was a fantastic meeting. I just took some notes of what I had the impression that it was frequently mentioned during this meeting. So transition of care, we need to do better. It is still a challenge. Multidisciplinary clinics seems to be working very well in the pediatric arena. In the adult world, it's a little more challenging too. We need centers of excellence the same way that we have in the pediatric, we need in the adult world to receive our patients. The example was the Penile Reconstruction lecture today. And I think regarding medical records, we should all be aware that this is a challenge for our patients and we have to empower them to have their own medical records, to always ask for a copy for their medical records and not assume that the hospital will still have it. Again, I don't know what's going to happen with electronic medical records, but paper records, they do disappear after a certain period of time. I am fortunate to receive many of Dr. Hardy Hendren's patients, and he used to draw the anatomy of all patients before and after reconstruction and hand it to the patient. And when we see a patient of Dr. Hendren and we receive that, that saves us hours of trying to understand the anatomy of the patient. So I think we should all take this challenge and do better for our patients. So I'm going to let Dr. Wood do the closing remarks, but thanks all that joined and all that presented today. It was a wonderful meeting.
Yeah, thank you so much, Andrea. It's been a real pleasure to organize this with you and a really exciting project to develop alongside the Hendren project. So thank you very much for all their support and their endeavor, and the hospital team here in terms of putting together all of the information. There are a lot of people behind the scenes that make this sort of meeting happen, and I'm very grateful to all of the work that they have done. I've certainly learned a lot over this last couple of days. It's been fascinating to hear the breadth of perspective and the different approaches. And I think that I've kind of walked away with, or I will walk away with new inspiration around this kind of work. I'm extremely grateful to all the people that took the time over the 2 days to join us and listen to this meeting. And if you see the evaluation come through to you, please take the time to repeat that. And to complete that. I anticipate that this is a meeting that we will want to run again, and your feedback will be enormously valuable in helping us to improve it and shape it going forward. So
and a big thank you to Ray. Ray's the man behind the curtain, doing all the work. We could not survive without them, and to the Hendren Project for hosting this event.
So it remains for me to say that for those of you who it's now Friday evening, thank you very much for giving up your Friday evening to join us. For those of you that have a bit more of the day to come, enjoy that and have a wonderful weekend. Thank you very much to everyone.